basic of the arthroscopy, that is the knee anatomy of the knee, and all the basics will be covered in this session. So I would like to invite Dr. ID, Dr. Ankit, Dr. Mohit, Dr. Tanveer to chair the session. And the first talk will be Anatomy of the Knee Joint by Dr. Manpreet Singh. He is Assistant Professor in Department of Orthopedic SGRD, Amritsar.
Good morning, everyone. My topic for today is the anatomy of knee joint, orthopedics point of view, the basic anatomy. The anatomy of knee joint can be divided into 4 subheadings: medial knee anatomy, central or the pivot knee anatomy, lateral knee anatomy, and the meniscal anatomy. First, we'll start from the medial aspect of the knee. The capsuloligamentous complex is divided into the 3 distinct layers, which is the superficial, medial, and the deep. Main in the superficial is the sartorius, and in the middle is the superficial medial collateral ligament, posterior oblique ligament, and the MPFL. In the deep layer, the main structures are the deep MCL and the knee joint capsule. So coming on the bony landmarks in the medial knee anatomy, there are 3 main bony landmarks. The first is the medial epicondyle. It is most anterior and distal bony prominence, as you can see in the diagram. Second is the adductor tubercle, which is also known as the lighthouse of the medial side of the knee. The third is the gastrocnemius tubercle, which is 6 mm proximal and 13.7 mm posterior to the medial epicondyle. Coming on the soft tissue structures, the most important structures is the MCL, which is divided into superficial MCL, which is a band-like structures and the largest structure of the medial aspect. On the femoral side, it is a single attachment, which is 3.2 mm proximal and 4.8 mm posterior to the medial epicondyle. For the tibial side, there are 2 different attachments. On the proximal side attaches directly to the soft tissue on the anterior arm of the semimembranous, which is 11.2 mm distal to the joint line, femoral joint line, and the tibial joint line, sorry. And the distal insertion site is 6.1 centimeter distal to the joint line. Because of these 2 separate insertion sites, they have 2 separate functions. The superficial MCL is the primary valgus restraint across all divisions of knee flexion, and whereas the distal division also acts as a primary restraint against the tibial external rotation. Coming on to the deep MCL, it is the thickening of the anterior aspect of the medial joint capsule, and it is most distinct along its anterior border and has 2 distinct components. First is the meniscofemoral component, which is longer and thinner, and it provides valgus stabilization at all degree of knee flexion. Second is the meniscotibial component, which is shorter, and it also provides valgus stabilization at 60 degree of knee flexion. Deep MCL also provides stabilization against the external rotation between 30 and 90 degree of knee flexion. The third most important point is the posterior oblique ligament. It has 3 facial attachments, which all originate from the distal aspect of the semimembranosus, which you can see in the diagram. It has 3 facial attachments, which are the superficial arm, central arm or the tibial arm, which is the largest, and third is the capsular arm. It primarily functions as internal rotation and valgus stabilizer of the knee joint between 0 to 30 degree of knee flexion. Next one is the pes anserinus, sartorius, gracilis, and the semiti. They are the goose foot insertion on the anteromedial aspect of the medial tibia. The sartorius inserts most proximally, whereas the semiti inserts most distally, and it is the longest, semiti. They are the most common autografts for reconstructions, and semiti and gracilis are both covered by thin fibrotic cap formed by the sartorius. Next is the adductor magnus tendon, which lies in the osseous depression, 3 mm posterior and proximal to adductor tubercle. Another ligament in the medial aspect is the MPFL, medial patellofemoral ligament. It attaches on the medial epicondyle of the femur to the superior medial aspect of the medial border of patella. It primarily provides passive restraint against the lateral translation of the patella. Next is the medial gastrocnemius tendon. Now we are coming on to the middle knee anatomy, which is also in pivot knee anatomy. It has two cruciates, anterior cruciate and posterior cruciate. Anterior cruciate basic anatomy, it is composed of multiple collagen fascicles wrapped in a sheath that connects the femur and tibia through a fibrocartilaginous bone tendon interface. It is intracapsular but extrasynovial. Its origin is on the medial surface of the intercondylar notch of the lateral femoral condyle, whereas insertion is on the medial to the intertubercular ridge. It is around about 4 centimeter in length. Now coming on the functional anatomy of ACL, it is primary restraint to anterior tibial translation, also acts as a secondary stabilizer to valgus and varus stress in full extension. There are two functional bundles which are classified according to the tibial insertion site. First is the anteromedial and second is the posterolateral bundle. Anteromedial bundle tightens it in flexion, whereas the posterolateral bundle is tight in extension and lax in flexion. Now, during knee flexion, during knee extension, both the anteromedial and the posterolateral bundles are parallel to each other, whereas in knee flexion, the posterolateral bundle moves anteriorly and the two bundles cross, like it is shown in the diagram in the third part. Now, footprint anatomy of the ACL. There are several bony landmarks and soft tissue landmarks on both the femur as well as the tibia. First, I will discuss the femoral bony landmarks. The two most common are the lateral intercondylar ridge, which is also known as the resident ridge, and second is the bifurcate ridge. The lateral intercondylar, like you can see in diagram, the lateral intercondylar ridge, it represents the most anterior femoral attachment for both the anteromedial as well as the posterolateral bundle. The ACL attachment is roughly 6 mm posterior to the lateral intercondylar ridge. Means it is the most anterior point, lateral intercondylar ridge. Second is the bifurcate ridge. It serves as a divider distinguishing the femoral footprints of the anteromedial as well as the posterolateral bundles. Coming on the tibial bony landmarks, there are three main landmarks: ACL ridge, retroeminence ridge, and the lateral and medial tibial eminence. The ACL footprint is 10.5 mm posterior to the ACL ridge, whereas 13 mm anterior to the retroeminence ridge. There is no ACL insertion is located posterior to the lateral tibial eminence. Now coming on the soft tissue landmarks, there are 2 to 3 important landmarks. The most important is posterior cruciate ligament. The ACL insertion is roughly 7 mm anterior to the PCL insertion. The anterior horn of the lateral meniscus, which is also known as LARA, the ACL insertion is 7.5 mm medial to this, and it is 9 mm posterior to the anterior intermeniscal ligament. Vascular anatomy, it is mainly supplied by the middle geniculate artery. Coming on to the posterior cruciate ligament, it is the largest intra-articular ligament of the knee. Its origin is from the anterolateral aspect of the medial femoral condyle, and it inserts into a depression which is known as the PCL facet, which is inferior to the posterior joint line. Functional anatomy, there are two bundles, anterolateral as well as posteromedial. Anterolateral is taut in flexion, whereas posteromedial is taut in extension, and posteromedial is vertical in extension. Now, coming on to footprint anatomy, femoral attachment, there are 2 to 3 arthroscopic landmarks. First is the trochlear point, second is medial arc point, third is posterior point. The center of anterolateral bundle is 7.4 mm from the trochlear point, and posteromedial bundle is 11.1 mm from the medial arc point. Tibial attachment, the two bundles of PCL insert together below the articular surface in the PCL facet, and the bundle ridge represents it separates the footprint of the anterolateral bundle from the posteromedial bundle. There are 2 points in shiny white fiber point. The shiny white fibers of the posterior horn of the medial meniscus are anteromedial to the anterolateral bundle, whereas there is a point known as champagne glass drop-off, which is the prominent ridge at the most posterior aspect of the tibial plateau, and it marks the distal border of the posterior medial bundle. Coming on, there are two meniscofemoral ligaments which are closely associated with the PCL. First is the anterior meniscofemoral ligament, which is known as ligament of Humphrey, and the posterior meniscofemoral ligament, which is known as ligament of Risberg. They cross the PCL anteriorly and posteriorly respectively. The vascular anatomy mainly from the middle geniculate artery. Coming on to the menisci, they are specialized fibrocartilaginous structure which serve a variety of functions like load transmission, shock absorption, and joint lubrication. They are triangular wedge-like cross-sections and attached to tibia by the meniscotibial ligament and anteriorly by the anterior transverse menisco-meniscal ligament. The most important point in the meniscus is the vascularity. They are supplied by the inferior geniculate artery, medial and lateral side, and the middle geniculate arteries. They form the perimeniscal capillary plexus that supply the outer 20 to 30% of the periphery of the medial meniscus and lateral. So according to these, the meniscus vascular zones are divided into the red-red zone, red-white zone, and the white-white zone. The periphery is the red zone, which has a good supply, good blood supply, and the medial two-third, like white-red and the white-white zone, are relatively avascular. Coming on to individual meniscus, medial meniscus is C-shaped with a wider posterior horn, and it measures approximately 45 mm in length and 27 mm in width. It can be divided into the 5 zones, with zone 4 being the most common for the meniscal tear. Lateral meniscus is larger and is semicircular in shape and attached to femur by the meniscofemoral ligament. It is also divided into 6 anteroposterior zones. Finally, the lateral knee anatomy, the bony landmarks are 3. There are 3 bony landmarks. It is the lateral epicondyle, Gerdy's tubercle, which is 1.7 centimeter distal to the tibial plateau, and the fibular head. There are 3 layers, superficial, medial, and deep, like analogous to the medial side. The superficial layer, ITB in iliotibial band, and the middle is the lateral patellofemoral ligament. In the deep, the main is the fibular collateral ligament and the popliteus tendon. Coming on to the lateral collateral or the fibular collateral ligament, it is a cord-like structure which is attached 1.4 mm proximal and 3 mm posterior to the lateral epicondyle. It is primary stabilizer to various forces on the knee from 0 to 30 degree of flexion. Coming on to popliteus tendon, it rests at the anterior fifth of the popliteal sulcus. From there it goes posteriorly and inferiorly and attached to the meniscus by 3 fascicles. The superior and inferior is further divided into anterior and posterior. There is an important point that posterior popliteus tendon attachment is separated from the FCL attachment by 18.5 mm, which is a key anatomical relationship during the PLC reconstruction. And primary role is restraining against the external rotation of the tibia. Popliteofibular ligament, it anchors the muscular tendinous junction of the popliteus to the fibular head, and there are 3 types. The type 1 is a single band which inserts directly on the fibular head. Type 2, it is a bifurcated ligament which has an anterior and the posterior arm. The third is the double popliteofibular ligament, which comes one from the popliteus muscle and one from the muscular tendon junction and inserts at the fibular head separately. It plays a critical role in resisting the external tibial rotation, maintaining joint stability in weight-bearing activities. Iliotibial band, it originates from the external lip of the iliac crest, whereas inserts at the Gerdy's tubercle. It has 2 deep bundles known as capillin fibers. It also has a capsulo-osseous layer, which is directly attached to the lateral head of gastrocnemius and posterior to Gerdy's tubercle. Biceps femoris, there are 2 heads, long head and short head. The long head is inserted via the direct and anterior arms, whereas the short head is inserted via 3 arms, direct, anterior, and capsular. Lateral gastrocnemius tendon, it emerges from the lateralmost aspect of the muscle belly and attaches to fibula if present and continues to attach to femur. Important landmark for isolated posterolateral corner injuries and reconstruction. Anterolateral ligament is Perley resistant band and originate from the lateral femoral condyle. Its role in Sigon fracture, like ACL tear, people say that anterolateral ligament tear is also present. Lastly, there are 2 proximal tibiofibular ligaments, anterior and posterior, where anterior attaches 15 mm posterolateral to Gerdy's tubercle, whereas the posterior attaches 15 mm anterior to the lateral tibial plateau. Thank you.
Thank you, Dr. Manpreet, for your elaborative talk. So we'll take the questions in the end. I would like to invite next speaker on the dais, Dr. Hakam, who will be speaking on biomechanics of knee. So till the time we are setting up the laptop, are there any questions? So if there are any questions, you can just get up and ask the questions. So anatomy as such is very important because this will dictate our terms in whenever we are deciding on the treatment or reconstructing the ligaments. So without wasting much time, I'll request all the speakers to please stick to their time because we are already late and we would like to finish it on time so that we can all go and enjoy our happy Sundays. So over to you, Dr. Hakam.
Thank you. So I will be speaking on biomechanics of the knee today. So most of you are already bored. So I promise I will not bore you further. So first of all, we will see the anatomy, the ligaments and the soft tissue, and the clinical application, what actually happens inside the knee. So first we will see the osseous and the articular anatomy because it is the foundation of knee biomechanics. First, as you know that the distal femur geometry is very unique. It has a trochlear groove, it has a posterior condylar offset, and there is condylar asymmetry, which drives that femoral rollback, and there is the patellar tracking. Then there is the tibial plateau morphology, which is very unique. The medial tibial plateau is concave, lateral is convex, and it provides the inherent stability on the medial side, and it also makes the lateral condyle roll back further, and there is pivoting of the knee. Because the medial tibial condyle is concave, it will lead to pivoting of the lateral femoral condyle. And then there is posterior slope, which is 5 to 7 degree, which also helps in the femoral rollback. Then third is the subchondral bone. As you know that the subchondral bone, it distributes the stress inside the cartilage. So it is very important because in early osteoarthritis, there will be increased stress concentration inside the cartilage, which will further lead to damage. Then there are the ligament footprints. We need to know the footprints because during ligament reconstruction or ligament repair, we need to maintain the isometry so that the ligament tension is near to normal. Then coming on to the tibiofemoral kinematics, as you all know, the knee joint has 6 degrees of freedom. Flexion extension, internal external rotation, varus valgus, AP translation, medial lateral shift, and the axial compression. So this is very important. Tibiofemoral kinematics, the roll, glide, and the screw home mechanism. As you all know that in the last 20 degree of extension, there is screw home, means our tibia externally rotates around 10 degrees. And there is maximum ligament tension in this phase, and the knee is inherently stable. And then when we flex the knee from 20 to 120 degree further, there is combined roll and glide. The medial femoral condyle acts as a pivot. It moves only around 2 to 5 mm posteriorly, but the lateral femoral condyle moves around 15 to 20 mm, which is known as the femoral rollback, and PCL ligament guides this rollback. And on further flexion, like 120 to 150 degrees, what happens is the femoral condyles almost overhang the tibial condyle. There is posterior meniscal protrusion, there are increased stress concentration posterior-medially, and there are increased chances of OA and posterior horn tear. Then we will come on to petrofemoral kinematics. As you know that the inferior, in 0 degree of knee flexion, the patella is not in contact with the trochlea. In 20 degree knee flexion, the inferior pole contacts the trochlea, and in 90 degree knee flexion, the superior pole contacts the trochlea. So we can adjust our post-operative range of motion considering this fact. Then there is the Q angle. Increased Q angle will lead to increased chances of subluxation or dislocation of the patella. Then there is trochlear geometry. When there is trochlear dysplasia, it can further lead to patellar dislocation or subluxation. Then kinetics and joint loading. As you know that whenever we move, there is peak joint loading. That is, in normal walk, our joint traction force in the tibiofemoral joint is around 2.5 times our body weight in normal walking. When climbing stairs, it is around 3.5 times our body weight, and jogging 4.5 and running 8.0. That's why we, during the post-operative rehabilitation, we delay climbing, jogging, and running. Then ACL biomechanics, as you know, there are two bundles of ACL, anteromedial and posterolateral. The anteromedial bundle is mostly, it prevents the anterior translation, and the posterolateral bundle is for the rotational control. And in ACL deficiency, there will be anterior subluxation or translation of the tibia, which will increase the posteromedial joint stresses, and it can lead to accelerated OA and posterior horn tear. Then we will see the PCL and the collateral ligament. PCL has anterolateral and posteromedial bundle, and in PCL, as you know that the PCL drives the femoral rollback. If there is PCL deficiency, there will be increased tibiofemoral and in addition petrofemoral stresses too. So the OA can further progress. Then it has the implication in the cruciate retaining total knee replacement, because that the PCL drives the rollback, and if the PCL is too tight or too loose, there can be paradoxical anterior femoral rollback, which is most commonly seen in cruciate retaining TKA. Coming on to the collateral ligaments, the MCL ligament has deep and superficial component. The deep component mainly resists the rotation, and the superficial component mainly resists the valgus force. The lateral collateral ligament and the posterolateral structures, they mainly resist the external rotation. In normal walking, they are not taught, but they are taught during high demand activities, and it provides also the external stability. Then meniscal biomechanics, as you know that the 50 to 80% load is transmitted through the menisci and mainly through the hoop stress mechanism. Whenever we load, the axial stresses are converted into these hoop stresses, and which are controlled by the anterior and posterior horn of the menisci. And even if one horn is torn, it means that there is total, it is equal to total meniscectomy. So we have to prevent, we have to repair if there is any anterior or posterior horn tear. Then articular cartilage mechanics. The articular cartilage has three components. First is the superficial tangential zone, second is the medial transitional zone, third is the deep radial zone. The superficial tangential mainly distributes the shear forces. The middle transition zone, it distributes the forces, and the deep radial zone, it dominates the stress. So whenever we walk, the 90% of the stress is borne by the fluid. It is distributed thoroughly due to the fluid. But if there is further, like we keep on loading it, there will be transmission to the matrix, and it can lead to OA. Then in gait cycle, the first phase is the most important, which is the early stance phase, which is the loading response. Whenever we bear the weight, there is 15 to 20 degree of knee flexion. So here there is the peak knee adduction moment. Most of the weight is borne through the medial component of the knee. The 70 to 80% of weight is borne through the medial component. And there are increased stresses on the ACL ligament. So that's the reason we tight or tension the ligament in 50, we tension the ACL ligament in 15 to 20 degrees of knee flexion. And the PCL load peaks in the mid stance phase. In terminal stance phase, there is second axial peak loading. So then again, I have talked about it earlier. Then meniscal repair versus resection. As we know that even if there is 10% decrease in the surface area of the meniscus, the stress will increase around 40 to 70%. So we will try to preserve the meniscus as much as possible. So surgical take-homes are preserve meniscal horn as much as possible, then restore ACL specific restraint, balance MCL length in total knee replacement, and tailor PCL tension in cruciate retaining total knee replacement. Thank you.
Thank you, Dr. Hakam. So thank you for making us more wise in terms of biomechanics. So I would like to invite next presenters, Dr. Ias Chauhan and Dr. Varun, who will be giving us more knowledge on the knee physical examination. So it's very important that we should not miss anything on examination, because these again guide us onto the treatment in a particular patient. So Dr. Avinash will be talking on physical examination of the knee. So in the meantime, if we have any questions, you can ask. Okay.
Good morning, everybody. Good morning, everybody. I welcome all the faculty on behalf of JOS, my dear colleague, friends, and younger colleagues. On this occasion, I am given topic which is very basic, but 30% of your clinical practice depends on that. That is where you impress your patients, how better you examine the patient. So again, obviously patient comes with the pain, swelling, and stiffness. Where patient remains confused, that you have to look for is mechanical disorders. That is quite primary. Limp and deformity, again, you can distinguish and clearly find out. Next, examination involves your position, palpation, motion, that is look, feel, and move. In that, again, I'll say inspection. During inspection, you should expose both the knees. That is one of the most important things. Then we go, when the patient walks into your clinic, you can see when he sits, you can see it again. What we obviously many times forget is the prone on-table examination. Then the alignment. Here again comes the genu valgum, varus, and recurvatum, quite obviously seen. Flexion deformities are to be keenly looked into. Shortening and Baker's cyst, again we can find. Antalgic gait is again we should be keenly looking for. Then this picture is very important for further coming speakers. They'll explain about it better. Then again we see the masses. Masses appears in the bursa, bony, and tumor. In tumors, we should have a clear-cut demarcation and knowledge about epiphyseal, diaphyseal, and metaphyseal tumors, because early detection of these tumors will help the patient in a long run. Scars and signs, of course, of trauma and lesions are obviously seen. Then swelling, redness. Here again we have to emphasize on the vastus medialis atrophy. Rest of the things we always see and observe. Then comes the temperature changes, which we have to look keenly. Tenderness is there, and joint line tenderness has to be palpated properly. Effusions, peterofemoral, synovial thickening, that we have to obviously look again. Quadriceps and hamstring powers has to be assessed. Then again the effusion. Fullness of patellar, everything is seen. Bulge sign is important. Patellar tap, and then ballotment. Many times we forget to do the ballotment, which should be done in a proper way. Patellar instability, here we have to measure the Q angle. All of us are very aware of it. Dynamic and active patellar tracking are the two things we have to look for. J sign is lateral subluxation of patella in full extension. We have to note that it is in full extension. Apprehension test, definitely 20 to 30 degree of flexion it is done. Movements, in movements, flexion and extension, we all obviously look for rotation. That is important. It is possible only in flexion. It is nil in extension. FFDs are seen, crepitus is observed, hip rotations are to be looked for, and observe any extension of the knee from the flex position. You can repeat these movements and test them properly. Test for meniscal injury, joint line tendon is one of the things the first and obvious sign we look for. McMurray's test, we all know how to palpate, how to do it, but negative McMurray doesn't rule out any tear. Appley's grinding test done in 90 degrees in prone position. These are two things we have to look for. Extended pain and popping tear is obviously seen in this. Anterior drawer, we all know. Here we usually have to clearly be about ki hip has to be 45 degrees. And stabilization of foot is important. Again, it is not possible to do it in the acute and painful conditions. Latchman test, it is one of the most sensitive tests for ACL. Sensitivity and specificity are in two different tests. Sensitivity is seen in Latchman test and it is useful. Again, I am emphasizing we can do it in a painful knee. Pivot shift test, it is done at the hip 30 degree extension, abduction, and it is most specific. Now it is specific, not sensitive, for ACL tears. Sag sign, obviously 90 degrees, you have to support the heel. Here you have to look for Joffrey's test, sag sign at the 90 degree flexion of the hip. If you do that, you might find the difference and you'll be able to distinguish properly. Posterior drawer test, 90 degree flexion, it is done for the PCL tear. Any sign of PCL tear if there is no hard end felt. Quadriceps active test, done in 90 degrees, active quadriceps contraction to the shift of tibia without extension, and anterior shift of tibia and PCL tear is obviously observed. MCL valgus test on the side of the table, knee in 30 degree flexion, external rotation has to be looked for. LCL tear, again 30 degree flexion on side of the table. LCL tear, when you find in the figure of 4 position, LCL is torn, it is not palpable. Posterior lateral corner injuries, we look for external rotation recurvatum. Dial test. Dial test we should be looking for, and reverse pivot shift test we can also perform to confirm our diagnosis. Thank you so much for your kind listening. Thank you.
Thank you, Dr. Avinash, for your detailed presentation on knee examination. Next, we would like to invite Dr. G.S. Bhola for his talk on radiology of the knee. So till the time presentation is being set up, if there is any questions to Dr. Avinash from
Good
the
morning, everybody.
house.
Nice to see all the orthopedics in their well-dressed suits and dresses, not in their scrubs. Today, orthopedicians are sitting at a crossroad of anatomy, biomechanics, pathology, and radiology. So the topic which has been given to me is knee, what to see. For orthopedicians, it is just one thing they want to see, is that their patient is fine. But for radiologists, they will ask all the questions which they don't know the answers. So knee anatomy and biomechanics have been already discussed. It's a modified hinge joint which allows flexion, extension, rotations. And we take a look on it through different modalities. The technology that is X-rays, age-old, but never to die off, CT, MRI, and new incoming facility that is the ultrasound in radiology. And things you all know, tibia, fibula, patella, nothing which I can say. But the checklist for radiologist always is to see ABCS, alignment, bone, cartilage, and soft tissues. So when an X-ray comes to you, the first thing you see is knee bones are intact, that is finished, but that does not end it all. Look for the symmetry, the smooth articular surface margins, and most important, the soft tissues. Like the suprapatellar fat pad, which is normal, is lost over here and distended, effusion is there. Hoffa's fat pad, it is lost over here. Then subtle fractures, depressed or thin, faint lines showing the bone fractures. the alignments. You will just, patient will walk in and you will see varus valgus, but you'll ask us the questions, what is the angulation? So we have these full leg, whole spine, full leg x-rays in weight bearing orthoradiograms from hip, knee, ankle to check out their angulations. Any obvious malignant looking mass or periosteal reaction. And of all the angulations, which we can see is the HK angle or different all types of angles. Then skyline view, AP lateral, all said and done. Skyline view is which orthopedicians I think have forgotten. Very rarely we get indications to get a skyline view done. But it can show very well the patellofemoral component, how the angulation changes, how the degeneration progresses. Then just by change of angulation, the things change. 30-degree flexion, you see so well joint space, but if we do the X-ray wrong, you will misinterpret it as the joint space is lost. So that is also important, that how we do it. We can measure sulcus angles, flattening of the angle. We can measure patellar tilt angles. Then TTTG distance will be requiring very special facilities like special softwares, but we can give you those things. And Salvati ratios or Descamp index for patella alta or baja, you can very well see on the X-rays. In young patients especially, very commonly missed finding, very less diagnosed but more often seen than diagnosed, is trochlear dysplasia. Few special signs on simple X-rays, double contour, suprapatellar spur or crossover sign. Then coming to MRI, the anatomy, that is the meniscal anatomy and all. It's going. The meniscal tears, you know better than me, the horizontal tear, cleavage tear, vertical tear, radial tear, and the direction. And you would like to see what is called a horizontal tear going all along the posterior horn, or a double PCL sign with meniscus lying displaced in the intercondylar notch. A well-taught ACL versus a torn ACL. On coronal, a good ACL versus a torn ACL. On axial, ACL, PCL versus torn PCL. The posterior avulsion fracture of PCL. Collateral ligament tears. Popliteal tendon, lateral collateral thickening or sprain. The popliteal tendon degeneration at its attachment. Articular cartilage, a normal good articular cartilage versus deep fissuring with open cortex grade 3 or a good large defect in the cartilage. And now the more recent outcome, that is the ultrasound. Initially it was being used only to see whether there is fluid or not, nothing more than that, but now all the superficial parts like collateral ligaments, menisci can be seen. A good meniscus is a echogenic triangular thing, and a tear can be seen very well as a hypoechoic or lucent thing inside. And similarly, we can even go for cartilage, a good cartilage versus shriveled cartilage, or a lost cartilage with sclerotic bones on ultrasound. So take home message in this very short time to describe radiology. X-ray remains fundamental. Anatomy, you all know, determines the biomechanics and leads to the pathology. Morphometry predicts instability. And for internal derangement, always MRI will be the best. Thank you.
Thank you, Dr. Bola, for the elaborative talk. We always remain indebted to radiologists for giving us the correct diagnosis, and it definitely helps us in making a diagnosis to reach a particular diagnosis and then treat the patient. Nevertheless, being an orthopedician, we should know how to get those X-rays done. At times, we need a particular view, so we need to train our technicians how to do the particular. So in knee particularly, we need a monopedal stance view X-rays or a monopedal stance view scanograms. So it is very important that we go and tell them how to do this, how to train the technicians. And radiologists are always here to help us. So thank you, Dr. Bola, again for being with us. So so we are moving on to the more interesting things which give us more kicks. So we are going into the OT now. So Dr. Tanveer Dumra will be talking on basics and positioning during a knee scopy. So over to Dr. Tanveer.
Good morning, everyone. So let's start with the scopy in particular. Now we know we're moving to knee arthroscopy, which is a minimally invasive video-assisted surgical intervention for the intra-articular diseases of the knee. It is a highly accurate procedure combined with low morbidity, and that is how it becomes an important tool for diagnosis and treatment. So coming to the armamentarium, what is the first is the visualization system. So we have an arthroscope. Normally the arthroscopes which are used in practice is 30 degree and a 70 degree. So what is 30 degree and 70 degree? It is basically the angle of inclination which it makes the angle beam mixed with the lens. So the standard one is a 30 degree, which is primarily used for diagnosis and operative. It's a 4 mm scope, and the 70 degree scope is used more for the posterior compartment for the PCL work and for the difficult corners. So the optical characteristics in a scope are basically the diameter, the angle of inclination, and the field of view. So 30 degree would give a field of vision like this. So that would be increased, and in the 70 degree you will have a better view, but definitely you will have a blind spot. So that is a difference. So the components of a scope are a telescope, which would be a rod lens system or a graded index system, of fiber optic light cable, a camera head, a camera control unit, and a high resolution monitor. So when you start your scopy, these are the basic instruments that you would need: a scalpel, trocar, cannula system, switching sticks, cannulated sleeves. That was what is kept initially. This is our finger. This is basically an extension of an arthroscopic finger, that is the probe. So that would help in palpating the intra-articular structures and planning the approach to the surgical procedure. The importance is of the tip, because this tip would help us in gauging the size of the lesion. So the various meniscal instruments that are available, I think this will be more highlighted during the procedures and in the workshops. So this is the basket, forceps, the scissors, the graspers, the various types, various angles. The other important part is the fluid management system. So most of us, I think, we use the gravity inflow system. That is a basic setup where we would use around the NS mostly. There is a 3 to 5 liters of bags. And important is the height of the bag. That is, for every 1 feet height, it would get a pressure of around 22 mm. So the average height of the bag would be placed at around 4 to 5 feet. The second system that we do use is a arthroscopy pump, which is a pressure control system of 30 to 60 millimeters of mercury. And definitely there is something attached to the outflow. There is an outflow cannula and a suction. So the fluid management system helps in joint distension. It helps in visualization of the joint and achieving a hemostasis. But importance is, do not have an excess pressure, because that would lead to a problem with the fluid extravasation and compartment syndrome. The resection and the debridement instruments would be a motorized shaver system, which would have oscillating rotating blades and a suction. These are suction integrated systems used for synovectomy, meniscectomy, and the debridement of the joint. And there are various type of blades which could be single use or reusable with 2.5 to 5.5 mm sizes, and more aggressively you would even use for burrs for doing any chondral work or maybe for any bony work. Energy devices are RF, radio frequency ablator, which would help in soft tissue shrinkage and for achieving hemostasis, and underwater cautery. But important to note is, if you would, it can also cause thermal damage to the cartilage if it is misused. So there can be specialized instruments for chondral work like curettes, microfracture awls. For loose body removal, graspers are used. And the sterilization of all these instruments is mostly by ETO. So coming to the operation theatre setup, this is an essential, this is just a model, just to show that the surgeon is on the opposite side of this is the surgeon, this is the patient, there is the myostand, and this is the arthroscopic tower. On the other side is assistant, a scrub nurse, and the scrub trolley. Sorry, I think the image is not there. Though the two positions that are used in arthroscopy is the leg holder, the free leg position. That is more useful for when you want to see the most of the posterior medial compartment or manipulation of posterior horn and meniscal surgery. I think the most commonly used by most of the arthroscopy surgeons is the position with the lateral thigh support and the foot support. Use of a tuning is essential. Use of epinephrine, there are some surgeons would use epinephrine at portal sites. The concentration would be around 1 milligram per liter. Hypotensive anesthesia, definitely it is by the pressure pump. And there is always a provision for documentation of the procedure. So coming to the principles of arthroscopy, the main principle of arthroscopy is triangulation. So it is like the scope, instrument, and target. So as you can see in this picture, so the idea is to always visualize before the movement of the instrument, maintain a low pressure when possible, avoid blind resection, and respect the posterior neurovascular structures. Common errors would be poor portal placement would lead to a limited access, loss of orientation would lead to cartilage damage, high pump pressure would lead to swelling, and inadequate probing would lead to missed pathology. So this is an important slide, how in what position we would like to do the scopy. When you flex the knee, it would open the intercondylar notch. On an extension, it would be prudent to view the patellofemoral compartment. On a valgus stress, that would open a medial compartment. If you give a varus stress, it would open the lateral compartment. In a figure of 4, that would maximize your lateral joint space. And in hyperflexion, that is important for ACL femoral tunnel access. So the various pathologies, the positions are different. I think I should not be discussing much on this because there are lectures. So in a medial meniscus state, just to tell you, it would be 20 to 30 degree of flexion with the valgus stress and external rotation of tibia. And if you find that compartment is tight, you can even do a pike resting for the MCL release. For a lateral meniscus tear, it would be a figure of 4 position, a knee flexion in 90 degrees and a varus stress. For ACL injury, I think there's a full lecture how to make the position. I think it's a step-based positioning. For a diagnostic, arthroscopy is 90 degrees, 110 to 130 for femoral tunnel drilling, and 80 to 90 for a tibial tunnel alignment. For a PCL injury, again, knee flexion 90 degree with the posterior tibial support, bump under the tibia to prevent the posterior sag. And important is that you would use a 70 degree scope. In a patellofemoral disorders, you would start in full extension and move to 30 degrees of flexion. And for chondral lesions, the common mistakes that you would make is inadequate valgus would lead to medial cartilage damage, no hyperflexion, improper ACL tunnel, poor positioning, instrument crowding, and ignoring dynamic movement would lead to missed lesions. So what are the important considerations in all these different positions? The popliteal artery risk injuries more in the posterior knee procedures, so I'll always maintain a good visualization. On the lateral side, avoid aggressive varus force, and you need to protect the cartilage, so do not force the instruments in the tight compartments. Thank you.
Thank you, Dr. Sanveer. Why don't you come and join us? Yeah. So positions are very important. We should know which area we need to target and position the patient accordingly. So the next talk will be by Dr. Devinder Lal, who will be talking on portals and knee arthroscopy. So it's very important to make a correct portal because it will make our life easy. Otherwise, we'll be struggling during the surgery. So over to Dr. Devinder Lal. In the meantime, the things are setting up. We can have a couple of questions from the audience. So are there any questions? So is there Dr. Hakam? Dr. Hakam, how much force is there when we are in a post-ACL reconstructed patient? If we are trying to do an Lachman's, how much force are we putting onto the knee? So in a post-operated ACL reconstructed patient, if we are trying to do a Lachman's test, so what amount of force does we are giving to the knee? So that is very important because generally we try to examine patient very aggressively, which can also injure the graft. So how do you think on that? So supposedly I come to you, I have my ACL which has been reconstructed by you. So I come to you on, say, 4 weeks after the surgery. So how aggressively will you do the Lachman's test? So because that's the force which we are giving onto the graft. Or you will be gentle.
Aggressively, but
so if it is your operated patient, if it is operated by someone else?
Yes, you can say 20 to 30 Newton they say, but how to measure that Newton I don't know.
Yes, so basically we need to be very gentle when we are examining any of the post-operative patients.
Whether it is your patient or someone else's patient. So anyhow, thank you for that. So Dr.
I welcome all the faculty, those who have come away from the Jalandhar, from the other part of the country, especially from the Amritsar and the other from Delhi. So many people have come. So my talk is basically on the arthroscopic portal. So this is the basic arthroscopic portal I am discussing here. So there are so many portal has been described about the arthroscopy of the knee, that is anterolateral, anteromedial, posterolateral, posteromedial, and there is one central Gilchrist portal. But the main portal is anterolateral portal. Whenever somebody starts, those who are beginners, those who want to start the arthroscopy, for them the main portal is anterolateral portal. Anterolateral portal is the main. If you'll see, go according to the book, they have described, whenever you want to do some arthroscopy, first you mark the joint line, patellar tendon, patella, everything. And then exactly 1 centimeter above the joint line and 1 centimeter lateral to the patellar tendon. But if you keep on doing, now they are doing high anterolateral portal, which is just at the tip of the patella and just lateral to the patellar tendon. This is how you mark everything. But nowadays they are doing this is just at the tip of the patella, and this is high anterolateral is exactly where you can reach up to the see all the segments. The main, it's not you will do the put the anterolateral portal, anteromedial. You first put the anterolateral portal and do the diagnostic. Then you start with the other portals. If you are going little low, then you will be stuck in the patellar fat bed. You won't be able to see. Either you do the normal anterolateral or slightly high anterolateral portal. Main is the anterolateral portal. You can infiltrate that with the xylocaine and adrenaline, and so that bleeding will be not there. But normally we all do arthroscopy under tunicate, and some people even exsanguinate the knee so that bleeding will be less. The describe is you give transfer incision on the skin and the vertical incision in the capsules. But once you will start doing, if you will give transfer incision very near to the patellar tendon, the chances that you will tear the patellar tendon. If you want to do the bone patellar tendon bone, then there will be a difficulty. So whenever you are going exactly just lateral to the patellar tendon, then don't keep your knife toward the patellar tendon. It should be away from that area. And this is the diagram showing if you are going little higher, then you can see up to here also. But if you are too high, then you won't be able to. You will see just anterior part. If you are going that, if your portal is little low, then you will be stuck in the patellar fat pad. Same thing for the high anterolateral portal and anterolateral portal are both. But once you will start doing the arthroscopies, you will do 10-15 cases, then you will be able to find the exact place where you want to do the anterolateral portal. Once your anterolateral portal is all right, it means your half of the job is done. Then the anteromedial portal, that described anteromedial portal is just medial to the patellar tendon and 1 centimeter above the joint line. But once you are expert in doing, we always do the medial portal under vision. We put the needle from the space and see under arthroscopy. This is how we do in this. We first see the medial portal and put the needle and see where your needle is going. Then you give the incision. Your needle should not be angulated. It should be going straight. Then you can reach up to the meniscus, the posterior horn, and the other areas. Then you give the incision and do the anteromedial portal. Accessory portal for the anteromedial and anterolateral accessory portal, because now we are putting exactly at the anatomical area. Whenever you are doing ACL, if your portal is very near to the patellar tendon, then you won't be able to do the femoral tunneling perfect. So you do little more medial from the normal anteromedial portal. The posteromedial portal is only necessary when you are doing some ramp lesion or some the PCL injury. For the PCL, the posteromedial portal is more important. Then you feel for the condyle, the small triangular spot formed by the posteromedial edge of the tibia and femur. And you feel for the spot and then go to that. The diagram is showing if you are going too posterior, then you can go more posterior part and do the damage to the posterior structure. If you are going anterior, then you will get stuck up in the femoral area. So it is good to do the exactly on the posteromedial part. But once you have done around 20-30 arthroscopy, then you will be able to do a posteromedial in this portal. Thank you so much. This is how you do the clinically when you do posteromedial portal.
Thank you, Dr. Davinder, for diving us into arthroscopy and portals of knee arthroscopy. It was a wonderful talk. Now I would like to call Dr. Manav Gupta
to
discuss more about diagnostic arthroscopy and around the knee.
Good morning, everyone. I am Dr. Manav. I am working as a consultant at Vivekanand Medical Institute, Palampur. I would really like to thank Dr. Varun Joshi and the whole organizers for this invitation and wonderful hospitality here at Jalandhar. So I'll be talking about the diagnostic arthroscopy of the knee. So we already discussed the aims, why we want to do the arthroscopy. Now I'll be just running the video now. So first of all, by the standard anterolateral portal, we put the scope into the suprapatellar pouch, and then we start for looking for the suprapatellar area. Here you can see the patellofemoral joint, and then we go and look at the gutters to look for any loose body. Here I'm looking at the medial gutter. There is no loose body as such. Then I'm going to examine the patellofemoral joint and the suprapatellar area. Here you can see a plica, which is not much clinical relevant, but sometimes this is very thick and causes issues and pain. Now I have moved to the lateral gutter. Mild synovitis is seen, and but mostly it is okay. There's no loose body as such. Now I am looking at the lateral patellar facet, and we always probe the patellar facet with the probe so that we look for any condyle injuries as such. So once we have confirmed that there is no abnormality in the suprapatellar area, then we move to the joint proper. So in this video, after marking the standard after marking the surface marking for the portals, I always try to make the anteromedial portal under vision by knowing the exact trajectory so that I have ease. And I have put this slide just to inform that we always have to put the shaver and visualize it so that the face is towards us, so that we don't end up damaging meniscus or the ACL. Now once we have debrided taken down the Hoffa's fat pad, Now we can go for the inspection of the trochlea and the ligaments. So in this video, now I'm inspecting the trochlea, and once I'm sure there are no injuries, there is no chondral lesion, there is no fissuring, then I am going to look at the ACL. Now I am probing the ACL, and you can see there is a complete tear of the ACL, and we also probe the PCL to see for the damage. Now shifting to the medial meniscus, if the joint is very tight, as already mentioned by my colleagues, we can go for the pie crusting because we don't want to scuff the cartilage as such. And here we can see a horizontal tear in the posterior horn of the medial meniscus. And we look at the anterior horn, the body, and the posterior horn, and we also probe to look for any other injuries in the meniscus as such. And now, after having a look at the medial meniscus, now our focus is to shift to the lateral compartment in the figure of 4. So you can see here, I've lifted the undersurface of the medial meniscus in the body, and you can also see part of the deep MCL, sometimes if it is torn in multiligamentous injuries. And here we can see a medial meniscus root tear, which is avulsed from the posterior attachment of the medial meniscus. And as sir already told, there are a lot of hoop stresses, and it is virtually equivalent to a total meniscectomy. So we always can see bucket handle tears as well. So here there's a patient with the bucket handle tear of the medial meniscus, which the meniscus has flipped into the notch and causing extension lag and locking. Now with the probe we are trying to reduce it. So these are all the things we can encounter in the diagnostic arthroscopy of the knee. Now coming on, I don't know what is happening here. Okay, no. Sorry. In the figure of 4, we have to look for the tendon of popliteus as well, because sometimes it is ruptured and torn and neat, and it gives us indication that the PLC is also injured. And after the medial compartment has been dealt with, now we take the position and shift to the position of patient figure of 4. Now we can see a radial tear in the posterior horn of the lateral meniscus, and we also have to inspect the body and the anterior horn as well. So I operated on this patient a couple of weeks back, and this same patient had a lot of findings. He had a ACL tear, he had a medial meniscal tear, and a lateral meniscus tear as well. So we can also see some loose bodies, and posterior medial corner is one very notorious corner where we especially miss the posterior medial loose bodies. So this patient had a loose body which was hidden in the posterior medial corner. So I had to make a posterior medial portal and remove this loose body from the joint, because these can cause locking and instability. And we can also see the chondral lesions as such. So you can see the lateral femoral condyle totally clean, and look at the medial femoral condyle. It has grade 3 chondral lesions, totally gone cartilage. So do you think is the arthroscopy of the knee complete here? My answer would be no, because we haven't looked at the posterior medial corner and looked for the notoriously famous ramp lesion. So I put my scope through the notch along the medial femoral condyle and go to the posterior medial aspect of the knee and look for the meniscocapsular separation, which is very common, actually very common with the ACL tears, and it also leads to a lot of pain and disability afterwards if it is not dealt with. So here I can see there is no ramp lesion per se, but I always try to cycle the joint so that I can see any hidden instability, because a lot of time the ramp lesions are actually not seen and then only seen on cycling. So that would be it. Thank you so much for your kind invitation and your great hospitality. Thank you.
Thank you, Dr. Manav. So this ends our session 1. Now we go to session 2 of ACL. For that, I will invite our Chairperson Dr. Naresh Chodda sir, Dr. Sagar sir, Dr. Siddharth sir, and Dr. Oberoi sir. First talk first take Dr. Nishant. So I invite Dr. Nishant for his talk on available graft options, harvesting, and comparison for ACL surgery.
Good morning, everyone. I am Dr. Nishant Setia. I am working as a senior consultant in Healing Hospital, Chandigarh. So today's my topic of presentation is available grafts, harvesting and comparison for ACL surgery. So multiple autograft options are there, which includes hamstring tendons, in which there are semitendinosus and gracilis, bone patellar tendon bone, Peroneus longus tendon, and central quadriceps tendon with or without bone block. So we'll be first talking about some pearls of different grafts harvesting. So in hamstrings, we should preoperatively palpate the pes insulinus, and we should mark the semitendinosus and gracilis tendon insertions. And we should use a slightly flexed knee position, which is about 20 to 30 degree to relax hamstrings and facilitate harvesting. So our incision centers on a 3 to 4 centimeter oblique incision just medial to the tibial tubercle, which helps access the tendons easily, and it centers on midline of tibial tuberosity and medial border of tibia. So special take care to avoid is we should protect the saphenous nerve, especially the infrapatellar branch, to prevent numbness, and we should avoid aggressive stripping to prevent tendon rupture within the sheath, and we should be mindful of medial gastrocnemius fascia attachments which can tether the tendon. So next step is tendon identification and harvesting. We should use a right angle clamp to isolate the semitendinosus first, followed by the gracilis, and we should keep tendon under gentle tension while passing the stripper to prevent premature cutting. And if there is any resistance is felt, we should be cautious of any facial bends which are remaining, and we should remove them, and we should move our stripper slowly, and we should rotate it slightly while advancing to avoid excessive force and avoid premature cutting of tendon. So after harvesting, we should check tendon length and diameter. It should be in 28 centimeter minimum to get a quadrupled graft, and we should remove muscle fibers thoroughly for better graft handling. This is a video showing hamstring graft harvest. So these are the steps. We should palpate thick band, which are hamstring tendons. Semity is normally palpable easily, so we can feel it with a finger. And we should elevate the sartorius sheath and see the tendons underneath. So those tendons we can hold with a right angle artery or clamp, and then we can pass ethibond through this. And after releasing, we can check the excursion of the tendons, and then after loading with a stripper, we should advance slowly and rotate to get a good graft. So advantages of hamstring tendons are there is no anterior knee pain in post-op period or in long follow-ups, and there is a long-term follow-up available in studies, and it works well with all inside technique of ACL reconstruction. The limitations are some patient report as hamstring weakness. And so I think I should skip all these and we should compare only. So comparing of strength of grafts, native ACL is 2160 Newton, hamstring is 4100, Peroneus is 42, and bone tendon patellar bone is 2977, and CQT is 2352. So follow-up studies, hamstrings have long follow-up, BPTB has longest follow-up, and Peroneus quadriceps have short follow-ups. So ideal graft should have a similar strength as original ACL. It should be for rapid return to recovery. It should have a fast and good incorporation. It should have a minimal donor site morbidity. It allows for secure fixation, and it should have a low re-rupture rate. So talking about which is a ideal graft. So no graft is ideal. One graft doesn't fit all. In general population, our first choice for primary surgery should be hamstrings, and ensure it should be 8 to 8.5. If hamstring is small, like in smaller females, small heighted females or fatty female, we should switch to Peroneus longus, which is 7.5 to 8 mm diameter. And in revision ACL, if hamstring is used earlier, we can switch to quadriceps or Peroneus longus. And if the patient is having frequent kneeling, then we should avoid BPTB and use hamstring, quadriceps or Peroneus. And in patients with hyperlaxity and pivot sports, we should prefer BPTB or quadriceps tendon. So when to avoid each graft, like hamstring when there is predicted small size, high demand athlete with borderline size, and in BPTB we should avoid when there is kneeling occupation and patellofemoral pain. And in quadriceps, when surgeon is not comfortable and he is not having the instruments for graft harvest and he is not well versed with the technique of quadriceps harvesting. In Peroneus longus, we should avoid when there is pre-existing ankle instability and high demand athletes relying on ankle eversion. So my practical OT strategy is I plan for hamstring. If it is more than 8.5, I proceed. And if it is 7.5 to 8 mm, I augment. And if it is less than 7.5, I switch to PL. And in patients who are athlete and high pivot demand, I switch to quadriceps tendon and BPTB. Thank you for your attention.
Thank you, Dr. Nishan.
Thank you, sir.
Next, we would like to invite Dr. Mohit Singla for graft preparation. In the interim, Dr. Nishan, what do you use for augment?
For augmenting, we use fiber tape.
Thank you.
Thank
Good morning, everyone. Big thanks to the organizing team for this wonderful academic meet. So I'll be talking on graft preparation and calculation. As Dr. Nishant has already explained about the various graft options, so I'll skip this slide. So coming on to the basic steps of the graft preparation. The first one is we have to clean the muscle tissue and adhesion bands. For the accurate sizing, and as the residual muscle can falsely increase the graft diameter, for better graft incorporation as it allows more direct tendon to bone healing, and to reduce the inflammatory load as it increases the synovitis and effusion after the necrosis. So this is a short video of removing the muscle tissue. You can do this with the help of a metallic scale or by with the help of a back of the blade. And this is the video of removing of the adhesion bands of the hamstring tendon. So the second step is you have to measure, after cleaning, we have to measure the tendon length. As the length of 240 mm or more is sufficient to make a 80 mm graft in a triple fashion preparation, and by using the adjustable loop for the femoral side fixation. So you have to put the graft on the graft board, and there is a measurement. After this measurement, you can decide whether to go for a double graft or triple graft. The third step is graft folding and whip stitch. There are various methods of doing the for graft folding. So I'll be talking about the most common methods. The first one is the one tendon double strand. Second is 2 tendon and 4 strands. The third is 1 tendon and 4 strands. And the fourth is 1 tendon and triple strand. So I'll be talking about each of the methods one by one. So the first one is 1 tendon double strand graft. So we have to pass the graft through the suspensory loop and make the graft of the equal length and stitch the distal end of the graft. To stitch them together, and after stitching, we have to do the whip stitch to tubularize the graft for proper sizing of the graft. We can do this whip stitch by ethibond or fiber wire, whatever you like. The second method is 1 tendon 4 strand graft. So we just have to double it. The distal end is being tied upon the proximal end, and in the same way we can stitch that together with the help of ethibond or a fiber wire. Then the third one is the 2 tendon or the 4 strands. As you can see, in the case of if we are harvesting a hamstring tendon, so we can pass both the semi-T and gracilis through the suspensory loop and tie the distal end of the graft together. And the fourth one is 1 tendon and triple strand. There are various methods to do that. So I'll be talking about one method only. We have to fold it into 3 equal parts and mark it, and then pass it through the suspensory loop, and 1/3 of the graft is being folded upon itself and tied, and the distal longer loop is being stitched. Then in this fashion, both the proximal and the distal end are being tied together. So after folding and whip stitch, we have to check the diameter with the help of the sizer. So there are incremental holes are 5 mm usually. So we have to start from the smaller diameter hole and increase gradually. It should just pass with mild resistance. It shouldn't be freely moving, and there shouldn't be stiff resistance to it. We have to go for a graft of 8 or more than 8. It is ideal for lower failure risk. So this is the standard sizer with 5 mm increments. So we'll be passing through, first we are passing through the 8.5 mm. It is passing with the mild resistance. Then we have to, like we are checking through 8 mm, it is not going, passing through the 8 mm. So it is 8.5 mm graft. So fifth one is we have to mount the graft on graft board under tension, as pre-tensioning removes the initial laxity, thus reduce post-fixation graft loosening. We have to secure one end of the graft, usually femoral side, to the graft board hook or peg, and fix the distal end to the board under maintained tension. This step is crucial as it helps in true graft diameter sizing. So in this video, the proximal femoral end is already being tied, and we are tensioning on the tibial side. So last step is we have to put the vancomycin soaked gauze over it to reduce the post-operative infection risk, and we try not to keep it fully immersed in the vancomycin liquid as graft may swell up. So this is the last step, and after that we can do our interarticular work. Thank you.
Next, I would like to call upon Lieutenant Colonel Dr. Aditya Dwivedi for his talk on ideal methods of fixation.
Good morning, everyone. So, my topic is the ideal methods of ACL graft fixation. Like we have already discussed the choice of grafts. So now we'll be carrying forward it with the different methods. So the core challenges in an ACL reconstruction are the graft integration, that is the achieving the reliable bone tunnel healing, the tunnel placement, anatomical positioning to restore the rotational stability, then the fixation strength, which can withstand the early rehabilitation. So the fixation strength must withstand the forces which is ranging from 200 to 450 nanometer for a early post-operative motion. Now the classification of the fixation methods, basically you can categorize them according to the location, mechanism and material. There are three main types of fixation. One is the aperture fixation, which is directly inside the tunnel, at the tunnel opening. Second one is the suspension, that is the cortical button or the endo button that is over the bone. And then there is a transverse fixation, which is by the cross pin. By location, you can broadly classify them as aperture, suspension and hybrid. By mechanism, it is compression, suspension and expansion. And then by material, it could be metallic, bioabsorbable or composite. These are the various the implants which are used for the ACL graft fixations. All are aware of it, just for a revision thing. So now I will be starting with the different implants. First I will start with the metallic interference screw. This is the gold standard aperture fixation. Provides direct compression of the graft against the tunnel wall, maximizing the contact area and the initial stability. The advantages is it has the highest initial fixation strength. The aperture fixation reduces the bungee effect, and there is a precise torque control insertion. The biggest disadvantage of using a metallic interference screws is the graft laceration. And in cases you want to see post-operative MRI or in cases of revision, there is an artifact and it is a very difficult hardware to remove. And then there is a stress shielding at the tunnel aperture. To remove certain things, to moderate the graft laceration, we have the bioabsorbable interference screw. Basically, there are many materials. The mainly are the PLLA and PLGA. So the difference is that PLLA have a slow degradation, about 3 to 5 years, and higher initial strength. But again, it has a side effect of having a late foreign body reaction. Whereas when you talk about PLGA, it has faster degradation, that is around 1 to 2 years, and lower initial strength, but it has a better tissue response in comparison to PLLA. Then we have composite screws, which has hydroxyapatite coated, which helps in increasing the integration of the graft with the bone. So there is one major side effect for bioabsorbable screw, which we all talk about, is the breakage. But if you see the data, that is around only 2 to 5% of the cases where the screw breakage happen. And if you have a proper tunnel and screw sizing, then we can avoid this. Now the suspension fixation devices, they flip against the outer cortex of the bone, suspending the graft like a swing within the tunnel. There are two main devices which are available, that is the fixed loop and the adjustable loop. The fixed loop needs a precise loop length, but there is no risk of loop lengthening in this. And it requires the accurate tunnel length measurement. There is always a risk of tunnel mismatch. Whereas in adjustable loop, there is an intraoperative tension adjustment, and if you have an error, it is forgiving. So potential of loop slippage and it is comparatively more expensive. So there are two main side effects of this. One is the bungee cord effect or the windshield wiper effect. Both are the micro motion within the tunnel. One is the longitudinal, that is the bungee effect, and windshield wiper effect is the transverse motion. Basically both widen the tunnel. So this is the main. Then the cross fin fixation, it is one of the rigid fixation. It is always perpendicular to the tunnel axis. The fixational strength, as you can see, there is always a chance of cyclic displacement in it. And main advantages are minimal graft laceration, and they are MRI compatible, the bioabsorbable ones. And disadvantages, this is a non-aperture fixation. Again, there is a bungee effect, comparatively less to the endo button, but risk of pin breakage and specific drill system is required for this. Then if you see in a femoral fixation, what are the different methods? If you can see that load to failure is highest with the screws and lowest with the suspension, and the graft laceration, MRI compatibility and revisions are more with the screw in comparison to the suspension and cross pin. In the tibial fixation, we have additional of washer and post. And if you see, the load to failure is the highest with the metallic screw and the lowest with the staple. It means with the staple, there is highest chances of failure. The biomechanical strength, the cyclic displacement, this is the important thing, which is the highest according to the study at 3 mm, but the lowest with the metallic screw. Clinical outcomes and evidence, if you see a 2023 study which has taken the IKDC scores, there is no significant difference after 2 years, whichever fixation method you are using. The failure rates are around 5 to 8% for all the methods. Pivot shift grade are not significantly affected by the fixation choice. So the outcomes are more driven by the graft type rather than the fixation. So the conclusion, the take-home message is aperture fixation wins biomechanically with the lowest displacement and highest stiffness, but the clinical outcomes are similar after 2 to 5 years. So there is no fixation method which outperforms the another one. Context drives graft type, tunnel anatomy, patient age, revision status, and surgical technique guide the optimal fixation strategy. Final thought is the best fixation device is one where the surgeon is most experienced with, applied to the right clinical scenario with sound surgical technique, and no single device is universally superior to the other one. Thank you so much.
Thank you, Dr. Aditya, for such a nice talk. And I now invite Dr. Mohit Sharma for his to deliver his lecture.
So we'll be discussing about the femoral tunnel placements and what can go wrong with it. I'm Dr. Mohit Sharma, consultant orthopedics in CK Villa Hospital. So whenever we're going for the ACL reconstruction, the femoral tunnel is the malposition 80%, which causes the non-traumatic ACL failures. We know the two bundles in the ACL are anterior-medial and the posterior-lateral bundle. Anterior-medial provides the anterior-posterior stability, whereas the posterior-lateral bundle provides your rotational stability. We've already discussed in anatomy, and we know that we rely mainly, the key determinant is the femoral tunnel positioning. We have to rely on that, and that is on the one which will be required for your graft longevity. Anatomy is the basis of orthopedic surgery. The 4 basic principles that we should always follow is restore the functioning ACL, restore the native insertion site, and correct the tensioning pattern. We have individualized surgical individual approaches for every patient. Transtibial versus transportal, the transtibial, the chance of impingement is high. And now, if you have a non-anatomical femoral positioning that is over the top, you can have limited ROM, higher graft tension and less rotational stability, and you have more chances of graft failure. So it is always preferred that we use a transportal which is independent of a tibial approach. Anatomical at the center of the soft tissue point, for the native ACL, at the central tunnel between 2 bundles, we can always see it by bifurcating the demarcation, that is a bifurcated ridge. Footprint is so large that no graft can occupy the entire area. What is the advantage of an anatomical position? You have a better control of axial rotation. You have more normal kinematics, more better pivot control. There is reduced incidence of late chondral or meniscal damage, and there is less chance of impingement. So when we talk about the ideal femoral tunnel, we need to understand that we need to identify in the arthroscopic portal the bifurcate ridge. We need to see both the bundles, AM and PL bundle, and try to center it out and try to avoid any posterior wall blowout. So you have to be 1 to 2 millimeters away from your posterior wall so that you can avoid posterior wall breakouts and avoid short tunnel fixations. The center of the ACL femoral footprint is located at an average of 43 to 51% of proximal to distance of the lateral femoral notch, usually centered over the lateral bifurcate ridge. So there are ideal multiple positions where we usually malposition or we have incorrect positioning. You can see an isometric positioning of the femoral tunnel, which is acceptable, not very perfect, or it can be an ideal position, which I say is a low and a posterior position, which gives better rotational control and a better pivot control, or it could be an anatomic short fixation, more horizontal. There are multiple methods that we use for placing our femoral tunnels. It could be a ruler method or a clock face method. Whichever the surgeon is more comfortable with is an ideal placement for him. So when we see for a right knee, the ideal is 10 o'clock position, or for a left knee, it is a 2 o'clock position for placing a femoral tunnel. Usually what we consider is that we should have a good graft angle between the tibial tunnel and the femoral tunnel. 19 degree, it should not be a vertical graft. Usually when we are going with a transtibial portal, we land up in a vertical graft. When we are doing an independent portal positioning, we have a more horizontal or a more anatomical tunnel positioning. So when we discuss about the two most common techniques for femoral tunnel placement, it's an all inside technique or an outside in technique. More preferred is an all inside technique, tibial tunnel independent. It has minimal skin incisions. We have an ability to fine tune the tunnel starting. The only thing that we need to understand in this positioning is that you need to hyperflex your knee to more than 120 degrees. In thin patient, it is very easily achievable. For obese patient, it becomes a bit difficult. So hyperflexion of knee is required so that you can have more susceptible for the graft tunnel positioning and for graft insertion. Whereas for outside in technique, we need to have an additional incision of 2 centimeters, which can again put your tunnel in a right position. So the idea is to understand the surgeon should ensure that proper positioning is very important when we are doing an all-inside technique. The surgeon should make an accessory far-middle portal with a spinal needle so that the instrumentation and the footprint can be easily identified, and the degree of knee flexion should be more than 120 degree. For an outside-in technique, after the placement of guide pin, the tibial tunnels and femoral tunnels should be fine-tuned. You should see it. You should have an additional site and trajectory and position should be always seen. It is usually seen, we use an outside-in technique for revision cases or maybe obese patients. I would like to emphasize femoral tunnel malposition 80% is the most causative cause for non-traumatic ACL failures. Increased lateral tibial slope, decreased notch index are all other risk factors for non-traumatic ACL failures. What can go wrong? The most common technical error that we see is improper tunnel positioning of femoral. More than tibial tunnel, 80% femoral tunnel are malpositioned and 20-30% tibial tunnel are malpositioned. Femoral tunnel, if placed more vertical and anterior, it can lead to a strong association with an ACL failure. When we see the positioning, a distal femoral tunnel will land up increased anterior transition of the tibia. A 2 anterior tunnel will land up into more loss of rotatory control, and you'll have more residual pivot shift, and you'll have elongation of graft, and eventually you'll have a graft failure with multiple cyclic loading. Medial placement of femoral tunnel will land up into impingement of the graft, and again leading to more tensioning of the graft. 2 posterior will lead into a risk of blowout of the posterior wall. So it is ideal that we are placed a bit away from the posterior wall. My take-home message is, anatomic placement is everything. Aim for a native footprint. Identify your bifurcate ridge. Try for a low and posterior placement of your tunnel so that you have a stable knee, more better pivot control, and more better rotational control. Avoid your high noon position or 12 o'clock position. Try and always check before you commit your tunnels. Always see for the posterior wall blowout. Always again check and again check. And aim portal drilling, keep your knee hyperflexed more than 120 degree. If you see an obese patient, try to do an outside-in technique by using additional surgical incisions. Thank you.
Thank you, Dr. Mohit. Now I invite Dr. Ankit Kataria to give his lecture on tibial tunnel placement and what can go wrong.
Good morning to all the dignitaries on and off the dais and my dear friends. At the outset, I would like to thank the organizers for this warm invitation and their wonderful hospitality. So today I'm going to talk about the tibial tunnel preparation during a standard ACL reconstruction. So the importance of an anatomic ACL reconstruction is it restores the knee biomechanics, it prevents graft impingement, ensures rotational stability, and reduces the failure rate. So footprint is important. Anatomic femoral footprint has been talked about. We are going to talk about the tibial footprint. This is a cross section of the tibia. As one can see that this is the ACL ridge. The native footprint of the ACL is roughly 10.5 millimeters posterior to the ACL ridge. It has two bundles, the anteromedial and the posterolateral bundle. It is roughly 7.5 millimeters medial to the anterior horn of lateral meniscus. And if I talk about the retroeminence ridge, it is roughly about 14 millimeters anterior to it. So this is a beautiful pictogram copied from Robert F. Leprard's beautiful paper. It shows that the anterior horn of lateral meniscus, it blends with the insertion of the ACL. So if you tend to err on the tibial side, if you go to lateral, you may end up damaging the root of the anterior horn of lateral meniscus. So the native ACL center is slightly medial to it. Now the ACL footprint, this is a 3D CT showing the medial and the lateral tubercular epicondyle, the tibial epicondyle. This green is the Pearson knob. Now the blue circle is the AM bundle, the yellow one is the PL bundle. this is what we aim for during an anatomic ACL single bundle reconstruction. So lateral meniscus, we need to avoid it. The tunnel should be placed posterior to it to prevent anterior misplacement. If we talk about the medial tibial spine, the footprint should lie slightly lateral to it. It prevents medial displacement. In relation to PCL, it is roughly 10 to 14 millimeters anterior to it. And if I talk about the radiographs on a lateral film, it roughly corresponds to about 48% posterior from the anterior tibial plateau. It ensures proper graft tensioning. In coronal plane, it should be the tibial tunnel should be slightly lateral to the midline, just near to the lateral tibial spine. So the common errors that one can encounter during initial few ACL reconstruction is, if the tunnel is too anterior, it can cause impingement into the intercondylar notch. If it is too posterior, it may cause a vertical graft. If it is too medial and lateral, again, it may cause late onset instability. So orthoscopic landmarks are important. One should confirm their position thoroughly. One can, always shift their scope from AM to AL bundle, or anterolateral portal to anteromedial portal, or can even make accessory portals just to ensure where their true bony landmarks are, and use a correct angle guide. So this is an arthroscopic view showing the lateral root of anterior meniscus and the ACL footprint where it lies. So this is just few of the pictures showing femoral tunnel. An offset aimer, an elbow aimer was used over here, and the tunnel were made. So why tunnel accuracy matters? It determines the graft function, it determines knee kinematics, and it has a major role in late onset failures. So this landmark paper was published in Knee Surgery Sports Traumatology Arthroscopy. It showed that about 10 to 40% of tunnel placements in ACL reconstructions are the reason for failures. So it can be attributed to your portal, it can be attributed to the degree of flexion in which you are making those tunnels, and it can be attributed to anatomic variations also. So getting a lateral X-ray, the tibial tunnel should be slightly parallel. It should be parallel to the Blumenstadt line, and it should be slightly posterior to the anterior lateral edge. Now, to anterior tunnel, it can cause impingement to intercondylar roof, can cause extension loss, can cause fraying, rupture of the graft, and pain and stiffness, which no surgeon wants. To posterior tunnel will lead to a vertical graft. It causes poor rotational stability. It may lead to persistent pivot, and it will cause functional instability. To medial is again non-anatomic, and to lateral will cause inadequate tensioning of the graft, leading to late onset stretching and suboptimal biomechanics. So combined malposition can lead to early graft failure, need for revision, and poor patient outcomes. So depending upon your technique, one needs to be wary how to make a true anatomic tibial tunnel. For a single bundle ACL reconstruction, you can shave off the entire footprint. You have a good idea about the anatomic landmarks. The dependency of classic landmarks is high. When you're doing an all inside ACL reconstruction, one need to be very precise. One need to, alter the, one need to be wary about the length of your graft and the length of your tunnels. You need to clean the sockets properly before passing the graft into the tibial tunnel. And if one is doing a remnant preserving ACL reconstruction, then one has to rely more on its experience, because the landmarks are not that much visible doing a remnant preserving. And while drilling the tibial tunnel, one has to be very careful. It should not take the reamer violently into the remnant. It may end up losing the remnant from the tibial side. So this is one of the cases showing bucket handle tear of medial meniscus and the ACL. I'll just quickly go through. So I'll just skip the femoral part because it has already been covered by my colleague. So after making the femoral tunnel, this is the bucket handle tear of the medial meniscus, which was lying inside the joint. Due precautions were taken after drilling the femoral tunnel. The meniscus was reposited into its natural position. Now, all inside and inside out technique was used to suture the meniscus, and it was repaired in its anatomic fashion. I'll just skip through it because meniscus will be taken in the subsequent lectures. So after doing the meniscus work, we are on to the completing the all inside ACL reconstruction. So in this, we are using a retro reamer after placing your femoral, the tibial beath pin. Now the retro reamer is drawn into the tibia using its specific instrumentation. Once the retro reamer is out, you mark the size of the reamer onto the anterior cortex of the tibia. you gauge your tibial tunnel. If it comes out to be say 20 mm or 25 mm as per your calculation, you retro-ream as per the specific diameter of the graft. After your retro-reaming has been done, ensure that your reamer is back into the bone. It is not in a flipped position, then you take it out so that you're not exceeding your tunnel size. Once it is done, ensure after passing your bead pin and the passing your fiber wires, you need to clean it thoroughly. The remnant of this debris may lead to arthrofibrosis or stiffness later on. One should be very clear about what his tunnels are. The tunnel should be adequately visible. Over here you can see I've shuttled my portal, and now I'm looking from the anteromedial portal. This is important because you need to clear all the debris. You don't want that osteochondral fragment while passing the graft to impinge, causing later on knee stiffness or cyclops into the tibial insertion side. So once it is done, the graft is passed into the femoral socket, and finally the graft is passed into the tibia. So final tensioning of the graft. So take-home messages: incorrect tibial tunnel placement is a leading cause of ACL failure. Precision is critical. One must identify the anatomic footprint. We can use always the anatomic landmarks. We have intraoperative landmarks. And one should always twice stick before drilling the final tunnel. Thank you.
Thank you, Dr. Ankit Kataria. I now invite Dr. Imroz Jindal, and his topic is all inside ACL.
Morning, sir. Sir, a small disclaimer, I actually prepared my talk as per 8 minutes, so you'll have to bear with me a minute or two extra. Sorry. Morning, everyone. Today I'll be talking on all inside ACL reconstruction. As my previous two speakers have already elaborated on the need of getting a good ACL tunnel. So just to brush up our anatomy and the technique of the all inside ACL reconstruction, this has been discussed by our previous surgeons, but still, so the femoral attachment of ACL, the AM bundle is behind the bifurcate ridge and PL bundle is ahead of the bifurcate ridge. And on the tibial side, the anteromedial bundle actually is a comma-shaped attachment and it engulfs the posterolateral bundle. So with this background, let's start with the basic how ACL, all inside ACL reconstruction is done. So mind you that this is the actual technique, not just doing that femoral tunnel with the typical technique and then looking at the X-ray and showing it to the patient that, yeah, we have done the all inside ACL reconstruction. So the basis of all inside ACL reconstruction was that to get a better anatomical tunnels. So for getting the femoral tunnel, you put your scope in the medial portal, look at the medial surface of the lateral femoral condyle, and that is the view which you will get. So you localize the femoral footprint. That, if you see from there that we are putting that, and then you put in your flip cutter. That's how the flip cutter will look like if you are looking from the medial portal, and then you flip it, and this is how that black ring over there will show you the length of the retrograde tunneling for all inside ACL reconstruction. And the jig with the ring is the tibial jig. And the same technique is followed over here also for the tunneling of the tibial tunnel. So is this the latest technology? Is it better? Everybody is talking about this all inside ACL reconstructions, how, because it's economically also good for us. So we decided to take on this, and we decided to do a study of our own. We did 30 patients with all inside ACL reconstruction and 30 patients with anteromedial portal technique. And we took them for studying the tunnel for a CT scan after the surgery. We used the Bernard method for finding the localization of the femoral tunnel. So you basically, over the medial surface of the lateral femoral condyle, you draw this quadrant and you localize the center point, and then you define it in the terms of T% and H%. H% divides the percentage of the height of the lateral femoral condyle, and T% is percentage of the transverse dia of the lateral femoral condyle. So as you can see over here, in the anteromedial and all inside both the groups, the data was statistically insignificant, both in T% and H%. And we also did some other analysis. We looked for the coronal alignment. So this is the axis of the gantry. We aligned it along the tunnel, and if once you align this, we measured the coronal angle, and once you align it on the axial view, you get such kind of view in which the whole tunnel is visible in one go. So we measured the dia and the length of the tunnels. So as you can see, the length of the tunnels was almost the same. However, if we concentrate over the coronal alignment, the femoral tunnels in all inside were more horizontal as compared to the anteromedial technique. And it is because if we go with the all inside jig for the femoral tunneling, we are able to see where our tunnel is coming out, because we have that punch which we put it in the lateral femoral condyle. So we know that, and we tend to make it more horizontal. That is why these were more horizontal. Same thing we did for the tibial tunnels, and both they were statistically insignificant in both the groups. However, in mediolateral direction, we were more closer to the posterolateral bundle as compared to the anteromedial bundle location. Otherwise, both the groups were same. We did the same thing for the tibia also. If we measured the coronal alignment, we saw the sagittal alignment as well as the diameter of the tunnel and the length of the tunnel. Obviously, the length of the tunnel in all inside was much smaller because of the technique. And if you see, the orientation was absolutely similar in both the situations, whereas the length was shorter in all inside, which is bound to happen being a socket method. The dias were similar in both the techniques, so there was no statistical difference in both the techniques. However, in all inside, the smaller diameter tunnels were more common, but statistically it was insignificant. We compared our data with the previous studies. These are landmark studies which we compared our data with, and our data had shown no statistically significance from any of the previous studies, except the thing which I have already discussed, that in anteroposterior it was closer to the posterolateral bundle insertion as compared to the anteromedial bundle. So our patients are more interested in getting back to their sports or to their profession. So there are multiple studies which have shown that their short-term functional outcomes are better with all inside ACL reconstruction. So we decided to take this on also. So we took pre-op data. We skipped the 3-month data because every study had studied at 3 months. So we studied at 6 months and 12 months. And there was no statistical significance. Yes, the VAS scores in first 3 months, at fifth day, 1 month and 3 months were better in anteromedial portal technique. Yes, obviously, because the anterior cortex is intact, patient is able to ambulate better. There is no fracturing of the anterior cortex, but in all inside, those are the benefits. But once that thing is gone, there was no functional difference in any of those techniques. And these are the few more studies which we went through, and these also say that at a long term, this is at 6 months, this is at 2 years, they show that there is no statistically significant difference at more than 6 months in all inside versus anteromedial portal technique. So benefits are not only in the clinical outcome sense, they are also in the amount of money which is involved, and also the time. The operating theater time, that's one of the variables which we do not look into when we are comparing the cost benefit. So I'm not going for the time part because that is variable for every surgeon, and the more surgeries you do, that will become different. But as all of us know, that the amount of money which the patient has to pay for all inside is quite statistically significant. So in the end, I'll like to conclude my thought with this, that both anteromedial and all inside techniques of drilling the tunnels can achieve near normal positioning of the tunnels. There is no statistical significant difference in both the techniques. The benefit of anteromedial portal is that it is cheaper, yes, familiarity by most of the surgeons, so lesser OT time, and those factors are there. However, all inside technique has got its own benefits. First, that the femoral tunnel positioning can be adjusted. In anteromedial, we are only relying on the offset guide. We cannot see where laterally it is exiting, whereas in all inside, we know where it is exiting. There is lesser anterior leg pain at 6 weeks. It's friendly in shorter graft. We need not go for augmentation. And there is less hardware symptoms because we are not putting up the bioscrew or cross pins. Thank you.
Dr. Imroz, a small question for you.
Sir.
You told that the difference between the femoral tunnel drilling method and the anteromedial and the the flip cutter method.
Yes, sir.
You identified the orientation of the tunnel.
Yes, sir.
Was more horizontal in cases that you drilled with the outside and aiming device.
Yes, sir. Yes, sir.
It depends, the angle of the tunnel depends upon what position you aim your drilling guide.
Yes, sir.
In the accessory anteromedial portal technique.
Yes.
So it is way more subjective than the orientation is way more subjective. The point where you keep your wire defines the result and the accuracy of the ACL reconstruction.
So
it remains the same, whichever method you use. The orientation of the tunnel, whether it's horizontal or slightly less horizontal, really does not transpire or has any effect on the outcomes of the ACL reconstruction as has been stated by in all the studies as demonstrated by you. So, in no way we can say that the drilling via the accessory anteromedial portal is inferior or less accurate than the by flip cutter method. So this is one method, observation I would like to make, because throughout the presentation there was comparison that the flip cutter method for femoral drilling is a superior method. Throughout the presentation you had many things comparing those. So just wanted to give this message to the audience that both the techniques have equal results as suggested by the studies. So both are equally comparable. Yes, for counseling purpose, you can say it may be more close to the all-inside technique, but so far as results are concerned, they don't transpire differently in the results. Just an observation.
Sir, I have also brought out the same thing, that there is no statistically significant difference between the outcomes at 6 months or 12 months or 2 years. There is no statistically significant difference. There is no statistically significant difference at the starting point of the tunnel in the femur as well as tibia. Exactly. My only point was that in all-inside, with the all-inside femoral jig, since we are able to see the jig and the exit of the wire from the outside of the body, we know where it will be exiting, and we know that with the vertical tunnels, the chances of rotatory instability are still there. So we tend to err towards making it more.
Again, I would like to correct you. The vertical or the horizontal orientation of the femoral tunnel does not affect the instability.
Sir.
It is the point inside the joint that determines whether it will have any effect on rotatory instability or not. The tunnel orientation, the direction, the exit point, it has no bearing whatsoever on your instability results of ACL.
Yes.
That is what I want to point.
Yes, sir. I am just saying that it is that we have a tendency to make it more horizontal because of this, that we have to make it horizontal. There is no functional difference. I have brought it out. There is no functional difference, but we always tend to err and make it more horizontal. And with the all-inside femoral jig, since we know that where is the exit, we tend to make it more horizontal. That is the only reason which I have brought out. It is not going to make any difference in your functional outcome. That is what I have brought out in my conclusion slide also, that there is no functional change. Most of the all-insides which they are doing with the, using the offset on the femoral side and just for the X-ray purposes, That's all, sir.
Can I add one thing?
Yes, sir, please.
If you'll see the paper by the Fridifu and all, they are doing more horizontal. Femoral tunnel one more horizontal. Even from the outside in, they are from the accessory medial portal, they are doing the femoral tunneling and at 120 degree. And he has shown the results are better if your femoral tunnel is more horizontal rather than vertical.
No, that is the point.
No, I'm saying there is no difference.
Point is that the results are same.
Yes, the results are same. There is no need to make a accessory medial portal.
Horizontal is the orientation of
graft.
The bony part of the tunnel. It is not the placement of the tunnel inside the joint.
Sir,
the horizontal part that you're saying the tunnel is horizontal is the orientation of graft inside the joint depending upon the point where the tunnel starts in the femur. What they study is the direction of the tunnel inside the bone.
So it can be extrapolated as there is no need to make an accessory medial portal just to make the tunnel horizontal.
That is
so
that point is well taken.
Yes. So that is what I have tried to bring out, sir.
Good enough.
Thank you, sir.
Nice presentation. Thank you. Next.
Please carry on. Thanks, Dr. Imroz Jindal, for the beautiful presentation. I now request Dr. Atul Raj Sharma to speak on pediatric ACL reconstruction.
Thank you, Dr. Jindal, for a wonderful talk, and Siddharth sir for putting up some great points. Very good afternoon, everybody, and I would like to thank JOS and Dr. Joshi for this wonderful invite. So I would also like to pay my advance apologies if my lecture extends over the borders. So starting with the pediatric ACL reconstructions. So the incidence of ACL tears has been increased about 2.3 per year from last 1 decade, increasing up to 29 folds in increase that has been seen in last 2 decades. So this is probably because of the increased demands of sports, high clinical suspicions, improved imaging and diagnostic methods, and surgical reconstruction techniques that are coming into pictures. Straight away to a case having a 12-year-old boy who had a football injury while playing, was unable to put weight on his affected limb, heard a popping sound, there was mild effusion, along with the ligament test that was positive, x-rays are suggestive, the physes are open, there is no bony fracture. On a sagittal view of the MRI, we can see that there is an ACL tear with no meniscal involvement as such. So what is going to be the surgical technique and how do we decide? So it depends on the things that come to our mind is the treatment options, whether we have to determine the skeletal maturity. If surgery, then what are the options available with us? So the first option that remains with us is the observe. Do we observe it and then delay the surgery till the skeletal maturity, or if symptomatic, the patient comes back, we can fix it later. So, but there is a problem with this approach. The natural history of untreated ACL remains, and it's not too good. There is enough literature to prove that. There is a systemic review and meta-analysis proving that in 30 studies, a non-operative treatment led to more instability, more meniscal tears, and low return to sports. Along with that, delayed treatment more than 12 weeks, the patient presenting late, showed up that there is an increased irreparable meniscal tears. Further strong, the study is being shown by bone and joint journals, Arthroscopy, and the knee surgery, presenting that delaying anterior ACL reconstruction increases the rate and severity of the medial condyle injuries, while the anterior cruciate ligament early fixation leads to better outcomes. This was proven in 9 studies having 1,353 patients, showing that the ACL reconstruction significantly decreases the rate of secondary meniscal injuries and the rate of medial, lateral, and patellofemoral condyle damage. So this option is no longer there. So what is going to be the next option? Do we select the patients depending on his athleticism, his age, or the activity level? But it has its own problems. We have a study to prove this thing, that the rate of concomitant meniscal tears in the pediatric patients with the ACL ligament injuries increases with age and the body mass index. For every year of increase in age, there is 60 to 20% increase in the risk of the meniscal tear. For every 2-point increase in the BMI, there is 10 to 12% increase in the risk of meniscal tears. So now, these two options, they remain out of picture. The last option comes is the surgery. But surgery, as we know, comes with its own downfalls. There are certain reports suggesting that damaging the physis can cause valgus deformity. But in a longer run, in a meta-analysis, it was shown the surgical outcomes of and risk operative treatments of rupture of the ACL in children and adolescents showed lower risk of limb-length discrepancy and the deformity. However, you have to take care of the graft. Bony graft should not be there. You should avoid any presence of any implant in the epiphysis. So how do we do ACL reconstruction in children? First, we have to assess the age or the remaining age that is left to decide what kind of surgery you are going to undertake. The chronological age is definitely not the right option to be considered. These are the kids of the same age having a different stature. So all little kids are of same age but have a different belts. So not a reliable option. So the maximum thing that we can, in today's time, that has been taken over is using a skeletal, we consider the skeletal maturity. And hand x-rays remains the paramount in that. We take the x-ray of a left hand. We see if the physes are open. That means if the distal phalanges are open, then prepubescent stage is going on and patient can have a physeal sparing ACL reconstruction. But if the physes are closed of a distal phalanx, you can proceed with transphyseal ACL reconstructions. So there is a brief treatment algorithm for the surgical management of the ACL tear. So this is a flow chart. You can take a picture of it. It depends on the tenor stage as well. So what are the surgical options available with us? It broadly depends on the physeal sparing and the transphyseal approach. We'll consider the first option where there are no tunnels. It is considered in patients up to 8 to 10 years with the tenor stage 1 and 2. It's a physeal sparing approach where we use an ITB graft from the patient himself. The advantages are there are no tunnels, no metals, and autograft tissue is used. We take a strip of iliotibial band marking on the lateral femoral condyle of around 15 centimeter with 1 centimeter width. We resect the proximal part. We introduce the Kelly from the anteromedial portal. We take the graft from there, from the lateral femoral condyle. We bring it down in between the intermeniscal ligament and we fix it to the tibia down there. The outcomes of physeal sparing ACL reconstruction is out of 237 patients, the graft rupture rate was less than 6.6% with no deformity or limb-length discrepancy. 48% of the patients reported a lateral thigh asymmetry, but only 1.6% reported to have a pain. So the next option that comes into the picture is all epiphyseal. Coming back to the guy that we discussed in the beginning, it generally preferred in the age more than 8 to 10 years with tenor stage 2 to 3, or there is a remaining growth left of around 3 to 6 years. It is an established approach. We had been performing this approach over the last 25 years, well published in JBJS, described and modified by the Anderson. So this is the brief of that. Show you the video. We clear the tunnel. We form the portal from here. We can use intraoperative imaging, drill it, protecting the physis, remain distal to the physis. Bring in the flip cutter, put in a graft, prepare the tibial ends, and then pass the grafts. And then end both the sides with a disc. So the outcomes and complications after all epiphyseal anterior cruciate ligament reconstruction in the skeletally immature patients showed 27 patients, out of which 4 failed. There was no growth arrest or deformities. 3 patients, however, had overgrowth, which required surgeries. The third option and the fourth option that remains is transphyseal, generally considered for patients more than 13 years of age with tenor stage 3 to 4, with 1 year of remaining growth. Transphyseal ACL reconstruction or a physeal respecting technique, the principle remains the same. The soft tissue graft should be used. You have to verticalize your tunnels as much as possible. No implants around the physis should be there. Now there is a study by Shia and Kresher that showed tunnels up to 9 mm causes physeal loss of around 3.8% on the tibia and 5.4% on the femoral. And if we make the tunnel horizontal, there is 7% physeal violation on the medial side of lateral side of the femur. And if we keep the portal more vertical, there are less chances of physeal disruption. So a graft up to 9 mm showed about 5.4% disruption of the fascias around the femur. Transphysial anterior cruciate ligament reconstruction in skeletal immature patients showed by Kumar in JBJS, published that 32 patients with vertical tunnels with 6 years of follow-up had only one re-rupture rate, one valgus deformity, improved functional outcomes. And in 61 studies, out of which 2 failed, 3 required manipulation under anesthesia for postoperative stiffness. The mean growth was normal, no limb length discrepancy was found, no deformity was seen. So my take-home message for us is where surgical treatment for a pediatric ACL test should not be delayed. Pfizer sparing and Pfizer respecting shows biomechanical improvement and functional improvement as well. Left hand X-ray for determining the bone age stands the landmark. Pfizer respecting surgical techniques should be there. Follow the patient till the skeletal maturity to know your complications. Thank you, and I appreciate your patience.
Thank you, Dr. Atul. The house, we are now open for all question and answers for this session. And as we are running short of time, I think we'll have to restrict the questions.
Sure.
Any questions, please?
So if there is no questions, we will go to the session 3. Thank you all the chairperson. Now I'll request Dr. Mukesh Joshi, Dr. Satpal Gupta, Dr. Gurdeep Sharma ji, Dr. Pramod Mahindra and Dr. Aman to chair the session. And I'll request Dr. Gagan Khanna sir to present his talk on Peroneus longus harvesting.
आगे कैसे जाएगा इससे
Thank you everyone, and I especially thank to Dr. Varun Joshi and the Jalandhar Orthopedic Society for inviting me here and giving me the opportunity to present on peroneal longus harvesting. Respected chairperson, I'll start my talk. My objectives are to teach the young surgeons and tell the residents about the steps of the peroneal longus harvesting. So what is the position? What is the position of ankle, knee? What are the bony landmarks? Then incision, identification of the longus and brevis tendon, tenodesis of the distal parts, and then the retrieval of the tendon. So when you see the landmark, there are 2 landmarks, one distally and one proximally. Distally, it is the lateral malleolus. So we mark the lateral malleolus, and this is the midpoint of the lateral malleolus, which is almost at the level of the posterior prominence. We will start the incision taking this mark, the midpoint of the lateral malleolus. The position is supine, ankle is plantar flexed. Video चल नहीं रहा है. दूसरे में लगा के देखें आपको पानी तो आप अपने में लगा के देख लो. ये तो गलत हो जाएगा. कैसे करेंगे? आपके लैपटॉप में होगी वीडियो. ये मेरी लैपटॉप की है. अंदर कहीं पड़ी. हाँ हाँ. लैपटॉप से की आपकी. Sorry for the inconvenience. See, peroneus longus is a tendon which has long tendinous anatomy, and peroneus brevis is a tendon which has muscle attachment to it. So peroneus longus is outer to, and it is the first structure you will see. Then is peroneus brevis, which is proximal to the 2 centimeter proximal to the midpoint of the lateral malleolus and 1 centimeter posterior. See, the positioning of the incision is important to prevent the injury to the sural nerve. So more it is proximal to the midpoint of the lateral malleolus, the chances of sural nerve injury is less. Otherwise, there is 14% chances of neuropraxia. So after giving the incision, cutting the skin and the deep fascia, superficial and deep fascia, you see the glistening tendon. This is the peroneal tendon. Now we'll cut the tendon sheath with the shoulder blade. The distal limit is the lateral retinaculum. So after identifying the tendon, we will use the hemostat, and with the hemostat we'll try to isolate the tendons. This is the one picture which I have taken from the fibula plating surgery, which is showing the identification of longus. See, there is big tendon, long tendon is there, and just medial to it is Peroneus brevis. This is from the other surgery. So now, after identifying the Peroneus longus, now we are isolating the Peroneus tendon. With the help of Leahy's forceps, I try to prevent the tendon sheets around it, and then bring the Leahy's forceps out of it. During this surgery, my ankle is plantar flexed, so that I am pushing the sural nerve more posteriorly to prevent the injury to the sural nerve. So after identifying the Peroneus tendon, now I will pass the suture around it. So this is the Peroneus brevis, which is medially and anteriorly to it, and it is close to the fibula bone. So now I am passing the suture around it. By putting this suture, I can maneuver the Peroneus longus tendon so that it can ease my further surgery. Now this is the other landmark which we can do it earlier also. This is the head of the fibula. So the peroneal nerve almost 5 centimeter from the head of the fibula. So my point is, you take the tip of the fibula and take 7 centimeter from the tip of the fibula distally and mark a point there. So your assistant is keeping a thumb there. Okay, it is getting fast here. बहुत फास्ट हो गया भाई. हैं? लैग हो रही है तो उसको इसको कर देते हैं. So after now I am doing the tenodesis. So the next step after identifying the Peroneus tendon is to tenodesis of the distal part. So tenodesis is done, either you loop it with the suture or you can stitch it. We do, in our setup, we do both the things. We first loop it, then suture it. It is getting really fast. So this is the hemostat I have put through both of the tendon. Now it is coming slow. And now I am suturing it. The first is I am passing a suture around it, then squaring it, then passing a suture through it. This is just proximal to the superficial lateral retinaculum. So after doing the tenodesis, now you have two methods. You can use the open tendon stripper or you can use the closed stripper. If you want to do the closed stripper, then you whip stitch it, cut it, and retrieve it with the tendon stripper. In this case, most of the time I use closed stripper, but in this case, as my closed stripper was not ready or it fell down by the sister, so I am using the open stripper. So see, now I am confirming that both of my tendon properly tenodesis is done. Now I am pulling my longus tendon distally, and see, is this at this point my ankle is fully plantar flex. My ankle is fully plantar flex because it gives you 10 mm to 4 mm additional benefit of prevention of sural nerve injury. Prevent the sural nerve injury. So now I am again pulling it distally. Ankle is plantar flexed, and the tendon stripper, the open tendon stripper, I am putting it, keeping it very close to the tendon so that it not injure the sheath. Now the knee is in extension. Now I am pulling the tendon and pushing the stripper and asking my assistant to keep the thumb at the point which is 7 centimeter from the tip of the fibula. It will prevent the peroneal nerve injury. This is the retrieval of the tendon. Now you can use this tendon for the various purposes. You can double strand it, you can triple strand it, and you can quadruple it also, depending upon the surgery you are using. So what is the benefit of Peroneus longus? The benefit is it has a very consistency in length and diameter. We did a study of 33 patients, and we found that the mean diameter was 8.2 to 2.5 centimeter in all the cases, which is comparable to the other studies. And the length is from 23 centimeter to the 30 centimeter. So the mean length came out to be around 27, 26 centimeter, which is consistent with the another study. Now the disadvantage is you always wish that you are removing one everter, main everter. But doing tenodesis, there are studies which are suggestive that there is no disability. Even in our studies also, the dash score, the ankle score, they are comparable to the previous scores, the preoperative scores. So what are my preferred indications? The preferred indication, it is not my preferred indication, it are the written indication in the literature. One is non-athletic person. Then the indication for the main indication is for revision ACL and multiligamentous injuries. For primary, it is for female gender, short stature, and non-athletic patient. So what are the tips and tricks with which we can reduce the disadvantage, reduce the complication? The main complication is neuropraxia, paresthesia of the foot, which stands from around 4 to 15% of the cases. Out of this, 8% are the sural nerve injuries, which can be prevented by by plantar flexion of the ankle. Second, as I have marked the mid of the lateral malleolus, that is a very important landmark, not the tip of the lateral malleolus, it is the mid of the lateral malleolus. 2 centimeter above it, we have very less chances of neuropraxia. But more you are closer to the midpoint of lateral malleolus, more the chances of sural nerve injuries. Second, to prevent the peroneal nerve injury, you keep a point, it is said that 5 centimeter from the femoral head. Femoral head is a very vague structure. You take tip of the femoral head and around 7 centimeters, that is 3 inches from that place, you keep a thumb over it and it will prevent passing of the tendon stripper across that point, which prevents the nerve injuries. And this is our study, which is comparable with the other studies. Out of 33 patients, one patient, the lady patient, had neuropraxia, which was transient. She had weakness of the avulsion, which luckily regained after 3 weeks. So we, as per my recommendation, it is as per the literature, if you have short stature female patient, which is non-athletic, you can always consider use of Peroneus longus as a primary structure, primary graft. Otherwise, it is better to use it for multiligamentous injuries or revision injuries. Thank you.
Thank you very much, sir. I'll call upon the next speaker, Dr. Tarun Goel, for relief on hamstrings.
A very good morning. So hamstring tendon graft, we are going to see how we harvest the hamstring tendon graft. It's one of the most commonly used graft for ACL reconstructions, and probably the workhorse of tendon harvest for ACL reconstruction. So we are going to discuss about how we make the incision, how we identify, how we take down, and how we clear the graft, and then finally strip the tendon. These are the surface landmarks that we are going to use. We are going to identify the patellar tendon, the patella, and the tibial tuberosity, and the posteromedial border of tibia. So our incision is going to start about 2 centimeters from the tibial crest and towards the posterior tibial border, and it starts at the level of the tibial tuberosity and goes down by around 4 centimeters, about 2 finger breadths from the midline. We can also try to palpate the hamstring tendon grafts. In most of the skinny patients, you can easily palpate the hamstring tendons against the proximal tibia. This is how the incision has been made, and once the incision has been made, remove the bursa which is present over these tendons with a blunt dissection with a hand or a wet gauze, and then identify the sartorial fascia. So the sartorial fascia is a very thin fascia which can easily pick up with your thumb forceps, and once you have picked up with the thumb forceps, you have identified it, you can dissect it with the scissors. Be careful you're not damaging the tendons. So saphenous nerve branches do come in this area. There is a vertical skin incision. It's possible that you may have some paresthesia in the post-operative period in these patients, which you should counsel them and also probably take in their consent as well. Be careful about the medial collateral ligament, which is deeper to these tendons. So if you are carefully identifying the tendons, that will not be an issue. So we are trying to harvest the tendons. We are trying to identify the tendons not at the insertion on the tibia, but little bit more proximal, because at this stage the 2 tendons are separate and can be easily identified from each other. The important thing is that these tendons can be palpated at this point. Once you are giving the skin incision, you can easily palpate the roundish tendon of the gracilis and the flattish tendon of the semiti. So these tendons, especially the semiti tendon, have adhesions to the surrounding bone, the sartorial fascia, as well as the medial head of the gastrocnemius, which needs to be cleared off, because these adhesions, these strands, they adhere the tendon to further distally, and it will not allow your tendon stripper to go in the right direction. And secondly, it also may cause premature amputation of the tendon while you are harvesting it. So how do you do it? Once you have identified the tendon, you have identified both the tendons, pull them individually, pull them out of the incision individually, and along the inferior border of these tendons, you will see multiple adhesions which are going down. So these tendons are taken down one by one with your scissors, and then as we have passed the finger, you saw us passing the finger there, so we have passed the finger all around 360 degrees around the tendon, causing a blunt dissection to dissect it clear from all the soft tissues. So there is no fixed number of adhesions of such strands in a given patient, and these may be variable. Sometimes you may have 3 to 4 of such strands. Some of them will be very distal, so you can easily see them as soon as you pull on your tendons after dissecting the fascia. But other times you may not be able to see them clearly. So you pull the tendon, and even up to 10 to 12 centimeters of the tendon insertion, these can be seen. So do not use your stripper, do not remove it unless you have identified and removed those incisions. Maintain the traction as you are passing your stripper, because if you do not maintain the traction, your tendon may be pulled into the incision, pulled into the around the popliteal fossa, and it may also cause premature amputation of the tendon. So maintain a continuous traction on the distal end of your tendon while you are harvesting it, and try to go in the right direction. So the right direction will be towards the perineal area, towards the pelvis, and past the popliteal fossa. And you should push your stripper once you are sure that you have passed sufficiently inside. So you have passed almost 15 centimeters inside or quite near the popliteal fossa before you actually exert force into the tendon and goes inside. So you may decide whether you want to take down the tendon before passing the stripper, or as in this case, we left the tendon insertion distally and then we harvested it. graft amputation, be very careful. A strong resistance at approximately 10 centimeters or 12 centimeters after putting the your stripper indicates that some of your adhesions are still left, which has to be removed. So you should not force your stripper inside, which may lead to premature amputation of the tendon. Go in the direction of the perineum or the pelvis, because that is the right direction in which your tendon stripper should be going. Do not allow your tendon to slip inside, because if it slips inside, the tendon ends may retract into the popliteal fossa, or it may even break. So depending upon the size of the tendon, you may have it doubled, tripled, or quadrupled. Preparation of this tendon, all the muscle tissue is removed with a blunt dissection. And after removing all this tissue, you remove the very thin tail of this tendon, then measure the tendon length, soak it in antibiotic solution, just dip it in antibiotic solution, measure the length, and then decide that how much you want. So in this case, we had a length of about 30 for the semity, and we decided to quadruple it. So this is how we are preparing it. The one end is attached to the tendon board, and holding the other end, we are passing the whip stitches. So the whip stitches, they convert the tendon into a tubular structure, the flat tendon into a tubular structure, because that's what you want to achieve. And they also helps that once you pull the tendon, it doesn't crimple upon itself. So this is how the whip stitches will be made on both the sides. So once you take the whip stitches, make them at a distance of about half to 1 centimeter from each other. Take about 2/3 of the tendon width at the same time, and 4 to 5 whip stitches on each side. Do not use too much suture material on the tendons, because the suture material is not biological. It is not going to help in healing. In fact, it's going to create some inflammatory response while you are inside the tunnel. Then the adjustable loop is passed, and the sizing of the tendon is done. We have seen the sizing. We have seen parts of this technique in by the other speakers as well in the morning. And then you have passed the vicryl at one end. Near this, you have marked it about 1.5 to 2 centimeters, depending upon what depth you want inside the femoral tunnel. Tie all the strands with the vicryl at about 2 centimeters, and debulk the excessive ends. And you are achieving, in this case, we achieved it about 8.5 millimeters and 8 millimeters of this. Minimize the foreign material, maximize the diameter. So to conclude, palpate the tendons and plan your incisions. Separate tendon from the fascia and adhesions. Have a good tactile feeling of the tendon harvest while you're passing your tendon harvester, and decide the final length and the diameter of the tendon that you're going to achieve. Suture with equal tension in all the limbs of the graft, and avoid excess suture material in your prepared tendon graft. Thank you.
Thank you so much, sir. I'll call upon Dr. Siddharth for relive on BPT.
Good morning, everybody. So, a technique, let's use BPTB harvest, a small video on this, and I'll try to do the justice. So I'll straight away start with the video. So after doing the markings, we give an incision right in the center of the patellar tendon, longitudinal incision, starting from the inferior polar patella, right till the tibial tuberosity. We identify the patellar tendon and the peritoneum, mark the extent of the tendon from the medial to lateral. In this case, it's around 28 mm. We mark the central 1/3 of the tendon after identifying the total width, which is around 9 to 10 mm in this case. After marking the planned tendon which we want to remove, then we further cross-check it with a cut end of a scale to see the width of the tendon that we would like to harvest. Once we have checked the width, then we take a 15 number knife and give longitudinal incisions along the patellar tendon to separate the 1 centimeter width of the patellar tendon from the whole of it. Now, after separating the middle 1/3 of the tendon, we proceed to the markings on the bony parts. With the knife itself, we mark our planned cuts on the bone in line with the tendon graft. Further, marking the bone plugs with the marker pen. So now we have a 1/3 central, 1/3 of the patellar tendon, around 9 to 10 mm wide, with the marked 2 to 2.5 centimeter bone plug at the inferior pole of patella and the tibial tuberosity. With using a small size 8 mm to 10 mm saw blade, we make the cuts in the patellar end 45-degree inclined to the vertical to give a triangular bone plug from the patella. So, so we make both the medial and the lateral cuts precisely through the patella with a 45-degree angled saw blade. This is the lateral cut being made. Then going to the medial side and making the medial cut. So both the cuts being 45-degree to the vertical meet in the center and give us a triangular graft which gets separated by itself. After doing both the medial lateral cuts, we do the horizontal cut a bit gently. So we take a 8 mm osteotome, a sharp osteotome, after separating all the 3 cuts, and gently lever out the bone plug. It should come out without much of force, so that you need not put too much of force and the risk of patellar injury is less. So generally it comes out easily if you have given proper 45-degree through and through required amount of bone cuts. So while doing the cutting, you have to put across the depth of the saw blade. You really want to go inside the bone so as to avoid going to the patellar cartilage. Now on the tibial tuberosity end, you again identify how much of the length of tibial tuberosity you want to take. I normally take around 25 mm. Same the medial and the lateral cuts are made with the saw. And the horizontal cut is again made, and I lever it out with the same osteotome. Sometimes you can give initial holes with 2.7 mm drill bit so as to direct your saw blade, and thus having less risk to injure the bone plug. Yeah. So this is cutting the tibial tuberosity bone with the saw, both medial and lateral. So as you can see some fumes signifying how hard is the bone. So while doing the cuts, you have to maintain traction on the patellar tendon so that it does not get stuck in your saw. So again, the direction has been around 45-degree. So as to let the bone plug come by itself, you lever it out gently with your osteotome, and sometimes you just need to complete it with the help of a bit of hammer. So with this, you can have an easy delivery of your graft, having 2 and a 2.5 centimeter of bone plug on the either side and a 10 mm width of the patellar tendon. I relatively give a lesser angle to the tibial tuberosity so that bone plug is relatively bigger and having more cancellous bone on this end, because I'm less worried about the bone stock at the tibial tuberosity vis-a-vis at the patellar tendon. So after separating both the bone plugs, with the 15 number knife, we gently separate any remaining bands of the soft tissue and the tendon and harvest the graft. Now, once the graft is harvested, we need to prepare it at the back table. We measure the total length of the bone plugs. This is 2.5 centimeter of bone on the tibial tuberosity side and around 2 centimeters on the patellar side. If you see the cross section of the this bone plug is triangular, So now preparation of the graft. Yeah, we drill 2 holes at both the bone plugs and pass 2 suture wires, number 2 in diameter, on both the ends, so as to have a longitudinal force with which we can pull the graft in the tunnels. So after we have passed 2 fiber wires in both the ends of the bone, we have a well-fitting 10 mm graft which we mark at both the bone plugs and can be used for ligament reconstruction. Thank you.
Thank you very much, sir. I'll call upon Dr. Inderdeep Singh for relive on quadriceps.
So good afternoon, everyone. So as it is said, I would like to thank the organizers for having me here, and it is very good to see everyone being engaged into the learning. So we are moving on to something which is called as new kid in the block, but I will not say it's a new kid in the block. It's been there since ages. So quadriceps tendon is very important tendon whenever we are doing a reconstruction particular set of patients. So let's focus on the legs. And I will say that it's very important to know your implants and instruments before you dive into a surgery, because you don't want any surprises on the table and cause some ruckus on the patient. So it's very important to know these particular instruments. This is called a guide track. It has a marking of around 10 mm on it, and even the longitudinal markings how much depth we have to go with a minimal invasive technique. It's a Q view retractor. It's very important to have this in your kitty because it will help us in viewing the quadriceps tendon and amount of tendon we need to harvest for our reconstruction purpose. A track cutter and blades is again helpful, although everything can be done with a simple BP handle. Then a quad cutter and a blade is important instrument to give a proximal cut on the quadriceps when we are harvesting it. Although we can harvest quadriceps with a standard tendon stripper also, I'll come on to that later. If you don't have all these fancy instruments, then you can use a simple 15 knife to even harvest a quadriceps tendon, but you have to make a longer incision and you cannot follow the minimally invasive techniques. The quad specific implants, there are different implants from different manufacturers. The one I am concentrating on today is ultra button quads. So it is an adjustable loop kind of button which we use for fixing a suspensory fixation on the femoral side, and we can use the ultra button tib, which is a suspensory fixation on a tibial side. However, you can use the interference fixation on the tibial side as well. So going on to the graft harvest per se, so I prefer giving a longitudinal around 2.5 to 3 centimeter incision over superior pore of patella, separate the fat pad and the peritoneum over the quadriceps tendon, and with the Q view, the COBS or standard elevator, we separate the subcutaneous tissue from the tendon and insert this retractor. With the cutter blades, we mark around whatever diameter we want of a tendon to be. It can be variable from 8, 10 or 12, depending on what ligamentous reconstruction you are planning to do. So normally we go in for 10 mm thickness, and you can also choose to do a partial thickness or a full thickness quadriceps tendon while harvesting it. So after doing the initial marking, you have to lift it up from the superior pole of patella. You can do an all soft tissue or a soft tissue with a bone plug on the patellar side. Do couple of whip stitch, separate it with the scissor. With a good hard heavy scissor you need, because it's a very hard tendon and a small fine cutting needle scissor cannot be helpful. Then with the quad cutter you insert it and choose the length you want to use. If you are doing a suspensory fixation on either side, 6.5 to 7 centimeter of length is quite enough. Or if you are doing an interference fixation, then you may need around 8.5 centimeters of length. it is important to suture the apex of the quadriceps tendon whenever you are harvesting a quads tendon, because otherwise there can be some weakness and there can be defect which can be palpable on the around 8 to 9 centimeters proximal to the insertion of quadriceps tendon. So it is very important to use an antegrade device and suture the apex of the defect, as we do in an episiotomy whenever we were doing it during our internship times. So after doing these knots, you close the apex and follow it distally down towards the patella and close the pouch, because most of the times it is said we don't hamper the pouch, but there will be a lot of extravasation of the fluid. So to prevent that also, it is important to close the apex till the patella. So then preparation is slightly different depending upon the device we are using. So till 20 mark, we pass in a needle. It is a needle which is continuous with the suspensory fixation device. You have to pass through it and cinch it through the graft. Mind it, don't remove it from this paper tagging sutures, because it will be a lot of sutures and you will get confused. Then you have to give a strong pull to do a luggage tag or a cinching it around the quadriceps tendon. So you have to pull it hard. So once you have done it, then you have to do a couple of whip stitches around it, behind where you have gone on the femoral side. From here you have passed, you go beyond it, make a pass from top to bottom, and once you have done this, you have to move these sutures of the adjustable loop distally and then move them out of the way, and then do a whip stitch over the tendon from distal to proximal. So keep on doing it. So these are the sutures which will help you in pulling the graft inside the femoral tunnel. So once you have done this, you have to do couple of stitches for this 1.5 to 2 centimeters of length. So once you have done this, this is how it looks. So similarly, you have to do it on the tibial side. So same on the tibial side. I'll just fast forward this video for want of some time. So same is on the tibial side as well. We have the ultra button tib, which is available in various sizes. So this is how it looks in the end. So both suspensory fixation on the either side with a quads tendon. So it's look a good stout strong graft, and it measures around 9 and whatever size you are intending to do in a particular patient. So if you are preferring to do a suspensory fixation on femoral side and interference on tibial side, then you have to take a longer length, as I said, and you can just whip stitch on the tibial side as we have done in this picture. So then comes a graft passage. It is not same as any of our fixation devices. It is slightly different from the normal routine adjustable devices. So once you make a pass here, you have to pull the threads. There are two set of threads. One is with the loop and one is with the graft. So now, we have to pull the shuttling suture before, and then you have looked for the button which is flipping over on the lateral cortex of the femur. You have to separate out these sutures and then pull them one after the other, because if you try to pull all the sutures at one time, there can be some crumpling of the sutures and entanglement of the sutures, and you can break the loop as well if you try to use an excessive force. So these blue sutures will guide the graft into the tunnel. So as we move in the video, I will just show you how it happens. So once you are pulling the graft with all the sutures into the intra-articular area of the knee. So here, once you go, then the blue sutures will pull the graft inside the tunnel. So then you can shorten the loop, and that's how is the final appearance of a quadriceps tendon. On the tibial side, it's just milking of the graft. You can do it and shorten the loop, and then do the knots over it to secure the loop. We don't do it routinely over the femoral side. However, on tibial side, it's right in front of us. We can do it. So these are the X-rays, how it look if you are using a suspensory fixation on either side, and a suspensory fixation and a interference fixation on the tibial side. So going forward, we can use a quads for double bundle PCL as well, with the same instruments and the implants. There is an alternative technique of harvesting a superficial quads or a rectus femoris, So in this, we can use a standard closed stripper, but it needs some somewhat more skill. It has been described by our own Indian surgeon, Dr. Rajiv Raman from Kolkata. So after harvesting, after separating the superficial layer of the quads tendon, you insert your your closed stripper and push it all the way proximally, and it will snap the graft, and you can get a good length of graft, and you can use it for any of your reconstruction in a standard with the standard fixation devices. So to conclude, learn all your techniques. You should know all your instruments, and you should have everything in an armamentarium if you are planning to do advanced surgeries. Thank you.
Thank you very much, sir. I'll call upon Dr. Shekhar Singhal for relive on ACL reconstruction technique.
Very good afternoon to all the dignitaries on and off the dais. So let's shift the spotlight from the graft to actual ACL surgery. Because till today, most of the ACL failures are technical rather than biological. So I have divided this talk into 4 videos. First is about identifying the femoral footprint. Second is how to drill it. Third is drilling of the tibial tunnel. And fourth is passage of the graft. So let's start with our identification of the femoral foot. First of all, debride all the tissues on the medial wall of the lateral femoral condyle so that you are able to identify your residence ridge as well as the bifurcate ridge, and mark your ACL point wherever you want to pass a graft with a awl, microfracture awl, or you can use an offset guide so that at least 1 to 2 mm of the wall remains on the back side. Then, after you mark the point, pass your beath pin. Place your beath pin over the point which you have identified, and hyperflex your knee. And after hyperflexing, just pass your beath pin through the lateral femoral condyle. So once you have done with that, then you have to drill over your beath pin with a beath pin drill, which is 4 mm drill bit. And while you are doing it, make sure that you are able to get a rough idea of whatever your tunnel length comes out to be. So, and after this, you have to measure your tunnel depth, and it has come out to be 38 in this case. Sorry. Yes. Now you want at least 20 mm of your graft to be inside your femoral tunnel. So when you have measured the graft diameter, take that appropriate size reamer and ream at least till 20 mm inside the femoral tunnel, and make sure after reaming you have to check that there is at least 2 mm or some bone is left on the posterior side. So after this, we'll come on to the drilling of the ACL tibial tunnel. Place a ridge and pass the beath pin right in the center of the native footprint of the tibial tunnel. And you always have to secure it with a curette or a hemostat so that your reamer is not pushed into the knee joint and damages the cartilage. So do serial reaming if you are just started with the surgeries, and to prevent the blowout of the tibial tunnel. And after this, you just have to pass a beath pin again so that you are appropriately in the center of the native footprint. So then comes the last part, that is the passage of the graft. Now shuttle your sutures through both the tunnels, and the most important part during this is that you have to be looking directly into your femoral tunnel while passing the graft, so that you are sure that your endo button is correctly flipped. So here accessory medial portal or central portal has been used to look into the passage of the graft, and you can see that the endo button till it flips over it, and then you should just shuttle your suture so as to pull whole of the graft inside the tibial tunnel, femoral tunnel. and then whatever fixation method you have preferred to use on the tibial side, you can use that. So here the graft is being passed from the tibial tunnel into the femoral tunnel, and here the stiffness of the graft is being checked. And here the bead pin is being used to guide the passage of graft into the femoral tunnel. So by following these few simple steps, these 4 steps, you are able to secure a good ACL graft in your knee. Like, thank you very much.
Thank you very much. I'll call upon Dr. Rita Mukhopadhyay for Relive on ACL repair.
We welcome Dr. Mahajan, Anupam Mahajan from Chandigarh. He's President of Punjab Orthopedic Association. And Dr. Tarun Goyal from All India Institute of Medical Sciences. And everyone, I really feel happy that we are here to enjoy your talks and your researches. We have never seen these things in our life, in our teaching period. Thank you very much for being in Jalandhar, all of you. We are with the Joshi Hospital, thanks to Dr. Varun Joshi, has brought arthroscopy to Punjab. Mostly arthroscopy, now the arthroscopy chapter has been made in Punjab. All the leading persons in arthroscopy in the sports injuries will be having the benefit of that.
I'll call upon Dr. Rita Mukhopadhyay for Relive on ACL repair. Okay. I'll call Dr. Ajay Gupta for Relive on ACL avulsion fixation.
Good morning, chairpersons and dear friends. I'll be speaking on ACL avulsions. ACL avulsion fracture occurs when anterior cruciate ligament is torn from the bony attachment on tibia, mostly on tibia, usually with a piece of bone. ACL avulsions are more common in adolescence age due to relative weakness of bone. The mechanism of injury is when the femur is adducted and the knee is abducted and ankle is in avulsion, and a dynamic force is applied to the knee, whether it's the body weight or a direct force, the ACL avulsion occurs. The classification is type 1, 2, 3, 4. 1 is minimal displaced and 4 is comminuted, avulsed and rotated fragment. The symptoms and signs are swelling, tenderness, instability, inability to flex, fully extend or bend the knee, bruising, or in clinical examination we find the signs positive. In imaging, X-rays are usually sufficient to diagnose. CT scan is used to understand the geometry. Status, MRI is used to view the status of ACL and other structures. Type 1 fractures often respond well to conservative management, while type 2, 3, 4 may require surgical intervention. Younger individuals are more likely to benefit from surgical fixation and it will help to return to the sports. If other injuries like ligament injuries and cartilage damage are present, surgical intervention may be necessary to address all issues. Factors like fracture size, displacement, and degree of combination can influence the treatment choices. Fixation can be open or arthroscopic. Open is mostly abandoned now, and arthroscopic has become the mainstay of treatment of ACL avulsions. Earlier, screw fixation was used. If you want to do a screw fixation, you should be well versed with high portals to attempt arthroscopic screw fixation. A central portal may help in this screw fixation. A K-wire fixation is usually used in the skeletally immature patients, which causes minimal damage to the physis, but they have to be removed after some time. The suture pull-through technique has become the standard treatment for all ACL avulsions. For this technique, you need a suture passer, maybe a lasso, strong threads like ethibond, fiber wire or fiber tape, a standard ACL jig, and some broad gauge needles to pass the sutures. Suture pull-throughs, you may pass the sutures using a lasso, or also use an anti-grade suture passer to pass the sutures through the ACL. Anchor suture fixation is used by few surgeons to fix the ACL avulsions. A single anchor is also useful to avoid the physis in young patients. Otherwise, double row repair suture bridging techniques have been described. In suture bridging technique, sutures are passed to the ligament, and an orthosis anchor is used to fix the sutures to the anterior cortex or tibia. In double row repair, of first anchor is inserted in the posterior aspect of the crater. The sutures are passed, and second row fixation is done with knotless anchors. Endo button or adjustable loops have been used to fix the ACL avulsions. Either endo button is flipped over the ACL, or you can pass the sutures through ACL and fix on an adjustable loop. Staple fixation had been described by Dr. Sundararajan and his colleagues in 2011, but I don't have any experience with this. The clinical instability was seen in 70% non-operative treated patients, but patients treated with screw fixation had a higher incidence of clinically measured instability. Chronic cases have been reported where neglected ACLs have been fixed and have united even after years after the injury. Even a paper has been published in 2017 by the PGI, our PGI colleagues, and they have done arthroscopic debridement of a fragment and open reduction and internal fixation with screws, and they have got very good results with this technique. The rehab protocol is, I will not go into details of this. Femoral avulsions, osseous avulsion have been reported. Many case reports have been there in literature. Femoral avulsion of ACL in multi-ligament scenario, or in adolescent individuals, in elderly patients, and in adults have been reported. The fixation is usually done with suture anchors or suture pull-through technique. So I'll go into the steps of the ACL avulsion technique. The ACL avulsion, first the fragment is identified and separated, and then the crater is prepared using burr and shaver. Then the fragment is reduced and provisionally fixed with K-wire. Then two tunnels are made, one medial and one lateral to the fragment. And the suture is, or a fiber tape is passed through the ACL substance using a anti-grade suture passer or a lasso, and fixation is applied. So we'll in this video we are seeing that the fracture fragment is being identified and is being observed and examined, and it is cleared of the soft tissue. Sometimes the patient turns up late, and we have to clear the crater and remove all the fibrous tissue and the hematoma, and then we use burr to freshen up the fracture site, the crater, as well as the undersurface of the fragment is thoroughly burred and prepared, and following that, the reducibility of the fragment is assessed, whether it is the reducibility is good. After that, we do a fine tuning of the fragment if there is any soft tissue around the fragment, so that the reducibility is good and we can fully reduce the fragment into the crater. And the fragment is reduced and provisionally fixed with K-wire into its position. And following this, a lateral tunnel is made with the bead pin, and a medial tunnel is made. You can do the either way around, make the tunnel first and pass the sutures afterwards, or may pass the suture afterwards. The sutures are passed through the ACL substance, and then the shuttling of the sutures is done in the medial and the lateral side. and another you may use 1 or 2 sutures to fix the ACL avulsion, and after passing the sutures through the tunnels, the fixation is done over a bony bridge or over a button or a suture post. So you can use 2 sutures or 1 suture. So to take home message is arthroscopy fixation of ACL avulsion is an effective method to treat ACL avulsions. Fixation can be tried in chronic cases. With proper rehab, early return to sports is possible. Thank you.
Thank you very much, sir. I'll call upon Dr. Inderdeep Singh for complicated case and how to tackle it.
This ends our session 2. So thanks our chairperson. Now we'll go for the panel discussion of complicated cases, which will be presented by Dr. Inderdeep Singh. So I invite Dr. Tarun, Dr. Ajay, Dr. Anupam sir, Dr. Tirth, and Dr. Siddharth sir.
May I? Huh? How to start? 1, 2, 3. So we'll have a panel discussion on complicated cases. Few of these are my own. So we'll start with case 1. So I'll start with Dr. Mahajan first. So you did an ACL. So this was well finished surgery. He was very happy. He went for a drink after the surgery. Everything went very smooth, and he was very happy as a surgeon. They even had a party in the restaurant. So, but then he sees this next day morning. So, are you happy with the X-ray, sir? So, what has happened? Too bright? Huh? Yeah, brightness. So it's okay? Yeah, you can see. So this is a scene. Now you have seen this X-ray on a morning round. So what will you do now?
Chairperson TV de AV.
Sir, please, you have a mic there. You can answer.
AV department.
So why it happened?
Chairperson TV.
So basically, this is a broken nitinol wire, which we have been using it for quite long time now for putting in a screw on the tibial side. So it's broken, and it's intra-articular. So what will you? So first, we want to know why it happened. So normally, why it happens?
Sometimes your wire get bent.
The angle.
There is slight bending in the wire.
Yes, that's true.
Sometimes there is a bending in the wire. So while you are removing, if it's not coming easily, then don't pull with the force.
This usually occurs when you remove the wire after the surgery, after putting the hole of the screw. When you remove the wire, when the screw is wholly inserted, and you don't remove it before. Then
True.
There are two things here. One is when you push the nitinol, when you put the wire, and if your angle of the screw is different from the angle of the wire, that time the screw tip might be impinging on it, and not that wire bends and then it cannot come out. Number two, when you put you tighten the screw to pull out the wire, at that time it can get cut through that time.
So the wire appears to be far inside.
Yes, so most likely in this case, what has happened is it has gone past beyond the intra-articular part and gone and stuck into the femur side. So where it was stuck, and one of us must have been trying to push the screw very hard as we try to put one size up for a screw. So, and more importantly, we try to use these nitinol wires, which are supposedly to be used as a single time, but we keep on using them until they break like this. So what will you do now? So you saw this on the morning round. So what will you do now? So there is a screw, there is a button, there is a graft inside, and there is a wire inside.
So we have to see where it is in the femur side. Maybe it's in the tunnel, and
It's in the tunnel. It's been past the joint.
Yeah. So the only way to take it out is intra-articularly. You have to go inside the arthroscopy, pull it out, maybe see the wire from there. Because this, if you try and untighten the screw, your graft is at a risk.
But that if we are planning to remove the wire, then the wire is still near the aperture on the tibial side, and the only way to remove will be to remove the screw, then search the wire, and remove it from the tibial side.
Sir, for me, I think we will remove the screw.
Alternatively, if you plan to, just retain the wire, because if you think that it is going inside the femoral tunnel, but
So
there will be again a risk of breaking it at one other place.
So if we see the
joint
sutures,
intra-articularly.
if we see the staples which are there, the staples are quite lower down, and the tibial aperture is quite high up. So if we see here, this is an aperture and this is a staple. It won't be very easy to see this also.
It's very near the
So
aperture.
and this wire must be maybe behind the graft, and it may not be visible also. And we can, arterionically damage the graft also while pulling it out. So you cannot go and beyond and pull it out and then
I
pull
think
it out.
what you'll do in this case is you'll go.
This is not my X-ray.
Oh, करना तूने है सुन ले. What you
Easily
should-
said and done,
sir,
but it
sir,
is not
difficult
possible.
to pull out. I have had this completion thrice. So what you do in this case, you go inside with the probe. You try to search the wire within the graft substance. Once you have identified the wire, then you try to grasp it with a mosquito or an artery, and gradually push it down the tibial tunnel. In this case, if it is through inside the screw, it's pretty much down in the tibial tunnel, so it looks like it's somewhere inside the screw. So along the screw, it is expected to project back from your lower end, and then you can pull it out. That is what the best thing I would do. In case I'm not successful, I'll remove the screw. Again, try to pull push the wire backwards from intra-articular, then pull it. If everything fails, I have no option but to remove everything and then remove the wire. And then again pass the graft with the fresh.
So will you use the same graft, or you will be ready with another graft?
Next, I'll try to use the same graft. I'll just cut the button up, remove the screw and try to pull the graft out, and use the same graft with the fresh set of implants.
So
If
that's good.
everything
So
fails.
basically, you need to counsel the patient that you may need another graft before
Yes,
surgery.
we shall need to counsel this.
Yes. Yeah.
We
So this
shall
is
need
very dreadful complication which we see very commonly, and so moving on to the next question. So you have already told it that these are different ways to skin a cat. So that's how we can remove the wire. And so more importantly, so if it is already said, so there are different ways you can push it down. You cannot pull it because it will be behind the graft. So it's not very easy. It will be all bloody inside. And post-operatively, if you are successfully able to pull this wire out, I will say always keep an eye on the wound, because there are high chances of getting an infection. So give a good lavage inside once you are doing this, and keep an eye on the wound. Give good antibiotics post-operatively to prevent the infection to happen, because it will be 2 surgeries in 2 days.
To identify the wire in the substance of the ACL.
So you may or may not be able to see it.
Hyperflexion of the knee helps because the wire is relatively rigid, so it has a tendency to project anteriorly inside the graft when you flex it more. So it is easy.
Yeah, these are different ways.
Yeah. Not in this case. All of my cases I was stuck in the graft only, they were not in the femoral tunnel.
So that was on the table or next day?
On the table.
On the table. So on the table you can
Every
play
time
with it anytime.
every time I remove the retinol wire,
So wait,
always check for the tip.
That's the next question.
Yeah,
So
every time
what
I
are the
check.
preventive measures?
with me once. I used the small wire. He was not carrying the original wire, so it was a small, short wire. I pushed it. So once it was pushed, I said, "There's no wire." You can same X-ray. It was on image intensifier.
It was on table, right? On table, we have different ways. We have time.
But if you try and scope it, you are not able to find
You can't see it. You can't see it. That's true.
The wire is not rigid. This is so flexible, it keeps on moving. So then what you have to do is just cut the button, take it out and regraft.
Yeah. So it's if it happens on the table, it's very. But what are the preventive measures? That's what we have to learn from here.
Check the wire every time. You are done.
Use
Anything
good,
else? What are different ways?
Use good quality.
Single-use wire. Single-use wire.
No, not single. I use only striker wire because if your
So
wire
they
is
are, striker guys are not happy with me. They are not giving me the wires. So what to do?
मेरे से ले जाना. But
So you need to donate
basically
it to
what
me.
I burnt my fingers, most of the vendors try to give indigenous made local wires which are less flexible and more amenable to breakage. That is the first thing. Secondly, when you put the wire inside, there are marking on the wire which signify how deep have you gone in. So always look at them while you
So
are
normally
inserting.
those markings go past the tibial tunnel.
You should know that just they have passed and around 10 mm, 15 mm, just pass it and stop. Don't let them go far beyond.
So, but if you don't do that, there will be a screw divergence from the tunnel. So how to prevent
around
that?
15, 20 mm, just go inside so that it just exit the tibial tunnel and then put the screw. They are marked at 30 and 40 mm respectively. There are two markings on
So
the
this is very important to learn. So that again, there are different ways to skin a cat. So you have to, whenever you insert a screw, whenever your assistant is pulling out a wire, look at the tip of the wire. It should be blunt. It should not be sharp, and it should have markings, as Dr. Siddharth said. But of late, how we do it, we always go inside, see the wire inside, hold it with a clamp or a needle holder, and then insert the screw. So I think this is one of the best foolproof method of doing it. So I always see the wire and then do it. So case number 2. So over to Dr. Tirth. So you have not answered a single point in last case. So you did a surgery, well finished ACL 20-minute surgery. He was very happy. He did a hamstring graft and the graft was very taut. He was very happy. So morning rounds, he see this. So Dr. Tirth.
Yeah, so this complication is very common, first of all, with the adjustable loop. So I would say that the graft is definitely
So can you recognize this button? What button is this from the X-ray?
I don't know.
So it's an adjustable loop.
Yeah. So with the fixed loop, it is very less likely that this will happen.
This is a tight rope.
Yeah.
So I don't want to defame any button, but it's a tight rope.
So what we can do is we can take the incision on the femoral
So
side.
this is on the morning rounds. So
Yeah, yeah,
This is
understood.
next day of the surgery, not same day.
Yes. So we have to counsel the patient well, definitely. And in this case, we can, pass the threads in the loop and pull it from the femoral side and put the screw. So that is one way how we
So
can
you have
manage.
already a screw inside, your graft is within the, or maybe on the mouth of the tunnel. So what will you do if you are not able to do that?
You will open it on the femoral side. You will see the button. You will still have the ends of the fiber wire of the loop, the adjustable loop.
So you have already cut it.
No, you have cut it at the skin level, but still you will have a couple of centimeters left with you, just adjacent to the button.
So you will open it on the lateral side.
Yes, you will open it on the lateral side. You will release the fascia. You will let the button sit on the bone and then tighten it again. Maybe you can or you may not put half inches, but you will have to open.
So how will you shorten the loop again? Because the threads will be maybe a 3 centimeter length. You cannot pull them and shorten them.
You can hold them medium and just request the medium and then you can just pull from it.
So if you are not able to do that?
Actually, I've done it a few times, so I know it will happen. It is possible.
Okay.
So one more doubt I understood what you are trying to bring out is, like, for example, if we have the larger reamer saturated, then what we can do? We cannot pull on the femoral side. Then we have to be ready with the tibial side also. We have to take out the screw and then do the needful.
So again, how to prevent it?
So one important thing what I would like to highlight here is this is common. So use fixed loop if possible. And nowadays there is one more eco button flex which is available in the market.
Hybrid, yes.
Yeah, hybrid loop. So it negates the complication of fixed loop and the adjustable loop both.
But it can also flip on the IT band, or it can go beyond into the muscle. How to prevent that?
So always make a marking on your fiber wire.
And put the scope in the joint and see whether, I mean, it is very flush. Once it is out of the tunnel mouth, you just flip the button and then pull it. So you will be able to see. So always put the scope.
The easiest way to prevent is like Dr. Tarun said, you mark, you know your tunnel size, you have put your depth gauge, you know the tunnel size, you mark that much from the endo button on the fiber wire. Once you have that wire distance, you know you have to just a little bit in to just flip that button, that's all. If you go deeper, then it will either go into the quadriceps or the IT band. It will go there and then it's never coming back.
Yeah,
I think
true.
You should always see, switch the scope to the medial portal. When you want to do an adjustable loop, always
so that's all
switch.
intra-articular. You cannot see button. You can see just button.
As soon as it exits the cortex, you have to flip it.
And another.
So most of the time, camera is in your hand, and your assistant is doing it.
Another thing is, if your graft slips in suddenly, means if there is a resistance and he's quite pulling it and it suddenly goes in, that is the time this normally happens. If it is a controlled pull,
So bring in your CM or IITV
then bring in your
to check
CM
it.
and see it before you tighten it.
Yeah. So
Once you pull on both
the toggling, yeah.
Once you do the toggling, you always have that bony feel that you are rubbing against the bone once you're doing the toggling.
So sometimes this bony field doesn't come.
So always be careful in those cases.
CM. So I was working at a place where there is no CM.
Then make a supralateral portal.
So I'm coming
clear
there.
from the supralateral aspect and
So
go.
that's how we do it. So it's not intra-articular, it's into the supralateral portal. So you have to clear out the supralateral plica, go beyond the muscle and see it on the lateral side, not on the intra-articular side. You have to go on the lateral cortex to see this. So it is very important whenever in certain doubt, you go onto the lateral side and see the button flipping onto the bone and sitting over the bone on the lateral cortex of the femur. So these are very common complications which we see. So we move on to the case 3. So this is something, it's kind of a complex case, I would say. It's not a complicated case or whatever. So it's a 39-year-old agriculturist. He's a recreational volleyball player and he plays sports to the village level. He had a jump landing injury on his right knee, which was 10 years back. No treatment for all these years. He was just playing and carrying on with his regular activities, whatever he wanted to do. So he continued playing, but it was a decreased intensity of the level he was playing earlier. He had instability on and off, but now he came to us with pain and instability, which was increased from past 2 years. So he had a varus alignment of the knee. There was a varus thrust gate. Medial joint line tenderness was present, and Lachman's was positive. So what all the investigations would you like to order, Dr. Siddharth?
MRI scanogram.
MRI scanogram.
One is MRI.
MRI.
Second is scanogram.
Okay. That's it.
X-ray obviously.
Yes. So it was Lachman's. It was positive, grade 2 plus 3 positive pivot. Yes. Reverse pivot was normal.
First is X-ray, then the MRI.
First is X-ray.
X-ray.
Okay, so we got this X-ray.
How much is PTS?
Sorry.
How much is posterior tibia slope you have calculated?
So I'll come on to that. So it's around 11 degrees.
Okay. And there's a medial.
So this is not ideal X-ray for calculating a posterior tibial slope.
Yeah. But there's a medial joint space loss.
Yes.
So next investigation I'll need a scanogram.
Okay. Any particularity of the scanogram you need?
Single leg standing.
It should be a monopedal stance.
Facing forward.
So before that you wanted MRI, so I got you an MRI also. So this is a medial compartment. So can you comment on this MRI? I know it's sorry for the blurry images.
So meniscal root loss with a medial cartilage lesion on the femoral side with a, this is a double PCL, looks like a double PCL sign.
Yep. So that's the lateral compartment. It's all good. Cartilage is good, meniscus is good. Some sub-signal changes on the lateral side, right?
Yeah, it looks overall okay.
Yep. So these are the coronal cuts. So there's no meniscus at all, and it's kind of
signs of meniscal medial compartment overload. There is subchondral bony edema both on the
yes.
femur and tibia.
So that's what I wanted you to comment on, because these are the signs which we should look for, and not depend on the radiologist to comment on these signs. It's very important for us to know all this. So this is your scanogram. This is a monopedal stance view scanogram. So what do you want now, sir? Okay, so Dr. Ajay Gupta, what will you offer? So I'll come on to MPT LDFA later, but what would you like to offer?
Definitely.
He's 39 years old, active, agriculturist. He wants to play once he's all right. He has come to you for a surgery, and he wants to play after the surgery.
I'll do a single stage ACLR with osteotomy.
With osteotomy?
Medial opening wedge.
Medial open wedge osteotomy on the tibial side. Dr. Tarun?
Yeah, I agree. I would also go with a single stage ACL reconstruction with the medial opening wedge.
So we have all of the same opinion. We'll do a single stage ACL with the osteotomy on the tibial side.
For tibial or femoral, we need these measurements.
So we got these measurements now.
There is some deformity on the femoral side.
Yeah, so everything in red is abnormal.
Yeah.
So MPTA is abnormal, LDFA is abnormal,
Yeah.
GLCA is abnormal.
We can even think of a DLO.
Single level.
So, yeah, I know these calculations would have been told to earlier. So what would you like to do now? Any change in plan?
Single level.
Single level osteotomy, that's it? With ACL. So single level osteotomy with ACL, everyone.
It's 92 is
We can debate whether we go ahead with a single level or double level osteotomy.
So it's MPTA is 80 and JLC is 4 degrees. So once you so we have these 4 options now. So what osteotomy? Medial opening wedge. Everyone is of opinion. Second, ACL with medial opening wedge, high tibial osteotomy. So however, I did a double level osteotomy with an ACL reconstruction. Did a lateral closing wedge on the femoral side and opening wedge on the tibial side. So what would have happened if we would have done just a single level HTO? So it's very important to have these softwares handy, because doing a single level HTO would have increased the MPTA to abnormal values, which would have increased a lot of joint pressure forces. JLCA would have been abnormal. So it's very important that to properly calculate it and do a double level osteotomy. This was his 1 month and 2 months follow-up. So we did a scanogram at 6 months. All his values were within normal limits. So that's how he's faring well at 6 months follow-up. So it's been almost 1 year now, almost 1.5 to 2 years now since we have done this. So he's back to his playing and doing his agriculture work. So we'll move on to the next case. So we have some more time, right? So this is 31 years old army man. He went ACL reconstruction and a meniscus surgery elsewhere. He didn't have any previous records, and it was done 1 year ago. He underwent a minimal rehab and just followed some random YouTube channels. He never went back to his daily physical activity or physical training because it was always giving him trouble, and he had a trivial fall which happened 1 month back. So he had pain, disability and locking which was happening from 1 month. So these were his clinical examination. His Lachman's was positive, pivot was grade 3, and there was a medial joint line tenderness also. So we had kind of this as a clinical diagnosis to start with. So what all investigations would you like to order? So he already had an ACL reconstruction which was done. Now he had most likely a graft re-tear with grade 3 pivot and a medial joint line tenderness. So what all investigations would you like to order, Dr. Tarun?
The MRI, and I'll also need a CT scan to look at the previous tunnels.
Perfect. So So we did all these investigations. In fact, we look for the scanograms as well. So lab investigations are also very important in these patients because you have to look for any component of infection if it is there. So these were the X-rays. I think looks more or less normal. Are you happy with the X-rays, sir?
Yes. There is some dilatation of the tunnel on the tibial side.
On the tibial side, perfect.
And
sorry. So this is the MRI. So there is no ACL probably, and there is a meniscus tear. So this is a fragment which is still there. You can see this fragment here roaming somewhere here. This is a fragment. So there is a bucket handle meniscus tear. Lateral root looks okay. So these are the CT scan. I'll show you the diameters of the tunnel. So now what will be your plan, sir?
So one investigation, have you measured PTS in this?
Your turn will come, sir.
Yeah.
Your turn will come, wait.
Yeah.
So what's your plan, sir? Dr. Tarun, Dr. Ajay, Dr. Tirth, you can also.
There are two things that we need to look here. One is the tunnel diameter, and another is the position of the tunnel, whether it is anatomical or non-anatomical.
So this was a tunnel somewhere here.
Yeah, so it looks slightly vertical.
Yeah, it's kind of near anatomical or maybe somewhere here.
Maybe we can find another place for the femoral tunnel. There is enough of footprint left on the femoral side for us to make a new tunnel. So probably we'll be okay on the femoral side.
So tibia tunnel is around 11 mm.
It's 11 mm. It's not too bad.
Not too bad for a single stage revision, right?
For a single stage revision, yes. We'll take a cutoff of 14 or 15 millimeters for a.
So femur is also around 8 mm. So we have probably, if we are intending to use these tunnels,
we can
use
the same tunnel on the femoral side.
So what graft are you opting to choose now?
Probably he had a hamstring.
He had a hamstring graft.
So we can use a Quadriceps or a Peroneus longus graft.
Okay.
I'll prefer BTB. Always on all cases I do BTB.
All revision BTB. Just a BTB graft and meniscus probably will.
Meniscus we have to prepare, and we should also take the long leg scanograms to see the how much is the varus and the slope obviously.
So when I saw this was the slope. Dr. Siddharth, is it normal? 73, almost 16 degrees posterior tibial slope.
Anything more than 13 degrees is uncomfortable, and more than 15 you have to definitely correct.
So it's 16. So what's your plan now?
These tunnels look good. So as Dr. Tarun said, we'll use the same tunnels.
So MPT LDFA is normal. Okay.
Yeah.
Happy with this?
Yeah. Graft of choice for me would be BTB with a ACWO.
So how much closure will you do?
That I have to calculate how much closure, but I will aim for a PTS of around 6 to 8.
Okay. So it's very important to look at the lateral radiograph, to look at the posterior tibial slope in the vision scenarios. So whenever anything more than 12, I would say, there are a lot of stresses on the graft or the reconstructed ACL or on a normal ACL as well, if the tibial slope is more than 12 degrees. So we were looking at a failed ACL which has a near anatomical kind of tunnel, no tunnel dilatation. There was a meniscus here and increased PTS. So we have already answered this. So I did a revision ACL along with the ACWO with meniscus balancing and lateral extra-articular tenodesis with a modified Ias technique. And this was a slope which we got after the surgery. It was almost to around 6 degrees, which was normal.
Which graft did you use?
Sorry?
Graft?
I think I used opposite hamstrings.
Opposite hamstring.
So this was his 9 months follow-up. He was back to running, jogging, and it's more than 2 years now he's been back to his daily activities. So moving on to the last case. So 30 years old police woman, she had an ACL which was done elsewhere with a PL autograft, which was 1 year ago. She had a trivial twist at 1 month and she complained of instability and pain. Lachman's was negative, there was medial joint line tenderness. So these were the X-rays, Dr. Siddharth. So do you think X-rays are normal?
Femoral tunnel is vertical.
Yes, yes. Yep, it looks slightly more medial. So looks like a non-anatomical femoral tunnel. So when I got his MRI, so we looked for the scanograms. I don't have the scanograms with me for this patient, but you have to believe me, those were normal. So this was the MRI. So tunnel looked fairly abnormal. It's not at anatomical place. So we got the CT also. So looked very juicy case for revision ACL, probably. So these were the tunnel sizes, not dilated much. So tunnel was non-anatomical. So my plan was to do diagnostic arthroscopy, do a revision ACL, maybe a femoral tunnel at more anatomical position and use the same tibial tunnel and do a BTB autograft. All agree with me?
So in that, I think it is a partially anatomical tunnel in
Yes,
the
it's
first
a near
place.
anatomical tunnel.
Maybe it might land up into a two-stage procedure rather than a single stage. Maybe, I don't know. We can try creating a femoral
CT
tunnel.
scan, I was very much taken away that it's all a normal, it's a normal tunnel. It's not at a right place. There's a lot of space for making a new tunnel.
Female patient.
Female patient.
Short stature?
Not short, she's a police woman, very active.
The CT scan cuts that you have showed, at the level of notch, any of these cuts, I am not sure whether these are at the level of notch.
So we got a 3D reconstruction
Let's see
also.
what you have in arthroscopy. Let's see, go ahead.
So I have planned my case. I want to do a single stage BTB autograft reconstruction using the same tunnels, most likely a new femoral tunnel. So this was the diagnostic arthroscopy. There was a torn ACL. So we divided it off. We ate all the graft. We were hungry to look for a place for our new tunnel and do a single stage, primarily kind of ACL. So we were tracing the old tunnel. So to my surprise, it was near anatomical. So this was the amount of bone which we had to make a new tunnel. So now I was taken away, to my surprise, what to do now. So this is an old tunnel. This is a place where I would intend to make my new tunnel for my BTB graft. And now if I try to do it, there can be a lot of problems.
I hope you have not harvested the graft by now.
No, it was always a diagnostic round.
How much is this area?
Yep, so that was a questionable. So I did put in my ruler, but I didn't have that video clipping with me. So this was around 8 mm. So what to do now?
If you are committed to a single stage, then it's different. Otherwise,
I have committed to my patient. We'll go in, do your surgery. I was very positive in the OPD with all the high hopes. Just single surgery and you will be out.
See, in case you want to still finish off it at a single stage, you can obliterate the superior tunnel with a screw, and the partially overlapping tunnel on the lower side may still be used. Definitely it's not the ideal option. Ideal is to do a two-stage and fill up this tunnel.
So CT can be misleading at times.
Yeah. Two stage is better.
So
8 mm bone is
2-stage means I have not prepared the bone graft site also. I have not explained to the patient, and patient is under GA. We don't have a bone graft site which has been prepared.
Fill this, you can try to do eccentric tunnel and obliterate the above one with a large size biocomposite screw. That is what is the only way to get get out.
So, but still, probably if I try to drill in my tunnel from here, so somewhere here, so my tunnel angle will go almost, and it may coalesce or may not coalesce, may or may not, and it will be very
This
horizontal
is
kind
very
of.
vertical. The lateral
This is
is not
vertical.
going-
This will be very. This will be. So this
Laterally
can.
it is not going to trouble you. It is only intra-articular the issue is. So in case you are able to find space intra-articular, you will be clear. I
So,
think
we'll do
you will be able to manage with a single tunnel in this case. हो जाएगा manage. ज़्यादा हो जाएगा 8 mm की tunnel इसमें.
8 mm will, it's a revision scenario. I will not land up with 8 mm. I will definitely try something more than 9 along with an LED. So I had planned of doing a BTB. With this amount of bone, probably I cannot do BTB.
BTB तो नहीं हो सकता.
So quadriceps, again, Peroneus longus was already been used by my colleague.
You can attempt an over the top.
Over the top.
This is the only way out, I think.
So, okay. So what, so I changed my plan here. So we did the tunnel preparation. So this was the marking which I made for my initial tunnel, which will be around 4.5 mm. So I'll just move on to what we did. We made a tunnel here with a 4.5 reamer. And we went and saw it from the anteromedial portal, and there was no coalition. And on the tibial side also. So once we reamed it, so there was bone wall all around in the tibial tunnel as well. And I used a synthetic graft for this because you don't have to make a bigger tunnel. So you just have to make 4.5 mm tunnel. I used a synthetic graft and just made it look like a primary ACL. So once the button flip onto the lateral femoral cortex, we pulled in the graft. It's a synthetic, and it, over a short period of time, it has shown good results. And put an interference screw on the tibial side along with doing a modified Lemaire's LET. 4.5. 4.5 on both the sides. So I was very skeptical in following up this patient. So we did a 9-month follow-up MRI of this patient, and we can see the graft which has, it's still taut. You can see the screw here. There is no tunnel dilatation, and we can see some fibers growing over it. So hopefully this will be giving a promising result. Thank you. Thank you for being with me.
Thank you, Dr. ID, for such wonderful cases. Now we'll start with the meniscus session, for which I'll call upon Dr. Manik Sehgal, Dr. Ajrawat sir, Dr. KP Jaidev sir, Dr. Nitish and Dr. Ambuj. And let's start the meniscus session with all about meniscus and how to visualize all parts by Dr. Kevin Khatri from Faridkot.
लैपटॉप है नहीं सर वो कॉपी हैवी है थोड़ी फाइल
Very good afternoon to all. And I thank Dr. Varun for inviting me and be part of this conference. So we'll start with the how to visualize arthroscopically. Why this topic is important? Because if we do not see what we repair, we lead to failures, and the problem area is only the posterior part of the knee, because whatever you see is from the anterior and you miss on the posterior aspect. In a standard arthroscopy, you see the suprapatellar pouch, medial gutter, compartment, notch, and the lateral compartment. But in this sequence, the posterior components all are missing. The horn, the root, the ramp lesions which we are focusing on is all missed in these things. So the first step, if you want to visualize a menisci, is have a good anterolateral and anteromedial portals. The positioning is very important. If you put it too proximal, you will looking down. Too close to joint line, you are damaging to the anterior horn of the menisci in both sides. So as we arthroscopic surgeons are trained to put just single portal, create a one portal, and then create all the accessory portals through with the use of spine needles, so that you indent to create the portal at the level and at the junction where you exactly want your instruments to be in. And with good anteromedial and anterolateral portal, the anterior part of both and the middle part of both the menisci can be easily and well seen and can be treated upon. However, the challenge comes when it comes to the posterior horns, especially the posterior middle horn of the medial meniscus, due to three anatomical constraints: medial femoral condyle, which is larger, the tight middle MCL, and you have a upsloping tibial eminence. So when we are talking of all the posterior lesions, the ramp lesions are very common these days. We know we are just focusing on those lesions, and we tend to miss on these lesions if we do not see and intend to see those lesions. We all know this a pivot shift, unlocking the pivot shift. You keep the knee in 20-degree flexion with a valgus stress, maintain this position, and externally rotate the foot. With this, you can see from first image to second image, the visualization improves markedly. And then comes the meniscus delivery maneuver. You apply valgus stress, keeping the knee in flexion, while your assistants try to push it from the back, just medial to the semimembranous, and you see the visualization in the field. And this is one of the very commonly used method during meniscal repair. You see the pie crusting technique. Again, 20-degree flexion, valgus stress, and you see with 18-gauge needle, you put 1 to 2 centimeter proximal to joint line, you just pie crust it, and then just a feeling of a giveaway will help you determine, and you can easily then see the posterior horn or the posterior part of the meniscal easily. In this, if you see, in the first part, the probe was barely going. And when you just do the pie crusting, you can easily put the probe and it can move around just by a simple pie crusting or needling the MCL. If you are looking for the root lesion repair, then you have sometimes, very rarely, remove the medial tibial eminence. If you can see in the red, it is showing the medial tibial eminence, and after you can remove it with the burr or a cautery, then you can see the posterior horn of the middle meniscus very well. And if you want a greater area to work with, then you can go the reverse notchplasty, in which you remove the posterior middle part, the non-weight bearing part of the femoral condyle. Though I have not done it, but rarely it might be done you might require it, you should know it, so that in case the visualization is not adequately from the anterior portals. Another good technique is Gilchrist to view. You put a stylus or a probe through the condyles and between the ligament, because this is for both the medial and the lateral meniscus, posterior horns. So you put through the menisci and the condyles, then you slide over the trocar, and then finally put the scope. Because if you try to push through between the ligament and the condyles to reach the posterior condyle, sometimes you damage the scope itself. So using this technique, you can just protect your scopes. And this recife maneuver is one of the other technique in which you put the scope in the posterior medial compartment, flex the knee in the 30-degree, apply valgus stress, internally rotate the tibia, and just apply a posterior medial pressure over the meniscus so you can see through the window. Here one person or assistant or you yourself is pushing through it and then seeing the posterior horn of it. I'll just skip this slide and come to the posterior horn of the lateral meniscus. This we all know, we create a figure of 4 position and which will widen the compartment, and you can see the lateral horn of the meniscus. Intercondylar notch, in the similar, we are doing the posterior medial compartment, we can do in the posterior lateral compartment. If everything fails, then you can opt for the portals, either the posterior lateral portal or the posterior middle portal, and create under vision using same spinal needles. So another way is to create a transseptal portal. You create the posterior lateral portal, posterior middle portal, and then progress through the septum and creating a through and through pathway across the posterior horn of the middle meniscus, and you can just see through the posterior horn of the lateral meniscus also through this transseptal portal. So you systematically progress. You create good AM-AN portals, anteromedial anterolateral portals with the needles, then apply valgus external rotation, do the recife maneuver, meniscal deliveries. If it fails, then move to the pie crusting. If you still feels tight, its ligaments is not enough space is not created, you remove the eminence or do the reverse notchplasty, and then if required, you can go for the posterior middle or posterior lateral portal. So the surgery, as we know, is you cannot repair what you cannot see in these things. And the posterior compartment is one of the most important compartment, especially for your repair of your ramp lesions. And thank you very much.
Now I invite Dr. Aman to speak on meniscectomy and its indications.
A very good afternoon to everyone. I'll be speaking on meniscectomy, indication, where, when, what. Physiology of meniscus, we already know, so I'll be skipping this. We go to the blood supply of meniscus. As we all know, the meniscus is divided into red-red zone, the red-white zone, and the white-white zone. The peripheral 10 to 30% of the meniscus is supplied through geniculate vessels, and the inner 2/3 is nourished by synovial fluid. The peripheral 25% has high healing potential, whereas the inner tiers have very low healing potential, often requiring surgical resections. The meniscus roots are critical anchor points. They attach the posterior horn to the meniscus to the tibial plateau. An avulsed meniscal root is comparable to a total meniscectomy. This presents as a rapid progression of osteoarthritis and contributors to subcondylar insufficiencies, fractures of the knee. Pathology. Generally, the meniscus tears are categorized into vertical tears and horizontal tears. The vertical tears are longitudinal tears, the radial tears, and oblique tears. Here, we can see the horizontal tear. It is showing separation of the meniscus into the upper and the lower halves. This is a longitudinal tear. This is a radial tear involving the free edge, and it is perpendicular to the long axis of the meniscus. These are the flap tears, which includes the buccal handle tear, the intercondylar fragments, and the horizontal flaps. The image showing a buccal handle tear. The meniscal lesions are frequently associated with anterior cruciate ligament injuries, about 50 to 65%. The most common injury is to the middle meniscus. The longitudinal tear on the posterior edge of the middle meniscus, accompanied by ACL, known as ramp lesion, should not be missed. The important consideration about meniscal fragments is that the middle meniscus is much more common to displace. It displaces into the intercondylar notch, particularly the posterior aspects, the middle parameniscal recesses, and the lateral fragment migrates into intercondylar notch and lateral recess. The classifications of signs and symptoms of meniscus tears according to British Association of Surgery of Knee. It can broadly be classified into meniscal symptoms, possible meniscal symptoms, and arthritic symptoms. We know that in a meniscal symptom, lock knee, when a sudden mechanical block to flexion or extension, locking, that is an intermittent block which returns to normal after unlocking, catching, the sensation of something giving away, and tenderness, palpable meniscal tissue. These are strongly suggestive of treatable meniscal lesions. The possible meniscal lesions, episodic pains, intermediate knee swelling, knee effusions, activity avoidance, squatting pain, clicking, meniscal provocation test positive, joint line tenderness positive, posteromedial tenderness. These are suggestive of treatable meniscal lesions. And arthritic changes, these are inactive pains, crepitus, bony enlargement, bony tenderness, aching pains, suggestive of osteoarthritis. So, the management of meniscal tears. Obviously, we start with conservative, RICE protocol, intra-articular corticosteroid injections. The non-operative treatment is to limit symptoms from the tear. The surgical management. Meniscectomy can be divided basically into complete and total or partial. Meniscal repair inside, outside in, all inside, and meniscus allograft transplants. Complete meniscectomy is an obsolete now, as we all know that it decreases the intra-articular contact area by about 75%, increases pressure by 235%. In long-term studies, it has shown that radiographic evidence of osteoarthritis increased by 14%. It is shown that the risk of developing osteoarthritis after lateral meniscectomy is greater than middle side. Given the drastic changes in the biomechanics of knee after total meniscectomy, much interest is focused on benefits of preserving as much meniscus as possible. What is the indication of partial meniscectomy? The horizontal tears, the degenerative tears, or traumatic tears in athletes after failure of meniscal repair, unstable flaps, longitudinal vertical tears in the white zone, buccal handle tears affecting non-vascular zones. The degenerative changes appear, inability to reduce the tear, radial tears, complex tears, irreparable root tears, or failed attempts at meniscal repairs. So, what are the guidelines? When we see a meniscal tear, see if there's a degenerative disease. If it is, then we have to go for a joint replacement or physiotherapy. If no, is it symptomatic? Is it displaced? If yes, we have to consider arthroscopy. Whether the displacement or the tear is in the red zone, is it reducible? If the patient age is less than 60, go for repair. Otherwise, meniscectomy. If it's in the red-white zone, patient age less than 40, reducible, try repair. If not, meniscectomy. Any tear in the white zone, meniscectomy comes first. The classification of meniscal lesions according to BAS guidelines, they can be target, possible target, and no target. Target lesions are meniscal which require surgery. These are bucket handle tears, displaced meniscal tears, and meniscal root failures. Possible targets are partial tears, horizontal tears, complex meniscal tears. No targets, contour abnormalities, a meniscus with abnormal edges. So what are the BAS guidelines? After an integrated assessment, we go for a common clinical look. If we come with a lock knee, we have to go for an urgent arthroscopic meniscal surgery. In acute injury with meniscal target positive, we have to consider meniscal repair. In meniscal target and corresponding signs, go for, if the symptoms are less than 3 months, we have to go for non-operative treatment and then reassess. If more than 3 months, you have to consider non-urgent arthroscopic partial meniscectomy. The possible meniscal target, go for non-operative treatment first. Advanced structural osteoarthritis, no arthroscopy. The clinical cases example of the same, case 1 week onset, lock knee, buckle handle tear, go for urgent arthroscopic meniscal repair. Case 2, 6-month-old, signs of arthritis, osteoarthritis, no arthroscopy required. Case 3, 1-week-old, twisting injury, meniscal, longitudinal tear, consider meniscal repair. Case 4, onset 1 month ago, meniscal tear, displaced parrot beak, go for non-operative treatment. The same case comes 4 months ago, still signs positive, considered non-urgent arthroscopic partial meniscectomy. Case 6, 6 months onset, possible meniscal, complex posterior tear, go for non-operative treatment. What are the guidelines for a meniscectomy? Remove with probe all mobile fragments that are pulled past an imaging line across the inner margin of the meniscus to the center of the joint. Trim the contours to prevent further tearing. It is not necessary to obtain a perfectly smooth rim, but remodeling will take 6 to 9 months. Determine the extent of resection, assessing the mobility and texture of the remaining meniscus. A normal meniscus is usually firm, whereas damage will be soft and mushy. It is recommended to preserve the portion where damage is uncertain. Use manual instruments which give a tactical feedback. The debris removal or trimming by motorized equipments. Protect the meniscoscapular junction to preserve the load transmission properties of remaining rim. We will not go into the detail of every resection. Results after partial meniscectomy. Short-term results of partial meniscectomy are excellent. But when we go for a long-term study of 136 patients, 8.5 years follow-up, it has shown reoperation rates of 22.8% and 53% of patients had osteoarthritic changes as compared to 22% in unaffected knees. A 147 athletic study at 4.5 and 14 years, it has shown that first follow-up has half asymptomatic patient, but this reduces to 1/3 in the final follow-up. The radiological changes rose from 40 to 89%. What are the factors that influence the risk developing arthritis followed by partial meniscectomy? Compartment involved, greater risk with lateral meniscus. Volume of resection, greater the risk with larger resection. Orientation of tear, greater risk with radial tears. Associated condition, greater risk with pre-existing condyle damage, greater risk with ACL insufficiencies. Knee alignment, varus and valgus alignments. Body habitus, greater BMI, greater risk. Patient age, greater risk above 40 years of age. Activity level, greater risk with lower pre-operative activity level. So, what do you conclude? Yes, preserving meniscus is extremely crucial. But in today's world of meniscal repair, we know that all meniscus lesions cannot be repaired. Partial meniscectomy holds a crucial role in treating various meniscus pathology. We must choose what is best for our patients with all the possible guidelines available. Thank you so much.
So thank you for the wonderful talk, Dr. Aman. So next I would like to call Dr. Karan Rajpal for meniscus repair and when to do it.
Good afternoon, everyone. Thank you so much for the organizers, Varun sir, Senior Joshi sir, for letting me be on this stage. It's a great opportunity. Starting with a simple question, a case scenario. What would everyone do here? A 25-year-old male with a bucket handle tear, locked knee, and MRI shows a red-white zone tear. So what do? Do you repair it, trim it, or leave it? Let's see a show of hands. Who would repair it? No one? So you would repair it. Anyone who would trim it? And I suppose no one's going to leave it. Fine. So I'm Dr. Karan Rajpal, here to talk about meniscus repair, when to do. A little overlap between me and the previous Dr. Aman. So hopefully I don't bore you. We'll be talking about the anatomy, classification, and the indications of repair. Starting with the anatomy, basic sciences. Type 1 collagen is the most important and most 90% of the meniscus. Circumferentially placed fibrils with radial tie rods. Resistant hoop stress and the shear forces. Histology says the same. Tissue bulk, circumferential fibers, and the surface ones are the radial tie rods. The functions everyone knows: load transmission, shock absorption, lubrication and nutrition, and secondary stabilization. So why do we actually repair it? Because we need to know how does it actually work. So meniscus helps to increase the contact surface area, thus distributing the load. So if we do an tire truck analogy, increasing the contact surface area helps to distribute the load. If we remove that or decrease the contact surface area, remove the meniscus, that's why the joint pressure increases. And thus the hoops test, which is played about by the meniscus, this is how it helps. And if the meniscus tear is there, the joint load increases. The most important classification which we follow for repair is the Arthroscopy and the Warren classification. So what is it? The peripheral 1/3, that is the most vascular structure, less than 3 mm, the red zone. The middle 3 to 5 mm, red-white zone. And the inner more than 5 mm, the white zone, the least vascular structure. How we grade it on the MRI? The grade 1 and grade 2, that's where there is no extension of the tear into the surfaces, either of them. That's where we can do the non-surgical intervention. And if it goes to the surfaces, either ones or both, that's when we repair it. Fun fact, first human meniscus repair was done in 1885, and it was called a tedious process. And then it was thought of a vestigial organ. That's why meniscectomy started to be a surgery of choice. Starting with the morphologies, vertical, longitudinal, or the peripheral, radial tears, L-mot, lateral meniscus, oblique radial tears, oblique or flap tears, horizontal cleavage tears, root tears, ramp lesions. The analog lateral ones are zip lesions, degenerative and complex tears. Starting with the vertical, that's most commonly the bucket handle, if it is a longitudinal one and going more than 30–40%. It is usually displaced into the joint. Chronic tears have additional radial components and they need to be repaired until unless very chronic. Peripheral tears, these are the most important ones and heal the best. They are the tears which can easily be repaired too. The radial tears have low success but are most important to be repaired because the circumferential fibers are lost. And that's why there is poor load transmission, almost equivalent to a meniscectomy. That posterior horn origin tears heal better than the middle third. So what do we do for it? A hashtag. So because the circumferential fibers are lost, we put in 2 vertical sutures on either sides of the tear that act as the ripstop, and then we put in the longitudinal sutures beyond the ripstops, thus preventing the cut through. L-mot, these are the varieties, the classification. A recent one, but very important, needs to be repaired. Oblique flap tears are the ones which usually are complex, and these are usually excised because mostly in the white zone. Horizontal cleavage tears usually previously thought were difficult to repair, did not have good outcomes, but now we repair them. We can cut off the unstable leaf, but repair the rest of the meniscus. We can use fibrin clots in between for augmentation, gives much better results. These are a few studies to say that. Root tears, the roots are the primary load transmitting structures. If there's a tear, it alters the biomechanics, increases the peak contract pressure, almost equal to a meniscectomy, and thus leading to early arthritic changes. This is the Laprage classification of a root tear. The ramp lesion, this is what the ramp is formed, the meniscotibial and the meniscocapsular junction. These need to be repaired because this can cause rotatory instability. This is the new classification, the Thanot and the Grief classification. And the latest one with Laprade and Dr. Sachin Tapasvi has given the latest classification in the last year. Complex degenerative tears, these are usually in the white zone or not repairable. So these are the studies which show that meniscus repair is the way to go, gives good results and prevents early arthritis. Do all tears need intervention? Usually not. Stable tears, degenerative tears, or asymptomatic tears, which may have McMurray's negative but a clicking on it. Stable tears defined as partial thickness less than half the height, full thickness oblique tears less than 7 to 10 mm, or the inner portion less than 3 mm of displacement. Radial tears less than 5 mm, that is in the white zone. General indications of repair concurrent with the ligament instability, vertical longitudinal tears less than 4 centimeter length, rim width less than 4 mm, or young patient. You have to repair all these. Other surgical indications, the age, less than 30, you aggressively repair it. More than 50, less likely, but still consider repair first. 30 to 50 depends on the surgeon, but yes, I still say repair it. Tear patterns which usually are repaired, the green ones, yes. Red ones, query, but then radial and horizontal cleavage tears now are a must repair too. This is a meniscus tear in young athlete, and how helpful is the arthroscopic repair? Poor candidates, more than 4 centimeter, degenerative tears, complex tears, avascular zone tears, half thickness tears, or incompatible patients or non-compliant patients. What does a meniscectomy do? It is short-term relief, yes, but it is long-term arthritis and early arthritis. Why? Because the contact pressures really increase. And if you have to choose one compartment, lateral has to be repaired because convex on convex surface area of both the condyles and the contact pressures are already high. So you want to repair that if you have a choice. These are a few suturing techniques. We can probably leave them. So the takeaway messages: consider meniscus repair whenever possible. Keep options always open for repair. Identification of the correct patient is the first step. If post-operative management is considered, bear caution. Counsel the patient appropriately. The literature is still class 4, so we have that problem. Thank you so much.
Thank you, Dr. Karan, for the wonderful talk on meniscus repair. Now, I call upon Dr. Lovepreet Saini for his talk on rehabilitation protocols for ACL and meniscus.
Very good afternoon, organizers. I am Dr. Lovepreet Saini, and my topic of discussion is rehabilitation protocols for ACL and meniscus reconstructions. So we have divided rehab into 4 phases: phase 1, phase 2, phase 3, and phase 4. And sometimes we can say it's level 1, level 2, level 3, and level 4. The first phase starts from 0 to 4 weeks. And our main goal is to protect any graft and eliminate the effusions. There are some exercises. After any surgery, we can start with quadriceps sets. Isometric quadriceps will be there. So for that, we can put one towel roll under the knee and ask the patient to press for 5 seconds and relax. 15 repetitions will be there. And second is patellar mobilization, superior, inferior, and lateral glides to prevent any infrapatellar contractures. And the third is ankle pump exercises for DVT. To prevent any DVT, ankle foot exercise will be there. And the fourth is heel slides. That limits to 90 degree of flexions to protect any menisci or ACL repair. So इसमें ऐसा होता है, सपोज पेशेंट हमारे पास फर्स्ट डे आया, हम फर्स्ट डे ही उसको 90 डिग्री पे नहीं लेके जाएंगे. फर्स्ट एंड सेकंड वीक हमारी ट्राई यही रहती है कि हम 0 to 30 डिग्री और 0 to 60 डिग्री तक करवाएं, बिकॉज एवरी पेशेंट इज़ डिफरेंट, एवरी पेशेंट्स रेंज ऑफ मोशन इज़ डिफरेंट. सो थर्ड एंड फोर्थ वीक में हम क्या करते हैं, उसको 60 to लेके 90 डिग्री तक फ्लेक्शन में लेके जाते हैं, बट दैट विल डिपेंड अपॉन पेशेंट टू पेशेंट. And the next is, in first phase, the straight leg raise, SLR exercise will be there. So SLR में हम क्या करते हैं, ब्रेस के साथ पेशेंट को बोलते हैं अपनी लेग को ऊपर उठाओ, because in case there is any extension leg is there, without ब्रेस उठाएंगे तो इंजरी साइड के ऊपर लोड आएगा. So this is the first phase of rehabilitation. Then there is phase 2. phase 2 में हम क्या करते हैं, वेट बेरिंग एक्सरसाइज करते हैं, अर्ली स्ट्रेंथनिंग एक्सरसाइज स्टार्ट कर देते हैं. इसमें हमारा जो मेन गोल रहता है, हम गेट पैटर्न को नॉर्मलाइज करते हैं एंड जो ब्रेस है उसको रिमूव करते हैं. फुल वेट बेरिंग एक्सरसाइज फेज़ 2 में हम स्टार्ट करवा देते हैं. सो जो फेज़ 1 में हमने एक्सरसाइज सारी स्टार्ट की थी वो तो कंटिन्यू रहेगी, और उसमें नेक्स्ट जो हम स्टार्ट करते हैं फेज़ 2 में हम मिनी स्क्वाट्स ऐड कर सकते हैं. सो मिनी स्क्वाट में क्या होता है, 0 to 60 डिग्री तक हम मिनी स्क्वाट करते हैं, बट 5th and 6th वीक हम पेशेंट को ये बोलते हैं 30 to 45 डिग्री तक ही मिनी स्क्वाट करो. अगर पेशेंट को कोई स्वेलिंग नहीं है, कोई पेन नहीं होती, देन प्रोग्रेस टू हम 60 डिग्री तक उसको लेके जा सकते हैं. एंड नेक्स्ट सेकंड फेज में हम टर्मिनल नी एक्सटेंशन पे काम करते हैं. विद द हेल्प ऑफ थेराबैंड हम पेशेंट को बोलते हैं सो इसमें क्या होता है कि जो हमारा 5 to 10 डिग्री का एक्सटेंशन लैग है वो भी निकल जाता है. देन नेक्स्ट सेकंड फेज में हम पेशेंट को स्टेप अप्स एंड स्टेप डाउन कंट्रोल इसेंट्रिक लोडिंग टू बिगिन लोडिंग द ग्राफ्ट. तो उसमें क्या होता है, इनिशियली हम 3 to 4 इंच का कोई भी स्टूल ले लेंगे, जहाँ डंबल प्लेट ले लेंगे, पेशेंट को बोलेंगे उसके ऊपर अपना पैर को लिफ्ट करने की कोशिश करो, ओनली 3 to 4 इंच. अगर पेशेंट वेयर करता है तो फिर उसके बाद हम उसको प्रोग्रेस कर सकते हैं. उसके बाद लेटरल स्टेप डाउन करना है, फॉरवर्ड स्टेप डाउन करना है, एंड एलिवेटेड लेटरल स्टेप डाउन करेंगे एज शोन इन पिक्चर. फर्स्ट स्टेप अप, सेकंड लेटरल स्टेप अप, थर्ड फॉरवर्ड स्टेप डाउन, एंड लास्ट इज एलिवेटेड स्टेप डाउन. एंड इन सेकंड फेज वी कैन स्टार्ट बाय साइकिलिंग आल्सो. इनिशियली वी कैन स्टार्ट विद हाई सीट साइकिल, सो ग्राफ्ट के ऊपर ज़्यादा लोड ना आए, एंड स्लोली एंड प्रोग्रेसिवली हम धीरे धीरे उसको नीचे पे ले जा सकते हैं. देन फेज 3, दिस इज न्यूरोमस्कुलर कंट्रोल. दिस इज वेरी इंपॉर्टेंट फेज. तो स्टेज 3 में क्या करना होता है, फर्स्ट स्टेज 2 वाली सारी एक्सरसाइज चलती रहेगी, उसको धीरे धीरे प्रोग्रेस करते जाना है, और उसमें स्टेज 3 वाली एक्सरसाइज हम ऐड कर देंगे. इसमें क्या होता है, हम सिंगल लेग स्टैंडिंग पे ज़्यादा फोकस करते हैं और स्प्लिट स्क्वाट्स के ऊपर ज़्यादा फोकस करते हैं. सिंगल लेग प्रेस, पेशेंट को बोलेंगे लेट जाओ, जिम बॉल को प्रेस करो, होल्ड फॉर 5 सेकेंड, देन रिलैक्स, होल्ड फॉर 5 सेकेंड, देन रिलैक्स. मिनिमम 15 रेपिटेशन विल बी देयर. देन नेक्स्ट इज बुल्गारियन स्प्लिट स्क्वाट्स. सो एडवांस लोडिंग फॉर ग्लूट एंड क्वाड्स. देन रोमानियन डेड लिफ्ट्स. सो मोस्टली कहा जाता है कि हैमस्ट्रिंग ग्राफ्ट के बाद हमको ये एक्सरसाइज करनी चाहिए, बट देयर आर सो मैनी रिसर्चेस जो बोलते हैं चाहे कोई भी ग्राफ्ट हो तो ये ज़रूरी होता है. हमको सिर्फ पोस्टीरियर स्टेबिलिटी नहीं करनी है, हमको इंटीरियर, पोस्टीरियर एंड लेटरल स्टेबिलिटी हर किसी के ऊपर वर्क करना है. तो ये हम वर्क स्टार्ट कर देते हैं लेवल 3 पे. ग्रेट. सो नेक्स्ट इज़ वेरी इंपॉर्टेंट प्रोप्रियोसेप्टिव ड्रिल्स. इसमें क्या करते हैं, हम फॉर्म पैड ले लेते हैं, पेशेंट को उसके ऊपर 1 लेग स्टैंडिंग करवा के फॉरवर्ड, बैकवर्ड एंड लेटरल मूवमेंट करने के लिए बोलते हैं. ये सेम एक्सरसाइज हम बाजू बॉल के ऊपर भी करते हैं, और प्रोप्रियोसेप्टिव ट्रेनिंग में हम क्या करते हैं, बाजू बॉल के ऊपर पेशेंट 1 लेग पे खड़ा हो जाएगा, कैच द बॉल एंड थ्रो, कैच द बॉल एंड थ्रो. देन लास्ट इज फेज 4, रिटर्न टू स्पोर्ट्स. ये हमारा मोस्ट प्रोबेबली 5th मंथ ऑनवर्ड स्टार्ट हो जाता है. तो इसमें हमने पावर एक्सरसाइज करनी होती है, एजिलिटी एक्सरसाइज करती है, स्पोर्ट्स स्पेसिफिक रिएक्टिव कंट्रोल पे काम करना होता है. तो इस पे इम्पैक्ट लोडिंग एंड प्लायोमेट्रिक्स के ऊपर काम करना होता है. जैसे कि वर्टिकल लैंडिंग कैसे करनी है, फ्रॉम जंप करना है, वर्टिकल लैंडिंग कैसे करनी है, फ्रॉम लेवल 1 टू वी कैन प्रोग्रेस एंड ऑफ लोडिंग. Then next is agility and change of direction. इसमें क्या करना होता है, पेशेंट एक्टिविटी करेगा, जैसे ही विसल बजेगी और पेशेंट अपनी डायरेक्शन को चेंज कर सकता है. देन क्रॉसओवर एंड लेटरल सफरर. स्पोर्ट्स स्पेसिफिक रिएक्टिव ड्रिल्स, इसमें क्या होता है, पेशेंट एक्सलरेट करेगा देन डिसलरेट करेगा, एक्सलरेट करेगा देन डिसलरेट करेगा जी. मोस्टली हर एथलीट जो भी आफ्टर ACL या मेनिस्कल रिपेयर के बाद स्प्रिंटिंग तो कर लेता है, बट स्टॉपिंग के टाइम पे उसको प्रॉब्लम होती है. जैसे ही वो स्टॉप करता है, पेन, वो बोलेगा हाँ मेरे यहाँ पे पेन होती है. तो उस केस में स्पोर्ट्स स्पेसिफिक रिएक्टिव ड्रिल्स के ऊपर काम करना होता है. अल्टीमेट हमारा एम यही रहता है, अगर वो एथलीट है तो बैक टू अपनी नॉर्मल गेम के ऊपर जाए, अगर वो नॉर्मल पर्सन है तो वो अपनी नॉर्मल ADL एक्टिविटी कर ले. थैंक यू.
Thanks, Dr. Lavpreet. That was a wonderful demonstration of how we should go and rehab our athletes in particular. We will be starting with the next session, and yeah, I was looking for you.
So I thank Dr. Daya ma'am and Daya sir, Jasmine ma'am, member of Punjab Medical Council, for coming to our conference. So I'll be talking about outside in repair, why it is called the Dhurandhar of meniscus repair. So why repair? It is already been covered by Dr. Karan. I went not to repair, beautifully covered by Dr. Aman. So there are changing concepts. Earlier we used to write letters, then come cordless phones, then mobiles. Same with the cars, and same with our knees also. Earlier meniscus were considered as a useless muscle which was present intra-articularly. But now with changing trends, it is learned that meniscus has a good role in biomechanical stability, in congruence, in lubrication, nutrition, and most importantly, the proprioception of the knee. So with changing concepts, we also learned that whenever the meniscus is excised, it will definitely lead to osteoarthritis of the knee, which will be seen in the radiographs. How meniscus is helpful, we are learning since morning. Dr. Hakam has beautifully explained biomechanics of meniscus, that how it helps in distributing the axial stress via hoop stress mechanism. So when and where to repair the meniscus? By outside in technique, it is either it should be anterior horn or the body of the meniscus, either it can be medial or lateral. Second, white zone, pink zone, red zone. Most common repairable thing is the red zone, and white zone one should not touch to repair. Then is the type. So there are three things which decide whether meniscus has to be repaired or it has to be excised. It is the geography of the meniscus, is the type of the meniscus, and third is the vascularity. MRI remains the gold standard, the bow sign, which shows that congruency of the meniscus is maintained or not, or extrusion of meniscus happens or not. Dr. Pollard taught us in the morning when to operate the meniscus. When patient is having severe pain, you did everything, you tried your conservative management, but it failed. Patient is having McMurray's test positive, pinch test positive, go for meniscus repair or meniscus surgery. Indications of repair, it should be acute, less than 8 weeks, and verticals, longitudinal tear, you should repair, but don't touch complex tears. So, first thing when you go for meniscus repair is you do pie crusting. It is just pinching or making the MCL loose so that you can visualize medial compartment very well. So why outside in? Why it is called the Dhurandhar of meniscus repair? First thing, it is very cheap to do, easily reproducible, and very less equipment needed, no expensive implant needed to repair that. Then it can be done very easily and it is very fast to do that. But difficulty in this is that aiming the right spot to repair is very complex to do that. Second thing is whenever we are puncturing the meniscus or whenever we are taking bite for the meniscus, that causes iatrogenic trauma either to the cartilage or to the meniscus. So what all you need to do outside in? You need epidural or spinal needles. You need PDS suture. This is monofilament. Then this is very important and very easy thing. This is called chia wire. And fiber wire, fiber tape, whatever you need, you can do that. So this is the animation, how it is done. Then I'll show you the cases. After diagnostic scopy, identify the tear. Put a 118 gauge needle through the meniscus. Put one PDS suture through a loop in that needle. Take another needle. Put a single filament of PDS through that loop and retrieve both the needles very slowly backwards. So don't do that quick, otherwise pull out of the suture or cut through of the suture can happen. And then subcutaneously tie that suture. So I will show you two things, how it is done by both techniques. First, I am doing the pie crusting of the meniscus. This will loosen the medial compartment. Now I identified my tear. Through subcutaneous tissue, I put one epidural needle through which I put a PDS and made a loop. Then I took another needle very close to my previous needle. So what I did is, through that loop, I inserted one more needle and inserted a PDS and passed through that loop. So you can see in this video that over the capsule, and I have loaded fiber wire through that needle, and with that through anteromedial portal, I'll use that grasper and I will hold the fiber wire, pull it very slowly and then retrieve it back. So this will repair my whole of the meniscus like this, and I will tie this subcutaneously and I will bury the knot below the skin and subcutaneous tissue. So very easy, very fast thing to do. This is the other case in which I used chia wire. In this, put one epidural needle, through that put a chia wire, retrieve that chia wire through anteromedial portal, put one end of the fiber wire through that retrieved loop of the chia wire, slowly pull that chia wire out of the bite which you have taken for the meniscus. Then similarly again take a bite from the other end or capsule of the meniscus, put the other end of the fiber wire through that chia wire loop, and ultimately this will reduce your torn meniscus and it will become like this. So take home message is that outside in is very easy technique to do. It is very cheap to do, no expensive implant or equipment you need. Learning curve is very less, but difficulty is that you have to mark the exact point which is difficult. and iatrogenic trauma to the cartilage is done. So whenever you are stuck and you are confused that you are not able to repair your meniscus by all inside or inside out technique, तो हमेशा ये चीज़ याद रखना कि आउटसाइड इन जो है वो आपको हमेशा हेल्प करेगा ही करेगा, एक्सेप्ट ड्यूरिंग पोस्टीरियर कैप्सूल रिपेयर, वहाँ पे वो हेल्प नहीं करेगा. So by this technique you will become the Dhurandhar of meniscus repair by doing minimum implant and minimum sutures, and it will be very cheap. Thank you.
Thank you, Dr. Varun, for
next session.
okay. Now I call upon Dr. Siddharth for single bundle PCL reconstruction technique.
उसमें दी थी ना अभी. हाँ PCL वही है. ये नहीं है यार, अभी तो ये डेस्कटॉप पे जो पड़े नीचे. टाइम लगी, हैवी है. करना स्टार्ट. इसमें टाइम लगता है. So sorry for the change in the program. So we'll talk about relive of single bundle simple PCL reconstruction. So the first part is, after making diagnosis, we have to create a space between ACL and the PCL so that we can go behind and in the posterior compartment and look across. So first of all, we clear up the space between the ACL and the PCL and go in the posterior compartment. Yep. Yes, okay. Second is the creation of posterior medial portals. We basically need two portals in the posterior compartment. Either it can be one posterior medial, one posterior lateral, or two posterior medial, or we have to use a 70-degree scope so to visualize from anteriorly and instrumentation from the posterior part. So I normally use two posterior medial portals, high and low. After creation of these two posterior medial portals, the high and the low, the superior one is used for the visualization. I put my scope through the superior portal, and the inferior one is used for the instrumentation for pushing in my radio frequency wand, shaver, and Wissinger rod. Next the part is the clearance of the space between the PCL and the posterior capsule. So we use a combination of shaver and radio frequency to clear the space. We have to be careful not to cross the midline or go even till the midline with the shaver, because that is the area which is a relatively difficult area or a risky area. So what I would advise anybody is not to go with a shaver across the midline, but to use a radio frequency to essentially do this step. After all, we have to pass our PCL jig, sorry for the heading, we have to pass our PCL jig in the posterior compartment around, this one. That has to be 20 mm below the joint line approximately. This is visualizing from the superior anteromedial portal, and the Wissinger rod is in the inferior posterior medial portal. If you see the markings, it is 20 mm below the joint line. Going inferior, you can see the fibers of popliteus, the champagne drop-off sign. So our aim should be to go around 20 mm inferior to the joint line for the tibial tunnel. Once we are comfortable with our placement of the jig, we start the tibial tunnel drilling. We have to keep this under full visualization so that we do not lose the tip of the guide wire and let it overshoot in the posterior compartment. So while the guide wire is coming, we maintain our clear visualization in this area, and once we feel that the guide wire has come, we hammer it gently and push the guide wire towards the last step. We use this instrument, which is a wire catcher, in the posterior compartment. This one, which we pass across the space between ACL and PCL in the posterior compartment, so that our wire does not overshoot and hit the vital structures at the behind. So once this instrument goes behind, we are pushing our guide wire, the bead pin, further in the groove of the wire catcher. If you can see on this image, the bead pin is stuck in the groove of the wire catcher, and now we can start the further drilling over with the 4.5 and the over reaming with the required size. Once we are sure that the guide wire is fixed in the wire catcher. So first of all, I do the drilling with 4.5 and then with the required size 9 or 10 mm of the reamer. So once I'm done with the basic drilling, I reverse the guide wire and put the blunt end inside, so that even if it overshoots, the chance of it injuring any of the vital structure is way lesser. So the blunt end of the guide wire is behind while the time I'm drilling. So after I'm done with the tibial drilling, I pass my threads right at this stage. I pass my threads right at this stage and deliver them through the lower posterior medial portal and keep them handy for the later stage. So these are the threads through the tibial tunnel which are delivering into the lower posterior medial portal. After that, I go to the femoral tunnel drilling. I clear the fat pad and the notch so that I have a clear visualization of the notch. After clearance, I identify the residual PCL remnant. I mark the point where I would like my PCL to enter, that is as near to the cartilage and as vertical as possible, maybe at 11:30 position and 4 to 5 mm from the cartilage, so that my final tunnel is very much adjacent to the cartilage. I switch my viewing portal to the anterior medial portal and make an accessory, I switch it to the lateral portal and make an accessory lateral portal which is inferior for the drilling of the femoral tunnel. So this is the mark I've made in the PCL remnant, very close to the articular cartilage and nearly vertical. Now I introduce a bead pin. I introduce a bead pin from the inferior portal. It's a freehand drilling. I'm happy with the point, and now I have started drilling. Once I'm done with the bead pin, I have a rough idea of the measurement, how deep is the tunnel. We over drill it with a 4.5 mm drill bit. We've taken the length, drilled it with a 4.5 mm drill bit, and over that we do the required amount of reamer drilling. After we're done with the reamer drilling, I clear the mouth of the tunnel always to make the passage of the graft easy. So this is a femoral tunnel right at the edge of the cartilage and as vertical with the clearance of the mouth, because this is soft tissue really hinders when you are pulling your graft, especially in the posterior and inferior portion. This part, the one I'm clearing, needs to be cleared thoroughly so as to allow the passage of graft. So next comes the passage of graft. To avoid the killer turn, we put a Wessinger rod from the low posterior medial portal under the threads, which act as a lever arm, converting the forward force to a backward force. While we are pulling from anterior side, this Wessinger rod is pushing the threads on the posterior aspect. Thus, the killer turn is negotiated and it's easier to pull the graft from the anterior aspect. So graft is passed from the posterior to the anterior into the femoral tunnel. So once we are done with the passage of the graft, next comes the fixation of the graft. So fixation at the femur, we can have two ways. One is we could have used a button at the end of the graft, or we can use a screw inside out or outside in as desired. In this case, I've used an inside out screw for the femoral tunnel fixation. So this is the screw being inserted right at the mouth of the tunnel. So we have finished with the fixation of the femoral end of the graft. Now cycling and pulling the leg in maximum anterior drawer, we fix the tibia with a screw as seen in the images. Plus, I always give a secondary fixation on the tibia in the form of a suture disc which is fixed over the screw. So at the end of the surgery, this is what looks like a final picture in which we have a tight PCL graft sitting at the tunnel. And if we see the outside picture, just now, we'll have a stable knee which will be well pulled anteriorly with not having any posterior sag. Thank you. Any questions?
Thank you, Dr. Siddharth, for a lovely talk. So the next talk will be on real life of outside in meniscus repairs by Dr. K.P. Jayadev.
Inside out. Inside out.
Inside out? Okay, right, inside out.
Good afternoon, everyone. I'll be talking about inside-out meniscus repair. At the outset, I would like to thank Dr. Varun and Jalandhar Orthopedic Society for this opportunity. We'll just brush up with the anatomy. Menisci are essentially fibrocartilaginous complex, and we know there are chondrocytes which are interspersed in between the collagen fibers. We are also aware from the Professor Anorski's work that we have a red-white zone, a white-white zone, and a pure red-red zone with different levels of vascularity and hence the healing potential. Functions, the previous speakers have already elaborated about these, so I will not go into the detail. Just to add on that, menisci function in a way that they convert the knee joint from a pure hinge or gliding to a more of a rotatory stable joint. If you look at the femoral condyle, they are essentially convex structures, and the tibial condyles, they themselves are either flat or they are convex. So menisci, they do provide a necessary concavity depression in order to receive those condyles, and that adds on to the rotatory stability of the knee joint. Again, I will not go into the details of various kinds of tears, it has been dealt with, but as if we talk about the techniques, there are outside in, inside out, and all inside technique. They actually depend upon how we pass our sutures and how we tie the knots. So the inside out and of course the all inside. Now you have to choose a technique for the location and the configuration of the tear, and be wary that you might need more than one technique to tackle a single tear. Now, inside-out repair, it has been considered the gold standard technique and continues to be one because of the less soft tissue damage as well as the arterial damage, because you are passing sutures under vision using certain zone-specific cannulas. You tie knots outside and you do not rely on the anchors, which is the case in the all-inside technique, and hence gives further biomechanical stable construct. Where it can be done, well, we can do it for the tears of the body, and especially the posterior horn of the body. Must pike crust whenever you want to do it on the medial meniscus to open the joint, and do use safety incision so as to avoid the neurovascular complication while tying your knots outside. What armamentarium you need besides the routine arthroscopic setup? You need a rasp, something like this, which we call as a diamond rasp to roughen the margins and to take out the scar from the chronic tears. You need zone-specific cannulas. You know, they can be a single barrel or a double barrel cannula. They are straight or curved on different sizes. We do have a double barrel cannula to reach up to the root and do use them. Then we need an implant, which is nothing but a long pair of flexible needles with a suture in the form of a loop attached to their posterior end. And then we need a curved spoon. Now, you don't need to have a fancy spoon. You know, even a 2.5 or 5 ml tablespoon of stainless steel, that will work for you. So this is a small animation video from the ceramics. Once you identify your tear and you bring down your zone-specific cannula and hold it against the tear, the assistant comes and passes the needle. You have an assistant who can pull the needle from the outside. Of course, if you are using a safety incision, it has to be through it. And Once you pass one needle, then of course comes the second needle. Now if you are using a double barrel cannula, they do have a slit in between, which will let the fiber wire or whatever suture materials there, it negotiates through the slit, and you have ultimately a loop inside the meniscus, and finally you have two different sutures outside, and then you can probably tie the knot on the, so you can use a sliding knot or you can use a mechanical knot as per your choice. You must know the safety incisions. You know, when we are dealing with the tears in the posterior half of the body, there are neurovascular structures, and if you are tying a knot blindly, you might entangle those. So safety incisions on both medial as well as lateral side, they are very simple. They both have to be placed just posterior to the collateral. On medial side, you take the sartorius backwards, and that takes care of the saphenous nerve. And once you do that, the medial head of the gastroc comes into picture. You retract that, and there you are on the capsule. Another trick to see whether your needle is exactly coming out, you can just bring in a probe from the anteromedial portal and poke and see where it is coming, and place your spoon just behind that so that while retrieving your needles don't come and injure the other tissues. Similarly, on the lateral side, as I said, incision is posterior to LCL. You retrieve the biceps femoris backwards, that takes care of the CPN, retract the lateral head of gastroc, and then there you are on the capsule. So we'll just go through the steps once again. Once you do a safety, identify your tear, take necessary safety incision, bring down your double barrel cannula, and then you start stitching your tear. Do make it a habit to please undergo the meniscus and place stitches on the undersurface as well if you want to reduce your meniscus nicely. Once you do a meniscus repair, do check for the stability of your tear and then proceed forward. Coming to the suture configuration, you know, you can place vertical, horizontal combination, but you must put stitches on the superior as well as on the inferior surface. And if you go into literature, these are the vertical sutures which are very, very stable and give a good biomechanical construct if you are repairing a tear in the peripheral half, because that constitutes your circumferential fibers. But if you are dealing with a tear which is in the middle half, say in the red-white zone, those there are only the, I mean, it's more of a radial fibers, so even a horizontal tear will suffice for that. So this was a case which was a bucket handle tear extending into the posterior horn. So once you debride of the things and come down, reduce it, do initial reduction, and then you bring your zone-specific cannulas. So we pass the first needle, and once you pass the needle outside, the assistant takes that out, and then you pass the second needle, and that reduces your meniscus. So after securing the first stitch, you know, the second stitch is passed, and that's how you bring it down. Since it was extending posterior half, so I had to use an all-inside device also. So as I said, even tackling with the one tear, you might need to use more than one technique. And the crux is that do put your stitches both superior as well as inferior. There should not be a waveform after the meniscus is torn. So once it's done, that's how your repaired meniscus looks like. Just a word about the biologics. You know, there has been a lot of talk these days of putting a lot of biologics, fibrin clot, PRP, as well as type 1 collagen scaffolds. They are controversial with no proven long-term results, but if you search through the literature, you know, the recommendation is you can put them in isolated meniscal tears, especially if you are dealing with the tears in the peripheral third. So we are already talking of the tears which are probably in the red-red or red-white zone, which we see, which we think, and we have seen that they do have some healing potential. So I don't know how much they affect, but yes, bone marrow stimulation is something that I usually do for isolated tears. If I'm doing a meniscus tear in conjunction with a cruciate, then as such the biology is getting added. So there's a lot of literature on that. Coming to our take-home message, you know, it's a gold standard technique, safe and cost-effective. Do use safety incisions, use zone-specific cannulas to reach out to the particular part of the tear. Put your stitches superior as well as inferior to the meniscus. Bone marrow stimulation can be done for isolated tear. You can use a microfracture awl or just a K-wire, and avoid iatrogenic cartilage scuffing. Thank you, gentlemen. Jai Hind.
Thank you very much, sir. Now may I call Dr. Tapish Shukla. He will be discussing relief on all inside meniscus repair techniques.
So good afternoon, everyone. In the interest of time, I have two talks to give. I'm going to club them together, and I hope I finish in decent time. So my first talk is going to be on all inside meniscus repair techniques. So this is a very crisp talk. I got 3 techniques to describe. We've got 3 different all-inside techniques. First is a lasso technique for your meniscal ramp lesions. Next is your meniscus-based technique, which utilizes knee scorpion. And the third is your capsule-based techniques, which utilizes the all-inside devices. So this is the lasso technique for meniscal ramp lesion. We all know meniscus ramp lesion is basically meniscocapsular separation. You make a posterior medial portal, put in your cannula in that portal. Usually when you're using lasso, you need to make 2 portals so that you can actually shuttle the sutures. But this is a different type of lasso. It is called ramp lasso. Arthrex has it. Its curvature is made in such a way that you can pass it in one go, and it is loaded with a number 2 fiber wire. So you don't actually need to shuttle the sutures. Once you've taken the bite through the lasso, the fiber wire directly comes off. You can retrieve it through the same single posterior medial portal and tie your knots, and then repair it. Of course, a single stitch won't suffice. In such a cases, you have to take at least 2 to 3 bites. However, one additional step of shuttling the sutures is beautifully avoided. However, one drawback, if the tear extends much more laterally, then you have to go through the standard 2-portal technique. Now, another technique is meniscus-based technique, which utilizes knee scorpion. This is typical Lamotte, which you see in acute ACL tears, lateral meniscus oblique radial tear. You're using a knee scorpion loaded with a number 2 fiber wire, taking your first bite through the meniscal root fragment. Make sure that the needle does not scuff the cartilage. You're there to protect the joint, not to destroy it. Use the same fiber wire and take a bite through the meniscal body fragment, and then tie a knot. Mind you, one stitch is not going to give you enough stability. So you have to repeat this procedure at least 2 to 3 times. And when you have put in 3-4 sutures, this is how stable it looks. This is probably going to heal. You can always use biological augmentations in such cases. Now the capsule base and the last technique for all-inside, which utilizes all-inside devices. This is your longitudinal tear in the posterior of medial meniscus. I always make it a point that I am pie crusting the MCL so that there is enough space to work with. In such cases, always go for biological augmentation. Now I'm going to rasp it with the help of a diamond rasp so that I remove the granulation tissue and the preformed fibrous tissue. One thing that I always use is I do multiple trephinations in the capsule and the synovium to increase the vascularity. Then accordingly, I decide what is the best trajectory to introduce my all-inside device. In first device, I've switched my camera to the anteromedial portal. This is me switching the camera to anteromedial portal. Now I'm introducing my device to the anterolateral portal. This is the best possible trajectory for my first anchor. So you use a slotted cannula in such cases. Slotted cannula helps us in introducing the all-inside meniscal repair device without scuffing the cartilage. You take your first bite through the capsule, you take the next bite through the meniscal tissue, and then just pull on the thread and the knot closes. Mind you, the second anchor, the T2, is going to move towards the T1. Hence, you see the meniscus getting everted in such case, but which is beneficial for us because it exposes the inferior part of the meniscus. Now I'm going to switch it again to the anterolateral portal, my camera. The device is coming from the anteromedial portal. Going to take the bite first in the inferior part, then through the superior part, and then again pull on it. These devices are set to an adequate depth beforehand. When you're going to pull on the thread, the meniscus is going to close, so you have to use a probe. Probe literally helps you manipulate the meniscal fragment back to its anatomical place. Now T2 is going to move towards the T1, hence even after putting the second anchor, you see a slight eversion in the meniscus. That tells us that we are going to have to put one anchor on the inferior aspect. So cut this second suture, use your slotted cannula again, introduce one more device, set to an adequate depth, take the first bite through the capsule, and the next bite through the meniscal tissue, and then just pull on it. So going by the same logic, the second anchor is going to move towards the first anchor, and your everted meniscus is going to come down to its anatomical location. So that's how you repair the meniscus through these capsule-based all-inside devices. Pretty stable meniscus. Thank you. So that was my first talk. My next talk is going to be a simple video on high tibial osteotomy, real life surgery. So this is just a 6-minute video and we'll start. So always do a very good skin marking. Make sure you're marking the patella tendon, your hamstrings and your tibial plateau. After you're done with the skin incision, go through your superficial dissection and then make planes so that you expose the medial side of the tibia. After I've done through the superficial dissection, I use a mop to sweep the posterior and the anterior tissues and then put in my retractors. After you've done this, you put in the retractor, you've exposed, you mark a reverse L. Now this reverse L is the way you're gonna elevate the soft tissues from the medial side of the tibia. Make sure you're doing this very carefully, very gently, because you need these tissues in a very good condition, because these are the tissues that you're gonna repair back onto the plate. You're gonna cover your plate with the tissue. So if you're not careful, at the end, you might not be able to approximate it properly. Go very gently, make sure you're not hurting your deep MCL. However, you have to raise the entire superficial MCL. This is me using a periosteal elevator now to elevate the superficial MCL from the posterior medial aspect of the tibia. Then the attention is turned towards the posterior aspect of the tibia after I'm thoroughly happy with my superficial MCL release. Posteriorly, I usually use a curved osteotome, but it is very important that ever so slightly you are moving your curved osteotome onto the bone and not going haywire. Your structures are going to be just posterior. One trick that I use is I always flex the knee in this situation so that my posterior neurovascular structures are further behind. How do you know that you have released it adequately? You should be able to put a finger that helps you elevate any little more soft tissue that exists. Also, your finger should be able to palpate the fibular head. That's how you know the adequate lateral extent of the release has been done. Then you can go ahead with your intra-articular work. There was a meniscal root tear in this case. I did my transosseous tunnel, passed a fiber tape, cinched it, and then parked my suture. Then I'm going to expose my patellar tendon. You have to use a scissor beneath the patellar tendon so that you create a space for your retractor. Now you use a blunt tip hormone retractor and then retract your patellar tendon. Now this is going to help you to safeguard your patellar tendon. Then you go ahead and mark your osteotomy site. I always do a biplanar cut. You mark your ascending limb as well as the horizontal limb of your osteotomy site. The angle between these two limbs should be around 100 to 110 degrees. Once you have marked it, you start putting in your wires. The wires are going to be guide for your osteotomy saw. The wire should be aimed at the tip of the fibular head. That is where you want your hinge to be. So as you can see, I'm going a little more superiorly. I'm not happy. I'm going to retract it and then again aim it towards the tip of the fibular head. So this is what I'm going to accept. After that, I want you to pay attention to what is happening to the medial tibial plateau. Now your medial tibial plateau has got a native tibial slope, which ranges from 7 to 10 degrees. If you take a AP view in dead extension, you're going to see slight oval structures, as you can see here. So if you flex it slightly and then take a shoot, you will see one dense sclerotic line like this. Now this is how you know that you have nullified the slope. If you put your second wire parallel to your first wire in such flexed position, you know that those two wires are going to be parallel to your tibial slope. So if you take a cut parallel to those two parallel wires, you probably are not going to affect the tibial slope that much. So you put your second wire parallel, that's how I like it. Then there comes the wire that I like the most, that is your hinge wire. So we are afraid of breaking the hinge in this surgery. So the only way to make sure that your hinge strain is reduced is putting in the hinge wire. Surface marking is going to be between the Gerdy's tubercle and the fibular head. Just introduce it by hand and hammer it down. There are two benefits to hinge wire. It is going to decrease the strain at the hinge site. Also, it is going to limit the movement of my saw. So I want my osteotomy saw to stop 1 centimeter proximal to the lateral cortex. And my hinge wire makes sure that I'm not going to go ahead. So you put your posterior radiolucent retractor now. You put your anterior hormone retractor to safeguard your patellar tendon. You've put in those two K wires. You're going to bend those K wires. And then you can proceed with the osteotomy with the help of a saw. So now when we are proceeding with the osteotomy, always make sure that you are cooling the osteotomy site with normal saline, continuous drip, because there's going to be thermal necrosis if you don't do it. And if you're going to keep your wedge open, not use any auto or allograft, it's going to end up in non-union. So always make sure that you're putting in ample saline to prevent thermal necrosis. This osteotomy, horizontal osteotomy, is going to be incomplete. It is going to fall short 1 centimeter of the lateral cortex. After doing this, you have to do this under CM. I'm checking in under CM constantly. Then my attention is moved towards the ascending osteotomy. For my ascending osteotomy, I have to make sure I'm doing it bicortical. So my left hand is going to be on the lateral aspect. I'm safeguarding the fiber tape that I've put in the meniscal root. How do I know that I have done it bicortically? Because I'm going to put my hand on the other side and feel for my saw there. The moment I feel the saw there, I know I've gone bicortical, and I'm happy. Then comes the opening of osteotomy. First of all, what you have to do is use the broadest osteotome that you have, and then gently tap it, and then check under CM. You don't have to worry that you're going to go too far, because remember, you have got the hinge wire in place. Now you use another osteotome just below this osteotome. The trick is to always use the broadest osteotome on top, because it is going to safeguard your tibial plateau. This is going to prevent the extension of your hinge and into the plateau and having a type 2 hinge fracture. So use another osteotome just below it. Make sure it stays 5 mm short of the first osteotome. Then you use another osteotome in between these osteotomes. This is going to again fall short 5 mm from the second osteotome. This technique is called stacking osteotome technique. It is a wonderful way of opening the osteotomy. As you can see, the osteotomy is getting opened. Now you gently come on with this rocking motion, make sure that your osteotomy is open. And then remove these osteotomes as well as the K-wires. Now remove your retractors as well. Now what you have to do is you have to put in now lamina spreader to open your osteotomy. The lamina spreader is always going to go on the posterior most part of the osteotomy. Now if you have to open it, and if you have an assistant, you can ask your assistant to give a gentle valgus stress, but it is not in your control. I don't like it because I get a different assistant each time. So I am not sure if I am happy with it. So what I do is I put the smallest possible osteotome at the anterior aspect and then just lever it so that the osteotomy opens a little bit. Then I put in my lamina spreader posteriorly. As soon as it is in, I remove that osteotome and gently open the osteotomy site. As you can see, my anterior, the limbs of my ascending osteotomy are parallel to each other. It is a trapezoidal osteotomy. That's how I know I've probably maintained the slope and not played too much with it. Always measure the osteotomy gap that you have managed on preoperative planning at the posterior level. Now this is how your ideal osteotomy should look like. Your hinge should be at the level of the tip of the fibular head, 1 centimeter short. There has to be a hinge wire, and the osteotomy should be that malleable that you can literally toy around with tibia. All now that you are left to do is just put in the plate and fix it with screw. And that's how it looks in the final picture. Thank you.
Great demonstration, Dr. Tapish. So just a question that by chance if you break the lateral cortex, what will your take on that?
So first of all, you need to identify if you have broken the lateral cortex. How to identify? There can be a sudden loud snap when you're using the saw. That's how you know. The osteotomy will be too malleable to manipulate. That's how you know you have done something wrong. So now there are 3 kinds of fractures that can happen. First, the fracture line can propagate into the tibiofibular joint. Here, it is better to use a plate. If it is going below the tibiofibular joint, again, plate is better. If it is going up into the joint, then you put in the screws from a cannulated cancellous screws from the lateral aspect. One thing that I would want to say, I always replace my hinge wire with a Herbert screw these days, because even if I'm sure that I've not broken the hinge, putting in a Herbert screw at the hinge makes me very confident if I want them to bear weight early.
Yeah, that's rightly said. And there's a small tip I would like to share. While opening the HTO, we have got a long distal fragment, the whole of the leg, and then there is a small fragment which is in the proximal tibia. So when we put in our jig and try to open our laminar spreader to open, definitely it's not possible for that laminar spreader to move the leg. It's going to put more pressure on the proximal part. So what I do when I encountered such complication is I tell my assistant to give a valgus force. So the osteotomy is open for me by my assistant by giving a valgus force and keeping one hand at the hinge. And once I see that it's sufficiently open, then I just place the laminar spreader inside with adequate amount, and then I just leave it. So just a tip, I mean, if
No. So these are two different cases. Actually, what I showed, I don't need to do it. So previously, as Matthew Oliver used to tell, I used to put it distal to proximal. But then Christian Clay came in PKS and he put it from proximal to distal. Like, what difference does it make? It is probably easier to put it proximal to distal. You can just hammer it. Yeah.
Thank you, Dr. Tapish. Now I invite Dr. Nitish to present on a bucket handle repair.
Thank you, Dr. Varun, for giving me the opportunity to deliver a talk on bucket handle, one of my favorite surgeries to do. And I hope everyone is awake after lunch. So brief history regarding this case. He's a 36-year-old male with a history of twisting injury left knee. He came to us at about 2 months. His knee is locked from last 2 months. There is extension lag of about 20 degrees and ROM is about 2200. Latchman is positive, medial joint line tenderness is present. And here are the MRIs. So in MRI you can see that there is a double PCL sign, there is a fragment in the notch, and ACL is not visualized. So MRI is suggestive of ACL tear along with bucket handle medial meniscus tear. So directly to the video. So as the bucket handle part was locked from last 2 months, so it was actually irreducible. So before starting with the case, I planned that I will just push in that fragment and then go with on my other things like preparing tunnels and all that. So I wanted to show that struggle, that because I was struggling to put that piece in. So the only good thing about bucket handle meniscus is that most of the times it is in the red or red-white zone. So there are chances of healing. So it was always worthwhile to repair such kind of tears. So my first stitch is always the reduction stitch because it is one of the most important, stitch. And you have to be very careful when you take out these all inside devices out, because sometimes the bucket handle part also comes out with it. So first part has been in the capsule, then in the bucket handle, the torn meniscus. So it's a vertical kind of mattress. So either you can use the vertical mattress or the horizontal mattress, but according to literature, the tension of vertical mattress is better than the longitudinal second stitch is also all inside. So after 2 stitches, your bucket handle is quite stabilized. So rest of the thing is just piece of cake. You have to just spread your stitches using all inside, inside out, outside in, whatever devices you can use. I know, but Dr. Varun is Dhurandhar. He's not much driven by industry, but yes, in orthopedics, industry and our branch goes hand in glove. So sometimes we have to do some things. So according to studies, some studies say that gap between the all inside devices should be around 4 to 5 mm, because we have some constraints regarding budget and all that things. We have to compromise sometimes on the usage of implant. And as soon the device is in, we use this pusher cutter. We just pull the fiber wire from the device and then cut it. So one of the crucial areas to stabilize the bucket handle is the posterior horn and the areas near the root. So you do a robust repair at those areas, and anterior to the body and to the anterior part of the meniscus, you can use outside in and inside out techniques. So my 2-3 stitches are in now, and you can see that bucket handle is nicely sitting over the area which you want. So I have a tendency to use pusher cutter after 2-3 stitches. I keep on piling up the devices, then I cut all the knots rather than cutting side by side. So now the posterior horn and the area near the root. So I'll use similar all inside devices for these as well. So it was a very nice talk that was given regarding the opening of the medial joint line, which we do pike resting. Right now we have shifted to the Bancha's point in order to release the MCL, because what Dr. Bancha from Thailand has showed that the healing of MCL is much better using that, and with a single or a double prick you can able to visualize the whole medial compartment, and your tears are very nicely visualized. So I had an opportunity to visit him once, and so I learned that trick using the Bancha point to release the MCL from him. In our videos, we don't show the struggle, but you have to understand a struggle is real. All orthopedic surgeons, all arthroscopy surgeons, suffer from it, and that's how things happen. So after repairing the posterior horn, my last stitch will be near the root. I'll just probe it once. If I feel that my meniscus is loose from any side, I'll give another stitch. So here I can see that there is a bit of mobility on this area. So I'll add another stitch at this place as well. So the idea of repairing bucket handle is that you have to save as much as collagen you can save, because down the lane, that's the only barrier between the progression of osteoarthritis of the knee. So if you are saving the meniscus, you are giving enough, you are saving enough collagen, and you are happy. So this one is near the root, exactly at the root, because I had some doubt that if there is a hidden ramp lesion, because I had already seen there was not, the hidden ramp lesion was not present, but still I wanted to stabilize the root. So for the anterior part, I opted for inside out repair technique. So nowadays I have shifted to the mini fiber tape which is available, because I feel it's more robust than the fiber wire. So once it goes in, it just holds your meniscus nicely. So this is the healed meniscus, and so this is the post-operative MRI about 5 months from now. Yes, you can see some meniscus repair artifacts that are seen. A little bit of torn bow tie is also visible, which Dr. Varun mentioned. So can't complain, patient is happy, patient is able to do all the activities. So can't complain. Thank you. Thank you. Thank you for patient listening.
Now I invite Dr. Tarun, who will be talking upon meniscus root repair. Very important topic, as all the pressure and stress over the from femoral to tibial is transferred to the roots. So if a root is torn, so osteoarthritis is on the way. So, Dr. Tarun.
A very good afternoon. So we'll talk about meniscal root repairs. So meniscal root repairs are generally seen in setting of degenerative osteoarthritis, partially degenerated knees, in which you see that the meniscus has, the posterior horn has torn and the meniscus has started extruding. So, you know, virtually it amounts to a complete meniscectomy where the load-bearing capacity of the meniscus is totally gone and the meniscus does not function as a shock absorbing capacity any longer. On this you will see as the meniscal, the posterior horn of the middle meniscus will not be attaching to its tibial attachment posteriorly, and you will see it also as a ghost sign in the sagittal view, where you will not be able to appreciate or you will not be able to see the normal triangular structure of the meniscus that you would typically see in this location attaching to the tibia, the posterior capsule and the tibia, and there will be extrusion of the meniscus as you can see here, and more than 3 millimeters of extrusion of the meniscus will be considered to be of clinically significant. This is classified by La Prade. Now, we would, as previous speakers also mentioned, we would always do a pie crusting of the medial side because it helps to open up the medial compartment for you to visualize what is going on there. And this is how the meniscus would look like after the meniscectomy. You will, after the pie crusting of the meniscus, you can see here that this is a posterior horn of the middle meniscus which is no longer attaching. It is detached from the tibial attachment. First of all, you would like to see the mobility of the tear, because unless the meniscus is mobile, unless it is reducible, you will not be able to put it back to its native attachment. And then, of course, it will also need a soft tissue release. This will help in stimulating healing in that area by roughening the cartilage and roughening the capsule and the meniscal attachment. And the third thing that you are going to do here is remove the cartilage to a healthy bleeding bone at the site of insertion, so that you have area where the meniscus can be reduced and healing can be stimulated by exposing the cancellous bone underneath. Now, two tunnels will be used. First of all, we are passing the fiber wire sutures. So the medial most 8 millimeters of the meniscus is considered to be avascular. So generally you would put first suture a centimeter from the edge and with a cinch knot, and you would again try to reduce it. You will check the reducibility of the tear. Similarly, a mini scorpion or a mini suture passer is being used here, and another one will be used about a centimeter from the previous one. And again a second fiber wire is passed through the meniscus, taking bite of at least or more than 50% of the meniscus. And another cinch knot is placed here, and you can check the reducibility of the meniscus, and you can see that it is easily reducible to this site. And now you will identify where you are going to make the tunnels. We have made past two sutures here, and we are planning to make 2 tunnels here. And always remember that since it is a cinch knot, it is at the anterior border of the meniscus. So it is going to reduce it in the tunnel at the anterior part of the meniscus. So the tunnel that you are going to make is a little bit anterior as compared to the anatomical site. So 2 tunnels have been made here, one medial and one more towards the center, where these are finally going to get reduced. And these tunnels will be drilled over with a 4 mm drill bit. And once you have drilled it with the 4 mm drill bit, you will pass the sutures for retrieval. You are passing it with a simple ethibond suture. You are passing your bead pin with a simple ethibond suture loop at the eye, which are pulled out from your anteromedial portal. And the suture is shuttled through this tunnel over this ethibond suture and brought out from outside. So many times you may be combining this with high tibial osteotomies also, in which case you would have to plan the position of your tunnels so that they are above the level of your osteotomy. Similarly, the same thing has been done for the other side, and the suture is passed, the ethibond is passed, and the suture is shuttled out. The second suture is also shuttled, and this is how it looks like after the two sutures have been passed from the tunnel. The meniscus has been reduced. Now we know that in these cases there is also extrusion of the meniscus, which is generally seen at the posteromedial border, and in this case a centralization stitch can be passed. So this is again a ACL zig that we are using here. You can use a ACL zig, or sometimes you have a special zigs for the root repair also, which you can use. So this is used to pass a guide wire or a beath pin at the edge of the medial edge of the tibia. And again this is drilled over with a 4 mm drill bit. Beath pin is passed with a loop of a ethibond, which is retrieved again from the anteromedial portal. And now we are again going to use a suture here, fiber wire suture, and a mini scorpion to pass a loop of the thread through this, and this will be quite towards the periphery. This will not be towards the center as we did previously. This will be at the periphery of the meniscus, menisculo-capsular junction, so that this can bring it back to the edge of the tibia. So this will be a centralization stitch. It will be shuttled out from the using this ethibond, and then the repair will be completed. This is will be tied outside with using a using a button type of a device. Any simple button type of a device can be used to tie it on outside with a cortical button. Alternatively, a suture ankle can also be used for using a further centralization stitch. It can be inserted at the edge, and the sutures can be passed. So in these cases, sometimes you need a complete package of not only a root repair but also centralization, and high tibial osteotomy is also frequently be required in this type of cases. Recovery milestone generally follows what we do for other type of meniscal repairs: protected weight bearing for 6 weeks, then transition phase in which weight bearing is progressed, range of motion is progressed, strengthening is started, and then started progressing to full weight bearing. Thank you.
Thank you, Dr. Tarun. So now on the last topic of the session, it will be on complicated cases. There are 2 to 3 announcements which I have to make. One is the lunch is going on the first floor. Second, do collect your conference gift in the trade fair. And third, there will be a lucky draw at the end of the session. And as I have already told, it is a sports cycle. So it will be awarded to all those who have given their token in the Corona stall. So let's go to the difficult cases of meniscus, which will be presented by Dr. Tirth.
So at the outset, I would like to thank Varun sir and the entire organizing team for having me here. So this is my first time in Punjab, as well as after becoming a co-convener of Indian Arthroscopy Society, this is my first JOPP which I am attending. And now, since morning, we are seeing that lot of meniscus repairs, but let's go to the difficult indication of doing a meniscus repair. So the tear patterns and all those things we know. The biggest dilemma that we face in our operation theater is, should we repair all the meniscus tears? So the answer is big no. So these are the criterias where we have to think about doing a meniscal repair. This point I would like to highlight: anything you do in absence of alignment, good alignment, it is going to fail. So first, always look for the good HK axis, normal alignment, then only go for the repair. Now I am jumping on to the case of discoid meniscus. So the discoid meniscus is the abnormal development of the meniscus which leads to the hypertrophic or the discoid shaped meniscus. So in some time I will start with a case who is 15 to 16-year-old male patient who had a snapping on the lateral side, and he was complaining of pain at the same time. MRI was showing typical bow tie sign, and now let us start with the. So as you can see, this is the lateral meniscus, and now when we just put the scope into the joint, and we see that it is covering the entire lateral tibial condyle. So at the first sight, we want to do the saucerization, and we want to take off the excessive part which is giving snapping in the knee joint. Now the next question comes is how much to excise. So it has to be 2/3, 1/3. So the 2/3 of the condyle, it has to be seen, and 1/3 of the condyle, it has to be covered by the meniscus. Slowly, gradually, you have to excise it and keep checking whether you are excising the enough portion or not, because otherwise it is going to land up into a re-tear. Once the enough excision of the meniscus is done, then you have to look for any tear, look for whether there is any tear at the meniscocapsular junction, or the horizontal tear, it is there or not. Because most of the times it happens that it is a degenerative horizontal tear which is there. So when we start excising from the inner aspect, we see that there are two lips. But in this case, it is not like that, since the patient was young. Now, after improving the biology, I will start repairing the meniscus, which we can use, we can repair using any of the method, like all inside, inside out, or outside in. Now coming on to the next case, the parameniscal cyst. So what is exactly the parameniscal cyst? So the meniscal tear is the primary pathology, and the cyst that occur is the secondary phenomena. So as you can see, if we have to repair or plan about dealing with the parameniscal cyst, either we do the meniscectomy, like we take out the superior leaf or the inferior leaf, we attack over here at the meniscocapsular junction, or we attack from the outside of the knee. But it is very important to remove the check valve mechanism that is there in the parameniscal cyst. A small video on the parameniscal cyst. So this patient, he was also a young gentleman having a cyst on the anterior aspect of the knee, which is very difficult to find out, to localize. So we have to take time to localize the parameniscal cyst. Slowly, gently, we have to use the shaver. Now using the needle, I am trying to find out the cyst. As you can see, the fluid, nice fluid is oozing out of the cyst, which is the mucinous fluid. Once that is done, we have to check for the patency of the meniscus, whether we have damaged in that process of removing the cyst, whether we have done any damage, iatrogenic damage to the cyst or not. So once the cyst is removed, there was another cyst on the other side. So as you can see, this was one more cyst. Once the cyst is removed, we have to plan for the meniscal repair. And as Dr. Varun demonstrated that how we can repair anything on the anterior side using outside in, which is the real Durandar. So using outside in method, I have repaired the meniscus, put the needle through the meniscus and take the horizontal stitch. So we all know how we should repair the meniscocapsular junction on the anterior aspect using outside in method. This is the third case where I have done the centralization of the meniscus. So the centralization of meniscus is often indicated when there is a traumatic tear, traumatic root tear, and which is neglected, and it is taking away the meniscus from the tibial condyle. And in those cases, we want to do the centralization of the meniscus. If there is malalignment, we should not attempt the centralization of the meniscus because it is definitely going to fail. So now I'm taking the accessory medial portal after the diagnostic round. After the accessory medial portal is taken, we have to do some release. After the release, we have to check the mobility of the meniscus. If you can bring it well to its native place, that's the time we start repairing it. So this is the all suture anchor. Like a banquet, we have to repair, but in banquet, we are taking the simple stitch. Here we have to take the mattress kind of stitch. Once the stitches are taken from all the anchor, we have to start tying the knot. And thereby you can see that after the root is repaired and the anchors are tightened, you can see that there is a good amount of centralization of the meniscus. So in a nutshell, multiple factor determines whether we want to resect or repair. So it has to be an individualized approach. Always err for the less invasive approach. We have multiple devices are available, but it has their own learning curve. Do not over repair or over resect. So we should have the balanced approach. Always try to improve the biology, because otherwise it is not going to heal and your repair is going to fail. And the post-op rehab, we have to individualize depending upon the associated injury. So keep saving the meniscus. And with this, I would also like to invite you to become an IAS member. Now, till today, we have become a largest arthroscopy community in the world. We have around more than 5,000 members. Thank you so much. Can I move on to my next talk?
You can do that.
Yeah.
For that, I'll call Dr. Haripal, Dr. Ranbir, and Dr. Avinash Chauhan.
Okay. So lateral extraarticular tenodesis, why we do the lateral extraarticular tenodesis? Because we want to remove the residual pivot shift after ACL reconstruction when there is a revision ACL scenario, and we want to increase the rotational stability on the anterolateral aspect. So what the anterolateral complex consists of, it is IT band, it has a Kaplan fiber, it has an anterolateral ligament, and they all act as a secondary stabilizer. With the LET, we want to control the internal tibial rotation. We want to decrease the pivot shift and decrease the graft load. So the indication of doing an LET is grade 2 or grade 3 pivot shift in a revision ACL scenario, in young athlete which is less than 25 years, in a generalized laxity patient, hypermobile patients, and the people who are playing the pivoting sports like football or kabaddi. The concept of LET, it is an extra-articular check-in, and we uses ITB strip, whether we want to take out from the proximal end or the distal end, depending upon, that's a different story, and it works synergistically with the ACL graft. The key step of a modified lemur is we are taking out 8 to 10 centimeter by 1 centimeter ITB band. Distal attachment is intact. We pass deep to the LCL and we fix it over the proximal and posterior aspect of the lateral epicondyle. So let us start understand the demonstration. So as you can see in this graph, in this picture, this is the fibula, this is the lateral epicondyle, this is a Gerdy tubercle, and I have marked my incision. So we have to take around 8 to 10 centimeter of incision. Then from the posterior half of the IT band, we have to take out 8 to 10 centimeter of the graft. Once that is done, we have to take the whip stitch because we want to pass it beneath the LCL. Once the whip stitch is taken with any fiber wire or the ethibond, we have to identify the LCL in a figure of 4 position. Once the LCL is found out, we have to pass the graft below the LCL, and after that we have to find out the anatomical point and pass the between. If you are doing it with a concomitant ACL, then we have to put the scope in the joint, see that you are not violating the cortex, and the direction of the drill should be proximal and anterior. So the clinical outcome, what happens after LET is, it reduces the pivot shift, it decreases the re-rupture rate, improved return to sports, and there is a better confidence that we have in the athletes. What are the complications with LET? Because it over-constrains the lateral compartment, there are chances, there are reports which suggest that there is a lateral arthritis, lateral joint arthritis. There is always a chance of tunnel convergence, so we can always avoid using this tunneling, doing the tunneling, and with the Tino-lock anchor we can just tie the LET band. Sometimes there is an improper tensioning, and there is also a possibility of lateral knee pain. So as I described, when do I do LET, I have already described. One word on Ellison technique. So in Lemaire's procedure, we are taking out from the proximal end. Now we want to take out from the distal end in Ellison. What we do in Ellison is, we take out from the distal end, pass it beneath the LCL, and then tie it again over the Gerdy's tubercle. So this is the alternative procedure that we have. In this, the advantage is that it minimizes the lateral compartment constraint, it is less invasive, it is safe, it is suitable for pediatric patients, and it gives dynamic sling on tibia. Also, we can avoid the problem of tunnel convergence. So the take-home message is, LET is not routine, it is a powerful tool in selected patients. It definitely improves the rotational control, it gives stability, LET gives confidence. Thank you so much.
If anybody has any questions?
Sorry. Okay, thank you.
Thank you so
Thank
much.
you, sir.
Now I call Dr. Jadev.
Good afternoon. My second topic, I will be talking on the PLC, the posterolateral corner, as we all call it, dog corner of the knee. But I don't think it's a dog corner anymore. We know a lot about this now. So just an introduction, it's a primary restraint to the varus instability, especially in external rotation, and it does give a restraint to posterolateral rotation as well. It acts as a secondary stabilizer to the anterior and posterior tibial translation, especially if you have a cruciate deficient knee. The main two structures, those comprise of this complex, are the LCL and the popliteus complex, and they are the ones which are responsible for primary restraint, especially in the mid ranges of the flexion. So if you look at the anatomy, we do have a static and the dynamic stabilizer. Static stabilizer, the LCL, popliteus tendon, and the popliteofibular ligament. And then we have an array of the dynamic stabilizers which help the static stabilizers in forming the PLC. There are different secondary stabilizers which are grouped into different layers. The point to remember is that we do have a neurovascular bundle in the form of CPN which lies between the layer 2 and 3, and this is important especially when we are doing a dissection so as to do a reconstruction, oblique repair. We also know from the work of the Professor Laprade that both popliteus and the LCL, they do have an 18.5 mm of distance on the lateral femoral condyle, where popliteus tendon is more anterior and distal and the LCL is more proximal and posterior. If you look at the injury patterns, the isolated injuries are very, very rare, less than 2%. Usually they are in conjunction with a cruciate, with PCL taking major chunk of that, around 27%. And it is important to diagnose and do this repair in conjunction with the cruciate, otherwise that compromises the cruciate reconstruction in itself. And there's a lot of literature on the same, including the one by the Laprade itself. Mechanism of injury is either direct varus stress or hyperextension, twisting injuries to the knee, and KD3 and above injuries. Clinically, other than the symptoms of pain and instability, you look for the varus thrust in the gait as well as the hyperextension. There are a lot of tests which has been devised to diagnose the PLC injury. You can do the testing for the individual component, or you can do a testing which includes more than one component. So you do a varus test to check whether the LCL is intact or not, and do it in both extension as well as flexion. One of the reliable tests is the external rotation or dial test. You can do it in supine as well as in the prone position, but must do it in both 30 and 90 degree of flexion, and this is how you interpret it, whether it's the isolated PLC injury or it's in conjunction with the cruciate ligaments. Houston and Norwood, they devised a couple of tests, including the posterolateral drawer test as well as the recurvatum test and the reverse pivot shaft. So all these tests can be done in conjunction, but posterolateral laxity plus a dial test gives you the diagnosis in more than 90% of the cases, and these tests should be incorporated in your daily practice. Well, they have been classified by the Houston again into different grades depending upon the amount of lateral opening and the external rotation, but we do have a finale classification which is more practical and gives us an insight as to what structures are torn and what we want to repair, oblique reconstruct. So how to go about it? You do an imaging besides the routine x-rays. We do a varus stress and look for the lateral joint opening, so that gives you a clue that something is wrong with the posterolateral corner. Of course, MRI is the gold standard. You look for the LCL, you look for the popliteus insertion, and a careful cut can give you an insight into the popliteofibular ligament as well. So can these injuries be considered? The answer is yes. Houston grade 1 and few grade 2 injuries can be considered. You know, in orthopedics, grade 2 is, or type 2 is always controversial. So type 2 still remains controversial, but once you want to conserve, then you can brace them up for 2 weeks and probably give them a rehab and reassess them after 4 to 6 weeks. But anything which is again grade 2 or above can be taken for the repair oblique reconstruction. Now, what to do, whether to repair or to reconstruct? Well, if you get a PLC injury within 3 weeks, and if it's an isolated injury, which of course is quite rare, less than 2%, avulsion injuries, they can be repaired. The literature has been in favor of better healing in distal avulsions rather than the proximal avulsions, but overall, if you look at the literature, the failure rates of repair are quite high as compared to the reconstruction from the works of Laprade itself. Now, when coming to the reconstruction, you know, the goal is to reconstruct the LCL and popliteus at least, if not the popliteofibular ligament. So we are done away with the non-anatomical reconstruction. We don't do them anymore. The anatomical reconstructions, they can be fibula-based or tibiofibula-based. So fibula-based, we do have a Larson's as well as the Arcerio's reconstruction, and then more anatomical tibiofibular-based Laprade's reconstruction. So if you look at the Arcerio as well Larson, they utilize the single graft. They are fibular-based. The difference is in the femoral tunnel. So the Larson's, he does a single femoral tunnel at the isometric point of LCL, whereas in the Arcerios, it makes 2 tunnels in the femoral condyle, which are 18.5 mm apart. And then comes the Laprade reconstruction, which is a true anatomical reconstruction. It uses 2 grafts. You reconstruct an LCL, you can reconstruct a popliteus, and of course the popliteofibular ligament. Now, what to do, how to choose? You know, you do a varus test and you do a dial test, and if it gives you a positive finding, both of them are positive, you have to do an anatomical reconstruction, either Laprade or the Arcerios, and that's how the things progress. So if it's an isolated LCL tear, then probably you can just go ahead and do the Larson's. That will save time. Now, out of these Arcerio and Laprades, what to choose and how? If you search the literature, you know, both of them give similar results. The difference is in time of surgery and probably the ease of doing surgery, because Arcerio surgery is technically slightly easy. It utilizes a single graft. You have only one femoral tunnel, fibular tunnel, and the one graft. But both are superior to Larson's technique in restoring biomechanics. Just a small word about the alignment correction. You know, if you are doing a PLC reconstruction or probably a cruciate reconstruction without correcting an alignment, it's going to fail, and a lot of stress is going to be there. I will show a small video. I did this patient around 2 years back. He came to me for deformity itself. But if you look, even after reconstructing or doing the high tibial osteotomy, he still has got a little bit of varus thrust in the post-op video. So that's because I did not touch his PLC at the time. Because of the constraints, he didn't come for that. So yes, the alignment correction does give a better healing rates and better results if they are done in conjunction with the PLC reconstruction. Post-op rehab, this is the rehab I have been following for last 10 years now, non-weight bearing for 6 weeks. First 2 weeks, I start them in the range of motion. Target is to reach 90-degree flexion by 4 weeks. 7th week onwards, I make them weight bear. Next 3 to 6 months, target is to make them do a brisk walk up to the jogging, and probably I will not allow them sports before 12 months. So the take-home message, don't miss the dog corner. Do dial test and posterolateral drawer in routine examination. They are commonly associated with PCL injuries, though isolated injuries are very rare, less than 2%. You can go ahead and repair in acute cases. Those are less than 3 weeks, especially for the distal avulsions, and reconstruct both LCL and popliteus whenever possible. You can utilize an R-Series or the Leopard's technique and do correct alignment to achieve better results. Thank you, gentlemen. Jai Hind.
Dear colleagues, do we have any questions from Dr. Jayadev? No, thank you, sir. Thank you so much. Can I call upon Tirath Vyas, Dr. Tirath Vyas? Dr. Indradeep, please come on the dais.
So good afternoon. So I've been given a special job to keep you all of you awake for the post-lunch session especially. So I'll be talking on PCL avulsions, how to arthroscopically repair them or do a reduction over it. So whenever we see a wound like this somewhere in front of the knee, it's very important to look at the posterior structures of the knee, especially the vascular structures and then the bony structures or the ligamentous structures. So it is very important that we should not miss upon the vascular structures. So the investigations starts with anything like X-rays to CT scans to MRI and the CT angiographies if you are expecting any vascular injury, or if it is a multiligamentous kind of injury with a PCL injury or a PLC injury. So X-rays can be deceptive at times. There can be a small fragment which may be looking at you, staring at you, or you may miss it. So it is very important to start on staring on these X-rays and try to figure out if there is some bony fragment which is there. CT scans give us a 3D view of the small fragment, the size, the combination if it is present, and it also aids in better planning of the surgery if you are planning to do it. So MRI is most of time indicated because there can be missed meniscal injuries or missed intra-articular problems which can be coexisting along with the PCL avulsion fracture. So it is very important to get an MRI also, just not rely only on the X-rays. So there are various fixation techniques if I talk about. So it can be open, mini open, and an arthroscopic technique. So we have to give a long incisions and do a quite lot of retraction when we are trying to do an open surgical fixation, and we have to use a metal hardware. So there are various modifications to this also, but still to me, in my hands, it will be an arthroscopic technique which overweighs over an open technique. So with open technique, we try to put in some these kind of screws to fix in the fragment, but at times the fragment can be very small, and these screws can get misdirected into the intra-articular area. So you have to be careful that you don't land up with this kind of X-rays at times. And I will suggest not to put in a screw when the fragment is too small or it is a comminuted fragment, because there won't be any hold of a metal hardware if you are trying to put in. And in obese patients, I would always suggest to do an arthroscopic kind of fixation. So moving on to the video per se. So these are the preoperative X-rays where we can actually see a fragment which is lifted off. It is type 3 kind of PCL avulsion. MRI revealed ligament was intact, but it was avulsed along with a bony fragment. So these are the portals. I make high anteromedial and high anterolateral portal, and 2 posteromedial portal, a high posteromedial and a high posterolateral portals, so which aids in working as well as viewing throughout the surgery. So we start off with the anterolateral portal. So after clearing the intra-articular hematoma, the floppy ACL is an indirect sign of having a PCL deficient knee or a PCL avulsed knee. So we make a intercruciate window. We have to be very careful not to iatrogenically damage one of the cruciates. And from here we move on to the posterior medial compartment. Posterior medial compartment, we make 2 portals, which is a high posterior medial portal, and this will be the viewing portal for the rest part of the surgery, and a low posterior medial portal, which will be, cannula will be parked in a low posterior medial portal, and this will be working portal. Then with the elevator, we create a space between the avulsed fragment and the capsule. So looking from the high posterior medial portal, we have to clear the bony crater or the area where we want to reduce the fragment back onto its place. So it is very important that we clear it off all the fibrous tissue. Then with the tibial jig, we have to make 2 tunnels at 2 sides of this bony fragment or the bony bed, and then over-ream it with the 4.5 reamer. It is very important to protect this wire so that it should not over-penetrate and injure the posterior vascular structures. So then with the suture tape, which is passed on the either side of the PCL, we do the knots, and these knots should not be very tight to strangulate the tendon bone interface. After doing a sliding knot, we do the half hitches over it, and then either end of this tape is retrieved anteriorly from the lateral and the medial tunnels, which we have already made. After retrieving them anteriorly, the knot is tied over a bony bridge, ensuring a stable reduction. So that's the final image. So these are the post-op X-rays, which indicates the fragment has gone back and reduced perfectly onto its place. So the rehab is like long knee brace for 4 weeks with posterior padding onto the leg. Quadriceps isometric starts on day 1. We start with prone range of movement 0 to 90 degrees from day 1 gradually, and full weight bearing starts generally at 4 to 6 weeks, and standard phase 2 and 3 rehab protocols are followed thereafter. Follow-up, we see these X-rays and there are minimal incisions, and we see a good union of the bony fragment. So this was a 1-year follow-up with the MRI and a second loop scopy, and there is no evidence of the suture tape. It has synovialized over the time. In view of large fragment with combination, we can make 2 big tunnels on the either side. We can use 2 double tapes to give a good stable fixation, and at end of 1 year, we can see complete obliteration of these tunnels. So it is important that we aim for a stable fixation and follow the AO principles. So there are few points. We should always take a proper X-ray. Just don't rely on single X-ray for looking at these fragments. You may miss if you don't do a proper X-rays. You should have a clear visibility as it is an acute injury at times. So you should be very careful clearing all the hematoma because it can give you sleepless nights at times. And I always weigh an arthroscopic way of reducing these fragments better and a handy than an open reduction. Thank you.
Thank you, Dr. ID. There is a request that lucky draw will be taken out by you only.
Yes, please.
Yes, sir, please.
I'm feeling very left out, ID, so I wanted to ask you a simple question. These screws that you showed, which is, in the posterior compartment, and they are not embedded in the bone. So as an arthroscopist who has so much of armamentarium in their hand, what do you do now to not have that thing, coming intra-articular or not leaving that metal inside the posterior pocket? I mean, you have to guide us because what are the newer materials that you
so
think?
That's what we started using suture tapes now.
Yeah.
And we are progressing to the polyethylene tapes now over
Okay.
time. Yes.
So
no metal hardware.
No metal hardware at all? I mean, I think that should be the word, right? Yes. No metal hardware at all now, I think, in the posterior pocket. Yes. Thank you. Lucky draw.
So, sir ਨੂੰ ਬੁਲਾ ਲਓ ਸਰ ਕਿੱਥੇ ਸਰ ਤੋਂ ਕਢਾ ਲਓ
ਰਣਬੀਰ ਸਰ ਹਰੀਪਾਲ ਸਰ ਇੱਕ ਵਾਰ ਲੱਕੀ ਡਰਾਅ ਦੇ ਲਈ ਨਾਲ ਹੀ ਆ ਜਾਓ ਸਰ ਆ ਜਾ ਯਾਰ ਆ ਜਾਓ ਪਤੀ ਨਾਲ ਤਰੁਣ ਡਾਕਟਰ ਸਾਹਿਬ ਆ ਜਾਓ
ਸਾਰਿਆਂ ਨੂੰ ਇੱਕ ਸਾਈਕਲ ਦੇ ਦੇਣੇ ਲਓ ਸਰ ਸਾਰਿਆਂ ਨੂੰ ਇੱਕ ਸਾਈਕਲ ਦੇਣਾ
एक स्लिप हो गई है सिलेक्ट लेट्स सी
डॉक्टर अभी विरल जोशी हॉस्पिटल अविरल है अभी तो हाथ में लगे आया सी remember to touch the golden hand okay
thank you so much sir I feel lucky
अरे गुड है
तो मेरे को ही मिल जाएगी एक्चुअली किसी को मिल गई सर मतलब पॉजिटिव रिइंफोर्समेंट कैसे अच्छा एग्जांपल तो नहीं मिलता
डॉक्टर साहब आ जाओ मानव
डीएनबी कर रहे हो जी सर डीएनबी पास हो जाओगे
चलो थैंक यू सो मच
डॉक्टर अविरल को तो बिठा दो क्या बाकी पर्चियों में दूसरों के नाम थे ना आ जाओ यार आ जाओ
मैसेज पढ़ने का फायदा कल आपके फोन रात में आ रहे थे मैं वहाँ पे लगा रहा था ये तो मैं आज सर यहाँ पे लगा
last three talks are there. One is Dr. Rohan will complications of HTO by Dr. Tarun. And after that, Dr. Rohan will present on HTO cases and then Dr. Baldish. After that, there will be a workshop on ACL, meniscus and HTO. That will be for 1 hour. You can play with the bones for 1 hour. There will be no restrictions. Thank you. Dr. Tarun.
सर आपने दी थी
Good afternoon, everyone. First of all, I'd like to thank the entire organizing persons there, Dr. Varun, and all the people who have given me the platform to share my thoughts on HTO, the common complications and the bailouts. So as the trend of H2 is growing, so are the complications associated with it, because more and more surgeons are now doing it. Overall complication rate is 31%, and they've been grouped into intra-op and post-op. Hinge fractures being 1 in 10 cases, peroneal nerve injury cases, especially when you're doing a lateral closing wedge, vascular injury 1.7%, and post-op complications such as compartment syndrome, superficial or deep infections, risk of non-union, risk of DVT. And some complications may be because of technical errors, and some can be because unintentional, such as increased tibial slope, decreased patellar height, or under and an overcorrection. So what are the major intra-op complications? The first being a hinge fracture type. Takeuchi classification has grouped it into 3 types: type 1, type 2, and type 3. Type 1 are the stable ones, which occur in the plane of the osteotomy. Type 2, they are potentially unstable, where the fracture line, it exits below the osteotomy plane. And type 3, where the fracture line, it goes into the joint and has a high potential to cause arthritis in the later life. So when you recognize a hinge fracture, there's always risk of loss of angular correction. There are chances of delayed or non-union, and there are chances of implant failure, and it causes an instability at the osteotomy site. Most of these fractures, they are recognized on the post-op x-rays, the left being a type 1 and the right being type 2. Persistent pain in the post-op period is the main thing that you can recognize, and you should think of a hinge fracture. So to protect this complication, you must use a hinge wire during the surgery, and the osteotomy correction should be very gradual. You should not have any sudden or jerky movements should not try to do a valgus very suddenly. It should be, osteotomy distraction should be very, very slow, and hinge wire is the main thing that will protect the complication. And if it does happen, then a hinge fracture screw is very important and a good option for a bailout. Next is a tibial slope increase. That usually happens when you are distracting the osteotomy more anteriorly than posteriorly. So the rule of thumb is to 50-50 rule, that the posterior osteotomy plane should be more than the anterior osteotomy plane, that is 50 to 67%. The left X-ray shows the more osteotomy anteriorly, and the right shows the osteotomy, the good correction of the posterior osteotomy, that the tibial slope has been restored. Next is the hinge point and the hinge axis. Always aim for an anterior and the lateral hinge point, so that you have a good internal rotation of the distal fragment. And because the osteotomies, where the hinge point is posterior, they have a tendency to increase the slope. Next complication is undercorrection after HTO. This is a 23-year-old female who had a failed multiligamentous reconstruction, and you will see that due to undercorrection, patient had a persistent medial joint line tenderness, and she was an unhappy patient. And next is the very important is not to overcorrect these osteotomies. Whenever you are neglecting the joint line congruence angle, especially in cases who have a lateral ligamentous laxity, then you are overcorrecting. There is always a tendency. So you first always address the correction with the HTO, and later on go ahead for a lateral ligamentous repair. Other complications that you must take care, they are vascular injury, and you should be very meticulous in your dissection. Use of radialiscent retractors posteriorly, that will help you not go in with this complication, and your saw should be very, very precise and not too deep. And common peroneal injury, which is very, very common, especially with the lateral closing wedge osteotomies. Persistent pain after the surgery does happen, especially when you do large openings. The opening wedge osteotomy, when the patella shifts downwards, and it is the main reason for it is a patellofemoral pressure syndrome. Or for the bailout for this is a descending biplane osteotomies, where you're not, because the height of the patella doesn't altered by a descending biplane osteotomies. And especially when you are not looking for a pre-existing patellofemoral pain, you should always look for signs such as a lateral facet weakening, so that you can rule out the lateral patella pressure syndrome just before performing these surgeries, because in those cases, partial lateral facetectomy and a lateral retinacular lengthening is a good option to do. So this is what I was talking about, descending biplane HTO. You can see that in the figure that is in the green color, the osteotomy of the, we have gone below the osteotomy plane. So this type of osteotomy doesn't alter the height of the patella. So this is a patient who had a descending biplanar H2, 59-year-old female who had a varus with a patellofemoral osteoarthritis, and you can see that you can appreciate the lateral patellar facets, and she was an unhappy patient, and she was performed with the lateral patellar facetectomy and a lateral reticular lengthening. Persistent medial pain, especially when you are not adequately releasing the MCL, you should be, the good guide is that you should able to palpate the fibular head with your index finger. That is significant MCL release, because if the MCL is not released in a good manner, then it causes a paradoxical medial joint line overload. And especially when you are also missing the intra-articular lesions such as a root tears or a meniscus tears, and especially that when you are attempting HTOs in medial advanced MGOA, medial joint line osteoarthritis, then these are also unhappy patients after HTO. Next is a saphenous neuralgia, which occurs usually by the entrapment of the infrapatellar branches of the saphenous nerve. When you palpate those areas, you can have tingling and persistent pain around that area. Patient will always say that he has a pain, stiffness as you do TKR, and similarly this complication may occur after HTO also. And it's a good option to start with some local anesthetic. You can give a cortisone injection around that area, and if the patient doesn't improve, surgical excision or a release is a good option to do. Non-union is a very rare complication, but it does happen, especially when your fixation is not good. And you should be always careful for the future options as well. Your incision should be very good, and these type of oblique incisions are always a challenge for the future surgeons who are going to do TKR on such patients. Other complications being DVT and compartment syndrome. Always use drains in such patients so they are not ending up in compartment syndrome. Risk of infections, as for any surgery, these do carry risk of superficial and deep infections, and plate irritation, which is also common with the hardware. So HTO is a very demanding procedure, and the number of surgeons doing, they are increasing the this interest that is generating by these type of CMEs, just to enlighten the future young surgeons. More and more people in future will come up, but these procedures, they do come up with complications, and so you have to be very mindful not to over or under correct, and you should always look for slope modification, because HTO is a procedure to restore or to maintain the tibial slope and not to increase the slope. And always look for your patellar changes. You should be mindful of the patellofemoral kinematics, and do a good superficial MCL release so that you're not landing your patient in a paradoxical medial joint line overload. Thank you.
Good evening, everyone. I am Dr. Pritpal. Today I'll talk about osteochondral autografts in chondral injuries. As we know that articular cartilage injury does not heal because there is poor vascularity, so there is no healing potential in it. Also, the adult chondrocytes do not migrate and fill the defect nearby. Once there is chondral injury, it begins in unstoppable cascade of events, both chemical and then mechanical, leading to degenerative joint disease. It may also progress to end-stage arthritis. Patient will come with pain, catching, clicking, locking, instability, effusion. How common it is? A retrospective review of more than 30,000 knee arthroscopies revealed that there were 41% outer bridge grade 3 chondral injuries, 19% grade 4 chondral injuries. Also, out of acute hemarthrosis, 5 to 10% have full thickness chondral injuries. Our goal is to restore smooth articular cartilage surface, relieve the patient of symptoms, and improve function. Also, we want to match the biomechanical and biochemical properties of normal hyaline cartilage, prevent or slow down progression of focal chondral injuries to end-stage arthritis. Early treatment options were debridement to remove mechanical symptoms. Then came marrow stimulation techniques like microfractures, but both of them yield fibrocartilaginous repair, which is not that durable. Other cell-based repair options are bone marrow stimulation techniques, perichondral and periosteal grafts, osteochondral autograft, osteochondral allografts, autologous cartilage implantation, and tissue engineering like hyalografts. Treatment options are divided into 3 categories: palliative, reparative, and restorative. Palliative, we have debridement lavage, microfracture, and autologous chondrocyte implantation come under reparative, and osteochondral grafting come under restorative. How to decide? If the lesion is less than 2 centimeters square, we can do osteochondral autografts, marrow stimulation, debridement lavage, also ACI and osteochondral autografts. Lesion more than 2 centimeters square with low demand patient, osteochondral grafting, marrow stimulation. In high demand patients, osteochondral allografts are a good option. Osteochondral autograft may be performed arthroscopically or open. It fills the defect with native cartilage. But as we know, there is limited, it can only be used in a smaller defects. And it may also lead to donor side morbidity sometime. It does not integrate with the surrounding cartilage, and it may sometimes disturb the congruity of the joint. Here we see a cartilage defect on the medial femoral condyle. We use the dilator to measure and plan the recipient socket. The recipient socket was drilled and dilated with the dilator. The osteochondral autograft was harvested from the non-weight bearing area, mostly the superolateral aspect of the trochlea. The graft was inserted into the recipient socket by gentle tapping. This was the final graft after the grafting was done. This was the portals used. This is a video of an open technique. The defect was marked. The recipient socket was drilled and dilated. The osteochondral graft was harvested from the superolateral aspect of the trochlea and inserted into the recipient socket. This is a case of a 17-year-old female. She came to us with pain on weight bearing, no history of trauma. She underwent a loose body removal and microfracture 8 months back, but still pain persisted. MRI shows osteochondral lesion of the lateral aspect of the medial femoral condyle. Arthroscopic OATS was done. This is the post-op protocol which I follow. Non-weight bearing for 6 weeks with knee brace, quadriceps strengthening and FFD correction from day 1. 0 to 30 degree flexion in the first 2 weeks. After that, 30 to 90 degree. And after 4 weeks, 90 to full flexion can be given. Partial weight bearing from 6 weeks, full weight bearing at 8 to 10 weeks. This is the patient at post-op 4 months. She is very comfortable squatting and walking. She rejoined her school at around 2.5 months. This is the system I used. It's from Smith & Nephew. Thank you, everyone.
Now will be the complicated and difficult cases of high tibial osteotomy. Case discussion by Dr. Rohan.
Thank you, Varun, and IAS1 and IAS JOPP. The disclosure that I want to give before starting is that the most important disclosure, I'm not an arthroscopist, so Varun just wanted me here. I think I just come here to fill some spaces. So, but the things are that every time it's not about arthroscopy, you may get some deformities and how do you have to tackle them. So we've got a very good esteemed panel with us, some seniors, and Varun is here, ID is here. I think we're going to have some good discussion on this case. I'm just going to present a single thing. So it's a case of a 30-year-old male with a 7-year-old proximal tibia fracture and a shaft tibia fracture. It's a condyle and plus shaft fracture. And it's been neglected for a few days and later it was casted. So typically what are the indications for doing an HTO is basics. We have to start from the basics. It's a medial joint pain is there, severe lateral thrust is there. It's a progressive deformity, and so what next? So these are the x-rays. So ID, if I'm not breaking up the momentum. So this is the x-ray. 30-year-old male, 7-year-old trauma. It was casted outside. So for the disclosure, it has a proximal tibia fracture and it had a shaft fracture. So how to proceed now? It's a post-traumatic situation. So let's discuss a single case because that's, I think, that is all we'll have time for. Yeah. So these are, I have the scanograms. I could not put it. I was traveling from somewhere else, from Amritsar only. So I just put up the case while coming. So yeah, so scanogram done. So that shows a deformity. There is a, yeah, so the very good point. So ID has highlighted a very good point, only on tibia. So how do you know whether the deformity is in tibia or femur? That is a very important thing. So I think clinical examination is very important. If you get a patient who's got a genu varum or who has got a medial OA or whatever you are posting him for, like an HTO kind of a thing, first you have to determine whether the deformity is in the femur or the tibia. So simple test is flex the knee. So once you flex the knee, if the deformity disappears, you know, so it means the deformity is in the distal femur. So these are the simple basics we have to understand. We all have the fancy procedures and everything, but if you flex the knee and the deformity disappears, it means it's there upstairs, not down below. The second thing, so bone on bone, medial pain, but post-traumatic, 2 level, a proximal tibia fracture and a shaft tibia. So is it the correct indication for a tibial osteotomy? ID? So we believe that we have a scanogram and it has got a problem. Definitely I could not put it up. So this is the best I could do. The pre-op x-ray is a stress view. Then it's a scanogram, it's a partial scanogram. I could not load it in time before coming. And a full lateral view in full extension. That is also, I think, important to determine whether you want to do an osteotomy. Any take of anything else to be done? Dr. Ajay, sir? Hello, sir. So for an HTO, sir, what are the views you would want to do, which should be there? I mean, of course, there is a scanogram. Yes, absolutely, is a must. A stress view. I think when you take a stress view, you come to know that the opening is there. And if there is an opening, it means it's partially correctable. You may be able to get a good correction even in a post-traumatic situation. So what point I was coming at was, in a post-traumatic situation, normally it is a contraindication. Don't do it in a post-traumatic fixed kind of a thing. Yes. Can you give a mic to sir? Mic.
is a medial pain. So, and definitely I would like to see a MRI before it and a CT scan. So this needs a thorough evaluation. We just can't stick onto the X-rays and offer some treatment to this patient.
So do you always do an MRI? I mean, because you're going to scope them, or you think that it is because of the...
If I'm going to scope them, I'll always do a MRI.
Of course, yes.
Always?
Yeah.
Always mean always. So that will help me in determining what kind of surgery I am planning into and what structures I am looking at.
Exactly. Sir, you want to add something?
There is some amount of patella alta also. So that's what we are thinking that. So this is a posteromedial maybe depressed fracture, right?
Yeah, but patella alta is not so. Yeah, there is, but I'm not very sure if it is that severe. Maybe the limb is extended in the because of full extension lateral. We put a slim kind of a film, I think probably. So probably looks okay over here. But yes, definitely a good point. A 2-level fracture. What it needs to be done? A correction. What kind of a correction? So stress views are important. Scanogram, as IDS said, lateral view in full extension. And a pre-op CT. Whatever films I could gather, I've just put them up over here. Because I didn't want to make any didactic theoretical lectures today. So this is the... So it had a posteromedial component to it. You can see a depression over there. But now the problem is a 7-year-old. So patient has medial joint line pain. So it needs the elevation and correction. Right? So 2-level fracture, does your plan change? Do you go in with a thought that if you're going to do an elevation, do a plating and everything, do correction for the intra-articular part? What about the extra-articular part down below at the shaft? Do you additionally keep anything ready if you get a case like that? I'm sure we get it rarely, you get all these cases a lot. So that's why I'm asking you. Any additional thing you would like to do? Nothing. Yes, sir, Lal sir. Tibial looks fine. Good. So what I want to, so before the correction, bone on bone was this. So yes, of course, there is a component to it. There was lateral thrust when he was walking. There was a medial joint line pain, which for me, as a basic general orthopod, is important. If the patient is having this, this is what is bone on bone, and this is what is I'm expecting post-correction. So now the problem is, normally they say in post-traumatic situation, just lift the medial condyle up and probably you will be able to get a good correction. But the only thing is that sometimes you end up changing the slope, you end up changing the rotation, so you may not be able to get just an elevation of the posteromedial condyle, because after 7 years to do a posteromedial condyle elevation, it's not an easy thing. So it's a difficult thing. Yes, ID?
Transcondylar valgus
yes,
kind of osteotomy.
you can do that.
To create a basically Teguchi type of 3 fracture and bone graft it and then do an kind of correction.
First the TC and then?
TCVO.
Yeah, TCVO.
So you have to create a vertical limb.
Yeah.
You have to create a vertical limb.
Yeah.
Basically an intra-articular osteotomy to correct it.
Okay.
Not a standard high tibial osteotomy.
Okay. All right. Point taken. So anyhow, I planned this for a biplanar HTO in my hands because this is what I routinely do in such a case scenario. When I've got about 3 or 4 patients, I did that. So it's obviously a oblique biplanar kind of an osteotomy, and these are the simple steps. You put your wires, you mark your biplane, and then you go in and stack it with your osteotome and try to do it. And this is just important structures, which I think Tarun has already said that you don't want to be too aggressive, you need to be gentle, and you can mark your biplane like this. So in this case, only the elevation was not helpful, so I had to open up the wedge a bit to correct this and to get it opened up like this. So probably it was long standing, so in my armamentarium, this was the best I could do. And we opened up, fixed it with a laminar spreader, how much ever so correction I needed, and we proceeded. So one thing as a normal orthopedic surgeon, which I feel, who's just doing it for deformity correction purposes, who's doing a lot of plastic and complex trauma, I think for me, I'm a little old school. I'll always still do the cautery test, and I would like to, it has got a lot of inter-observer and intra-observer discrepancies, everything. But whenever I've done a DFO for a valgoid knee, whenever I've done a HTO for a varus knee, whenever I've done a MPFLT2, anything, as a general orthopod who does these kind of deformity corrections, for me it gives me a basic idea that whether I am very medial, whether I'm neutral, whether I'm very lateral. It cannot be quantified in MMs, but I think this is the gold standard which has been going on, and we teach, and we've never had to really, repent, basically. So why we have to do this? You want to see the Fujisawa point. So whenever you get a patient, I'll just take 2 minutes if there are today, I think this is the last talk. So you want, I just want to discuss the case, that's why. Yeah, so we want to just see the cautery lead, so it should go to the lateral tibial spine. The Fujisawa point for the basic people who want to do the HTO should be known. Out of the whole width of the proximal tibia, it is at the 62 or 63% of the margin at the lateral side. If your osteotomy correction, your cautery lead is going that laterally on the lateral tibial spine, it means you have done a good correction. So you do not need artificial intelligence, you do not need a lot of measurements on MMs. And generally what we say that 1 mm of correction is equal to 1 degree of correction does not hold true now. I think that is out of the picture. So you can see that. So after we have corrected this, we fixation with the plate and we see a correct limb. So only a couple of things why I was hampering on the fact that this is a 2-level kind of a fracture, because sometimes you have to understand that these kind of deformities, if your wedge of the osteotomy becomes more than 15 mm, then you cannot go in with only single correction. You have to go at a double correction. So whether you need a double correction later on or not, that you have to see on table, because if you open it up more than 15 mm, then the structural biomechanical failure of your construct will occur because you've opened the wedge so much. So in a case of genu varum or genu valgum or a double level fracture or a triple level fracture, it means that's a multi-apical deformity, whether the deformity is in femur also and tibia also. So you have to be ready with 2-level osteotomy sometimes. You have to be ready with a distal femoral osteotomy, a proximal tibial osteotomy for multi-apical deformities. If the deformities are in both the planes, in both the bones, or it's a big varum of more than 20 degrees, 30 degrees, or it's a big valgum of 20 degrees, 30 degrees, and it's not correctable. And third thing, if your wedge becomes more than 15 mm, measure your wedge. If you do single level osteotomy for a more than 15 mm wedge, your structural biomechanical failure of the implant will occur even if the patient is slim, because it cannot accommodate so much of surface healing. So anyhow, this is the correction we got. We forget about the diaphysis. The TBI is okay, as sir said. And we got a good correction in this patient. His thrust went away. I'll just quickly go with the small bits of videos. So this is what is pathogonomic for me. So if you see the fibular head coming out like this, it means it needs a correction. This is a basic clinical examination when you see. This is when we started the knee. It has got a bend. The fibular head pops out. And I was talking about the clinical examination. Now I like to open these knees up in flexion. One assistant is holding. You don't need too many people. So as I'm opening the knee up, so you see that the knee is in flexion, and still it looks to be a lot bent. So if it's a bent knee in flexion, it means the deformity is in the tibia itself. It's not in the femur. But if pre-posting the patient for surgery, if you flex the knee and the deformity disappears, then do not touch that patient for an HTO. I have had these complications myself. I have had these from others, and I think it's devastating for the patient. You will push the patient toward misalignment syndrome. The next thing, sharp dissection to the, to the bone to elevate the periosteum so that you can have the anterior limb of the oblique plane osteotomy. Take out everything, be gentle. Take out everything from the bone. Have a good skin, big periosteal flap. That's very important. Take down everything with a sharp dissection. And the next point is just mark with the wires. After you have marked with the wires in the correct position, just mark the osteotomy. My wires are there. Osteotomy has been marked. And now after marking this in this fashion, I just directly, I've marked the oblique plane osteotomy also, the anterior limb, the medial and the posterior limb. I just directly take the saw and I start doing what I had to do. So this is for the wire insertion. I'm not going to play everything because most of the real life things have been shown over here today. So this is the osteotomy which has been marked, the oblique biplanar osteotomy. And we just carry on with our medial opening of the osteotomy site. Just take a small, nice nip, sharp with a saw. Don't go all the way. Keep it controlled. Keep it not so aggressive like in a routine scenario which we'll do as plastic surgeons. But just keep it over there. And even when you're doing the anterior bit, use a slow kind of a controlled motion and use a smaller blade and keep a kind of a Hohmann retractor or something over there. And don't go all the way. Don't disrupt that. Don't make it a TTO basically. So once we have done that, we'll just put in the osteotome. Try to see how much my osteotome is mobile. Never do it forcibly. And then I will put my laminar spreader in. and I'll keep it very, very posteriorly or at the midpoint of the medial and the, midpoint of the medial and the posterior aspect, so that I have a lot of place anteriorly on the bone to apply the plate. That is very important. And just once you fix it with the laminar spreader, just keep it. I think there was a discussion going on in the previous session that somebody has to hold it with a valgus thrust. I don't think that one assistant should keep on doing the valgus thrust because you're going to over valgusize. Just use your laminar spreader and keep it fixed over there. And now is the time, after finishing this, after we have opened the wedge, we do the cautery test. We do it. Definitely it has some intra-observer reliability issues, but let's do it. That's important. After this is done, we check it from the center of the femoral head. And this is a time, nobody is needed, just your laminar spreader is there, it is posteriorly, and just put your plate anteriorly in a simple fashion. It's a routine tomofix. It is a fixation of the screws. So we started from here with some lateral laxity on the thrust. It is completely aligned well. Post-operatively, I'm able to correct it. And I take ID's word. I've done 2 cases after this where I have done TCVO, probably in the next meetings if the Indian Arthroscopy Society wants to call. So that is why. So 3 months follow-up of the patient. The posterior hinge is intact. The anterior hinge is intact. The lateral hinge is intact. Hinge intactment is very important. And no substitutes, no grafts, nothing. So what you see is even in a big wedge of about 10 mm, this is the cancellous bone which fills up, it heals up itself. And it's a good sclerotic margin of the osteotomy site. These 2 lines are very important, and this is the cancellous healing. And only where the wedge is there is which is not filled up. Otherwise, everything is filled up on its own. So no grafts, no substitutes. I think anything new is there, ID will add to it. Is a 2 years follow-up today morning of this patient from Philippines. I just called him and asked for his follow-up. So I think he did well. So it's always a learning curve, I think. So, but his thrust, his pain, everything is gone. He's back to his normal life. Thank you so much.
Hello everybody, my talk will be on genu-valgum deformity with prime focus on X-linked dominant hypophosphatemic rickets. So we basically do treatment of genu-valgum by medial closed wedge osteotomy. So first, before that, we need to understand a little bit about parathyroid hormone pathway. So I usually remember that it has phosphate threshing hormone. So whenever there is decrease in calcium and decrease in magnesium, it stimulates chief cell of parathyroid gland. So the eventual result, it causes decrease in serum phosphate and increase in serum calcium. So only about these laboratory findings, you have to know the difference between nutritional rickets and hypophosphatemic rickets. In case of hypophosphatemic rickets, calcium, parathyroid hormone, and vitamin D remains normal. Whereas in case of nutritional rickets, there is decrease in calcium, increase in parathyroid hormone, and decrease in vitamin D. There is decrease in serum phosphate in both the cases and increase in alkaline phosphatase. It is important because in X-linked dominant as well as nutritional rickets, first medical management is important so that the quality of bone improves, followed by surgical management. So there was few cases of rickets which was resistant to normal therapeutic dose of vitamin D. That was first described in 1927. So study of these refractory cases reveal low serum phosphate concentration as a common factor. So X-linked dominant hypophosphatemic rickets is the most common genetic disorder. The prevalence is 1 in 20,000. It's an X-linked dominant disorder in 80% cases, in 20% is autosomal dominant as well. So clinical presentation is the same: frontal bossing, curved humerus. Bowing may be lateral, medial, or anterior. Lateral most common. Apart from that, there is concomitant there is short stature in case of X-linked dominant hypophosphatemic rickets. Radiological feature is the same: cupping and fraying of metaphases, and thickening of the epiphyseal face and demineralization of the shaft. So how will you differentiate X-linked dominant?
So if serum phosphate is low, blood pH is normal, and then you will do serum PTH and calcium. If it's high or low, it's vitamin D dependent rickets, and if PTH is and calcium is normal, if most probably hypophosphatemic rickets. In case of, since these rickets doesn't respond to vitamin D, so we usually give 1 to 3 grams of elemental phosphorus divided into 4 to 5 doses, along with calcitriol, 30 to 70 ng per kg per day. The most common complication is kidney stone, so we have to give hydrochlorothiazide amiloride with it. So, through this paper, we aim to show that medial closed wedge osteotomy of distal femur is a good technique in the treatment of the genovalgum deformity. So this is the first case. It is a 14-year-old male child with short stature that present to us with gross deformity of bilateral lower limbs. Deformity is present since early childhood. Tibiofemoral angle is 50 degree on the bilateral side. Intermalleolar distance is 48 centimeter. This case presented to us in March 2023. Laboratory investigation showed normal parathyroid, normal vitamin D, high alkaline phosphatase, and low phosphorus. Based on the clinical finding and laboratory investigation, it is a case of X-linked dominant hypophosphatemic rickets. This is the deformity, as you can see. The patient, there are macular rash on the face that is due to increase in fibroblast growth factor 23. This is how the case actually presented to us. You can see it's an hand to knee deformity with severe tibiofemoral angle of 45 degrees on bilateral side. For the first 1.5 years, we just focused on the medical management. We gave him 2 grams of elemental phosphorus divided into 4 doses and calcitriol divided into 2 doses for a period of 1 to 1.5 years. There was significant improvement in the deformity with medical management only. Then we did medial bony wedge distal femoral osteotomy of the femur and upper tibial bony wedge on the right side, accompanied with fibular osteotomy. It was followed by above knee POP cast on the right side. Then we did the distal femoral osteotomy on the left side after 1 year. So this is the same case after 1.5 years of medical management. The deformity has slightly improved. Then the same case after correction on the right side. This is the same case after correction on the right side. This is an X-ray after correction on the left side. Now this case actually came to our OPD just 2 days back. And this is the final outcome after correction on the bilateral side. So you can see the deformity has now corrected. So for the first 1.5 years, we've only focused on the medical management. Then we operated on the right side. And 1 year after that, we operated on the left side. So this is like the photo of in May 26. The patient came to us first on March 23. So it's 3 years now. So this is the second case. Again, a case of X-linked dominant hypophosphatemic rickets. The deformity is 45 degrees on the right side and 35 degrees on the left side. You can see. Again, we followed the first medical management first. Elemental phosphorus divided into 4 doses and calcitriol. Then we did medial closed wedge distal femoral osteotomy on the bilateral side, followed by 2 K-wire fixation. So this is a clinical image. This is clinical image after correction on the right side. Now this is a clinical video after correction. Now this is the clinical image after correction on bilateral side. We just used 2 K-wires, that's it. This is the third case, 10-year-old male child, nutritional rickets, genovalgum bilateral side. Right side 35 degree, left side 30 degree. We did a knee flexion test as demonstrated by Dr. Rohan as well, Dr. Rohan sir as well. The deformity disappeared on knee flexion. There is only femoral component. Then we did medial closed wedge osteotomy on the distal femur on the right side, followed by above knee cast for 6 weeks. This was followed after 3 weeks by medial closed wedge osteotomy of the distal femur on the left side. This is how the same case presented to us. There is a gross deformity here as well. This is after correction on the right side. The good thing about this one, we didn't even use a K-wire also. We just did a medial closed wedge osteotomy followed by above knee cast for 6 weeks. So this is correction on the left side. Now this is the picture after correction on bilateral side, clinical video of the same patient after correction on the bilateral side. This is the fourth case, 11-year-old male child with bilateral genu-valgus with hypophosphatemic rickets, 35° on the right side, 15° on the left side, knee flexion set, the deformity disappeared. When knee is flexed, intermalleolar distance 26°. We did medial closed wedge osteotomy of the distal femur on the right side. That was followed by 2 K-wires. This one is the deformity, how he presented to us. This is the clinical video at the time of presentation. Now this is the post-op correction clinical image. Now this is again a 13-year-old male child with genu-valgus, supracondylar medial closed wedge osteotomy done on bilateral side. This is how he presented to us. Now this is 4-year post-op clinical picture and video. Now this is the 6th case with bilateral genu-valgus. We just did a medial closed wedge osteotomy on the right side in this one. Now this is the 7th case. This is 7th case, a 15-year-old female with bilateral genu-valgus deformity. We did supracondylar medial closed wedge femoral osteotomy on the bilateral side, followed by K-wire fixation. This is how she presented to us. Now this is the post-op clinical x-rays. Now in the discussion section, Aguility et al. First described the supracondylar V osteotomy in 1987 in a study involving 14 patients, that is aged 15 to 70 years, in which he used no internal fixation device. In the third case also we used no internal fixation device. Rustagi et al. Evaluated the outcome of supracondylar simple wedgeless metaphyseal distal femoral osteotomy and POP cast immobilization with excellent result. Now the most important is the fourth one. Our TA et al. Did a study comparing K-wire fixation and using locking plates for correcting genu-valgus deformity and found out that K-wire can yield satisfactory result as compared to using locking plates. So our conclusion is medial closed wedge distal femoral osteotomy plus 2 K-wire fixation is a very reliable method to treat genu-valgus deformity. The method is safe, reliable, and cost effective in a low resource setting. Medical management should be must. Like in case of X-linked dominant hypophosphatemic rickets, you need to give him medicine for 1.5 years, calcitriol and elemental phosphorus. Only then the quality of bone will be improved and it will be fit for surgery, so that the quality of bone should improve. Thanks a lot. Thank you. Thank you.
So with this, we end our conference. So there is a message from the President of Indian Arthroscopy Society, Dr. Sundarajan, from Ganga Hospital, Coimbatore, and Dr. Rajiv Raman from Kolkata. So he will be, they both will be addressing all of us. Just 5 minutes, you bear with us, and then we are good to go for the workshop. Thank you.
Greetings from Indian Arthroscopy Society, and please accept my apologies for not being in person due to multiple programs across the India. And I want to proudly say that Indian Arthroscopy Society has got almost 5,000 members. That means 5,000 sports surgeons across India, one of the largest society around the world. So we can be proud of that. And my presental theme is joint preservation, that is to repair, reconstruct, and restore the joint. We don't treat as a ACL surgery alone. or meniscal surgery alone. We treat the patient at the same time we treat as a joint, and so that we can reconstruct the joint to delay the arthritis or delay or postpone the replacement in the future. I'm sure that these kind of programs will help us to understand all about ligaments, cartilage, as well as the alignment, so that you can restore the joint for this patient to get back to their normal life. And I take this opportunity to thank organizers for arranging this program and esteemed faculty who traveled across the India to teach you and share you and to help you to get upgrade your knowledge in arthroscopy. It is a great opportunity for all of you at the same time to become a member of Indian Arthroscopy Society, so that you can avail a lot of fellowships. You can get a lot of large knowledge from our website, which constitutes hundreds of webinars, surgical techniques. So please become a member of Indian Arthroscopy Society. Once again, I congratulate all the organizers of this course. At the same time, I wish best wishes for all of you. Thank you very much.
Dear friends from Indian Arthroscopy Society, I would like to congratulate Dr. Varun for conducting successful Ias joint preservation program in Jalandhar. Best wishes for your joint preservation program. Dear Varun, membership drive, and request all of you to attend the annual conference of Indian Arthroscopy in Kolkata this year on 8th, 9th and 10th October. Best wishes from Jalandhar. Thank you so much.
So that ends our session, and we'll proceed for the workshop, and high tea is also there. So all of you can take tea and start with the ACL and meniscus workshop first, and then with H2O workshop we have 1 hour with us. So clear all your doubts that how to do, and any trick and tips from all your table instructors. Thank you.
क्या फोल्डर तो बनाया है बट डाला नहीं है तरीके से।
ਇੱਥੇ ਕੋਈ ਲਾ ਦੇ ਲਾਈਵ ਹੋਟਲ ਹੈ ਪਾਰਕ ਕੋਈ ਪ੍ਰੋਪਰਟੀ ਬੜੀ ਚੰਗੀ ਉਹਨਾਂ ਦੀ ਜ਼ਿਆਦਾ ਪਹਿਲਾਂ ਡਾਊਟੀ ਕੋਲ ਜ਼ਿਆਦਾ ਧਿਆਨ ਨਹੀਂ ਹੋਣਾ ਚੰਗੀ ਪਰ ਜ਼ਿਆਦਾ ਸੁਣਨੀ ਉਹ ਸੋਚਦੇ ਉਹਨਾਂ ਦਾ ਥੋੜਾ ਬਿਜ਼ਨਸ ਵਾਲਾ ਜ਼ਿਆਦਾ ਕਿਉਂਕਿ ਪ੍ਰੋਪਰਟੀ ਬੜੀ ਸੰਭਾਲਣਾ ਵੀ ਹੈ नहीं चल रहा लाइव चल रहा है बंद कर नहीं यहाँ तो ठीक है लाइव चल रहे हैं लाइव वाले बंद कर दो यहाँ